And for this first session, I couldn't think of a better first speaker than someone who we're welcoming home to Southern California. Dr. Marla Dubinsky is currently the professor of medicine and chief of digestive and liver disease at Mount Sinai in New York. And she is probably better known to all of us, though, for her 16 years at Cedars-Sinai Medical Center. She is really an international expert in pediatric inflammatory bowel disease, and she really takes it from preconception to adulthood. An incredible CV, an incredible person, and we've been trying to get her here for a few years. We're so lucky to have her here today. Marla, welcome.
Thank you so much. I remember many years spending at this conference, so thank you again for inviting me back. It's a pleasure. So excited to sort of share with you where we are from IBD and from DDW. This morning you heard, I know in the product theater around guselkumab, and you're going to hear a lot more about guselkumab since it really was the star of actually DDW and IBD. So a lot of exciting stuff I'm going to show you across multiple targets and some of the new oral medications that may be in our clinic even perhaps within the next year. So lots of really exciting stuff. So I'm going to start with first about risankizumab. This was a study where they integrated intestinal ultrasound. So I don't know how many of you are up on this growing, immense, enormous integration into our clinics, which is bedside intestinal ultrasound that we're bringing into the IBD centers where gastroenterologists are the ones actually performing it and are trained by a certification. And so what this study is showing is that as we advance our targets in the world of IBD, where are we focused? We're thinking that in Crohn's disease in particular, endoscopy is probably not the perfect target. And what we need to think about is transmural. And we have to go beyond the mucosa in order to actually change the natural history of inflammatory bowel disease, particularly Crohn's. And what this study did is it actually wanted to look at the success and the efficacy of IL-23, particularly risankizumab, in terms of transmural response and also remission. But the primary outcome was whether or not we see a response in the bowel wall as early as 4 weeks after starting our therapies. And what they did show is about a third of our patients already start to have a thinning of the bowel wall. Just to let you know what transmural response means is whether or not the bowel wall thickness progresses towards normal, which is less than 3 millimeters. And so what this study actually showed is that our current drugs do move towards not just endoscopic changes that we see from the clinical trials. And if those of us do 12-week endoscopy, which I doubt many of us do, but in the trials, that is part of the primary endpoint. But this was just to say that if the target is going to change towards transmural, do our current drugs do that? Risankizumab tested and showed that there was some transmural response post-induction already, which is great. So it means that we may be moving towards a new target in the future. Now I'm going to talk about guselkumab. So this was really the first non-anti-TNF study to show in a phase 3 study called Fusion, which was looking at whether IL-23, particularly guselkumab, actually had any effect on perianal fistulas. Because as we know, outside of infliximab, there was never this. There were only post hoc analysis of existing studies like the upadacitinib studies where they looked retrospectively and said those Crohn's patients who had perianal disease at the beginning, did they have some improvement? And it looked like upadacitinib, and I'll show you some data on UPA and perianal as well, but it did look like in the controlled trial that there may be benefit of upadacitinib in TNF refractory patients. This was looking at whether or not in a phase 3 design, hopefully going for indication, obviously, whether or not guselkumab showed efficacy and safety. And bottom line is that it did. And actually what's really interesting, and the placebo is in the gray, and then the two blue bars. What was interesting, and some of you may experience it, I don't know what was discussed this morning, but that the dosing of guselkumab between 100 Q8 and 200 Q4, there's a lot of debate about whether you need 200 Q4, who are the patients that you really need that in, and we're hoping to assess that a little bit better. But more importantly, in this study, 100 Q8 did not do any different than 200 Q4. So from a dosing perspective, based on this, obviously we'll dig in, as we usually do, look at multi-refractory patients, whether there are certain findings post-induction that made us think that they would benefit from 200 Q4 over 100 Q8, like what we do with Galaxy or like what we do with Quasar, for example, in the phase 3 pivotal trials. But at the end of the day, this was exciting to have yet another option. And many of us who have had patients who failed anti-TNF, maybe failing or intolerant to upadacitinib in clinic, many of us were already adding IL-23 to our practice already, particularly in these very refractory perinatal disease patients. So it was nice to see, outside of like just a clinical N of 1 or an N of 2 experiment in our clinics, to see randomized data. And also, not surprisingly to anyone, the adverse event profile was no different than in those individuals who got guselkumab either in your practice or in the phase 3 registration trials. So this was the first, phase 3 study with IL-23, particularly GUS. So this is very exciting for our patients. Another story about GUS was the idea that it actually may have some impact on extraintestinal manifestations. As you may or may not know, about 50% of our patients over the first decade after diagnosis report some extraintestinal manifestation. There's emerging evidence that more patients of ours actually have more like sacroiliitis than we actually think at diagnosis, that they did, they looked at diagnostic cross-sectional imaging and found sacroiliitis in not an insignificant amount of patients who are completely asymptomatic. And so as the studies emerge and as a lot of our industry partners are trying to find their way in terms of the narrative about, as new therapies come to market, therapies that are claiming, for example, that they will have an indication in, for example, rheumatoid arthritis or in psoriatic arthritis or ankylosing spondylitis, when you start to have drugs that expand outside of just the gut and are approved for other indications, a lot of the drugs are looking at retrospectively, going back to our studies and saying, who reported any extraintestinal manifestation, joint, eyes, skin, and did it actually, or mouth sores, for example, aphthous ulcers, and did it actually get better? And what these GUS studies, actually, the bottom line takeaway is that patients with EIMs, particularly peripheral arthritis, because just as a reminder, the IL-23s are not approved for axial SPON. TNF and upadacitinib, for example, yes, and maybe our future targets, TL1A, which I'll talk to you about this morning, both in a minute, and then in the state-of-the-art section thereafter, after Sandy talks, is that the idea that drugs are going to have to do better than just go after the gut. And there are a lot of EIMs that do not parallel gut activity. And so if you're going to have a play in the IBD market, really the goal is to get drugs that affect EIMs that are not dependent on you healing the mucosa. And sort of this was the concept of looking at this. And it also showed that maybe it actually prevented, meaning there was no new occurrences. And every pharma is now looking at EIMs as part of their portfolio. So you will see a lot of EIMs, especially, as I noted, because of the TL1 revolution that's going to happen over the next few years. So this was probably one of the highlights of the meeting for everybody. It was the first presentation of the DUET CD and UC study. What is DUET? It is combining golimumab, which is sub-Q anti-TNF, with guselkumab in one sort of co-antibody. So basically, think of them as co-formulated in one asset. And they looked at 3 different dosing of this combination versus GUS alone, versus golimumab alone, and versus placebo. And this was the design that they had discussed with the regulators. And this study was really, when I show you the data, which was in theory a negative study, I mean, no one walks away saying this was a positive study. How the study was really a framework for a phase 3 trial design. And how would we design the first combination study with the regulators on getting an approval, hopefully, of 2 drugs in one formulation. So although the study was negative, and this is the data, if you look at the key takeaways, and you can, happy, by the way, take as many photos as you want, but the key takeaways is that, and the main comparison was the high dose of the combination versus the monotherapies. And as just a reminder, golimumab is not approved for Crohn's disease, which is why they needed to do a monotherapy arm of golimumab. It's only approved for UC currently in the market. They're not going for an indication for Crohn's, don't worry. But the idea being that there needed to be a comparison across the monotherapies. And a few things to remember is that it, as I noted, in the overall population, it didn't hit its primary endpoint. However, it looks like, which is where I'm guessing the drug will be positioned in the future, is if you failed at least 2 advanced therapies, and you can imagine most of them had already failed an anti-TNF, whether it was adalimumab or infliximab. Those individuals came into this trial, and they probably failed ustekinumab or Veto and came into this trial. So just keep in the context of what this trial population was. And if you look at the graphs on the right, those where there was some significance was in the combination versus golimumab. But again, I don't think that shocks anybody. We all know that these 23s work very well in Crohn's disease. And there was some signal to look like there may be an advantage over GUS alone. A couple of things to remember. The IL-23s, particularly guselkumab, where it gets a little bit tricky is that when you have a great monotherapy, that sometimes you don't always see such a significant benefit of combining it with a TNF, especially if someone has failed a TNF. I mean, you can all imagine what your practice looks like and then think about going, wait, you failed like infliximab, good levels, you were a non-responder, I'm now going to give you golimumab, right? I mean, that's just not something you're practically doing, but maybe in combination with 23, that was the thesis, is that when we combine 2 of these therapies, we get incremental gain. So that was the Crohn's duet study. There will be, of course, a phase 3, and we will see how it's designed, and we'll know a little bit more about how the regulators are actually going to help us design combination studies in the future. In duet, you see, again, negative study framework for the future. Again, GUS performed really well in refractory patients, which made it as not much a huge difference in combination. And I think we can all agree that anti-TNF, at least sub-Q in our hands, does better in Crohn's than it does in UC. That's why our guidelines sort of say, you know, sub-Q TNF is the lowest effective of all the drugs we have for Crohn's, for ulcerative colitis. There's a reason for it. It's a dosing problem. We just can't get enough PK in individuals based on how it was dosed. So again, we're going to learn a lot, but I wanted to say that this was obviously, everybody was waiting for duet. We thought it would be at ECHO, and then it came at DDW, and there was a lot of nuances to try and uncover the data when the primary outcome is negative, to sort of see how would I design a phase 3 and what would my population look like if I want to bring this drug to market. And it will be in the multi-refractory patient population. It's not going to be in just one monotherapy failure, right? So it's an evolution in our landscape, but I can tell you that after the TL1As, which will come out in 28, 29, and 30, there will be 3 of them, depends on how quickly they all move, is that that'll probably be the last monotherapy trial you will see for IBD. Every single trial that is currently happening in the landscape right now is combination therapies, using TL1A as a baseline, using IL-23 as a baseline, using vedolizumab as a baseline. No one's using an anti-TNF in the combination except for duet. So that sort of gives you the landscape that the future is that we have reached a therapeutic ceiling because we use one therapy, assuming everybody, which is obviously false, as we know. And although I would say we have definitively changed the landscape in ulcerative colitis with, for example, our JAK inhibitors, I was telling Dawn that we haven't done a colectomy in like 10 months since we started using, UPA in the hospitalized patient, for example, in a TNF failure. But we are not seeing as much a dramatic change in ileocecal resection. So there is a huge need for better Crohn's management. There is no doubt. Also UC, but Crohn's is where we really are hitting the ceiling. This was another dual targeted that Andres Herrera put forth, and this is just the preliminary where they combine Veto plus TOFA. in patients with UC, and just looking at and then de-escalating them to veto only, take away the one that may have more safety hit and give them on something that is more, what we believe to be a safe monotherapy. And preliminary data, when you look at benchmarks of each of them alone, it looks like you're seeing improved efficacy. Anyone would be shocked on this. I mean, the JAK inhibitors in a UC patient is just, it's the queen. I mean, it really is. If you have a very sick UC patient, I was telling Don, if we were on a private island, what drug would you take to your island? It would be a JAK inhibitor. I mean, that's just how we know about the strength of, these JAKs. So again, there's a study sponsored by Takeda that is combining Veto plus UPA. So this was Veto plus TOFA. So you're kind of getting a sense about what the market and what IBD management is looking like in the future. We also did that where we combined IL-23 with upadacitinib. So we combined a JAK with IL-23, and that is a biologically very plausible combination. Why? Because when you become selective, JAK1, so UPA, TOFA is JAK1 and JAK3, UPA is JAK1. When you are selectively choosing JAK1, you sort of lose some impact on a couple of other pathways, which is called JAK2 and pathways that the JAKs go after. And as you become more selective, by going and getting a little bit lighter on the TYK2, JAK2, guess what pathway that is? IL-23. So the idea that you combine an IL-23, and we were seeing people who had, who were going to go to the OR, and that's who we use this combo in, by the way, in clinical practice. It's like, well, you're like going to have to go to the operating room. You're failing, our monotherapy, and we're going to just combine what we think to be the best two drugs on the market right now, a 23 and a JAK for Crohn's and for UC. And we saw a significant reduction, and we did a lot of ultrasound. We were able to show complete normalization of the bowel wall. So this combination is the future. There is no doubt about it. We are taking patients who, after a short period of time, are not achieving what they need to on monotherapy, and we're adding something to it. And we are seeing transformative efficacy. And that's why drug development is in the world of combination, bispecifics, and now there's even trispecifics where you're combining three things all in one molecule, going after three different targets, not three different injections, not three different pills. We're talking one formulation that goes after multiple targets. This was looking at perianal disease. I was mentioning upadacitinib has been looked at in the original Crohn's phase 3 trial, and there's been a number at every DDW. There's a lot of groups that are looking at upadacitinib. This was a real-world multi-center study, and if you look at the key takeaway, that really it was effective at achieving response and remission in both patients with anal ulcerations, very important because we have a lot of patients with horrific anal ulcerations with Crohn's disease where we're like, I don't know what to do with you, and perianal fistulas. So we are getting more and more comfortable with expanding our arsenal for perianal. But then I would tell you, everyone asked me about safety with JAK. And by the way, the safety by adding UPA to IL-23, there's no difference in safety. Remember, Veto, IL-23, these are platform drugs. There's no safety attached to them. So the safety you get is with a TNF or UPA, right? That's the safe, or TOFA if you're adding it. So you're not compounding the safety by adding two, just to give you that clarity. The safety signal is tied to the least safest between the two, if you want to think about it based on what we know about these drugs. And of course, not surprisingly, the number one side effect we see with JAKs, not death, not VTE, not all that crazy stuff you see on TV, but acne, which you don't see on TV. And your patients will tell you, what should I experience? So instead of the commercial, you're going to say, many people get acne. It's dose dependent. We can work around it. And that's what we see in every UPA study. Again, this study out of University of Michigan, a couple of multi-center sites, looked at comparing TOFA versus UPA because the group in University of Michigan first started looking at tofacitinib in acute severe hospitalized patient and then progressed to looking at UPA. And what they showed is there was no significant difference, good news for patients, so whatever one you want to use, no difference between tofacitinib and upadacitinib for acute severe UC in the hospital. A lot of folks, if you remember, are concerned around immunosuppression before surgery. Remember, the TNFs got a really bad rap, and then the Puccini study came in and said there's absolutely, you can give TNF the day before the operation. We are not seeing an increased risk of side effects using our meds. You don't have to stop them, or surgeons, please stop delaying surgery because you were worried that they got, an anti-TNF 10 minutes ago. This study was showing you that even JAK, because people are concerned as well, that what if we take a JAK exposed patient to the OR, there was no increase. If anything, they had actually a little bit of better surgical outcome with the UPA group, and I don't know why compared to TNF. But anyways, so just to reassure you that there was no increased side effect profile by using a JAK over a TNF. Fun, Trokinra, we call it ICO for short because who can pronounce that? ICO is very exciting, another J&J drug development pipeline, an oral IL-23 receptor. So this study is enrolling like gangbusters in phase 3, so expect it to be sort of in the news a lot over the next year or so. We have the phase 2 study, which was very positive, and this is looking at the week 28 data across different dosing. So there's placebo, 100, 200, 400, just looking at whether or not if you were exposed versus refractory, because some people believe that some drugs are a bit for milder patients versus more severe patients, and by giving it IV, I think that the JAK inhibitors sort of like blew that out of the water because, we don't think that an IV or systemic exposure needs to be by an IV or sub-Q to get like real efficacy. The JAKs do just fine. And some of the other small molecules, which I'll share with you in a minute, also do just fine. So this is exciting. So the phase 2 study was positive, and there's a phase 3, as I noted, and it will be the first study that is included kids down to the age of 12 in the study as an open label, single arm, no placebo, in parallel to the adult placebo control trial. So this is literally precedent setting as to how we can bring pediatric drugs to market sooner as well. And the last target I want to talk about is obefazimod. It's been in the news. They just presented a press release last week on their maintenance data, and this is a drug which is a microRNA. It's a regulator of cell behavior, and it normalizes certain cells that we're very familiar with, which is Th17, but it also reduces some macrophage recruitment. So it kind of has a dual role, but we're not 100% sure as to how it works. All we know is in ulcerative colitis, it worked. And it worked very well in very refractory patients. And when you look at the data, it led to meaningful clinical improvements in endo, histo, and both endo and histo, and it met all of its endpoints. And this was just the maintenance data was presented last week, as I noted in a press release. So this is only the induction data. It was a week 8 induction trial. And this is the next oral that is going to come to the market. And it may be available for naives as well as refractories. So we're going to wait to see what the FDA, how it positions it. But this is exciting because now that the maintenance data, we should have something maybe in 27 or early 28, the next oral that hopefully you don't have to fail advanced therapies to get to. And that's why I say it. And it looks very similar to the JAK inhibitors in the refractory patient population. So this is a very exciting new asset. And then that it also showed, just like all small molecules, it works quickly. So the benefit of the orals is that they work quite quickly, and they work quicker than our IVs while we're working up our induction. There's no doubt, because you're giving the full dose, at that time, and the half-life or the time to steady state is very quick. So this is the primary endpoint. I just wanted to let you know the first week 8 data that we presented at UEGW. So that would be the fall of 25 already. The data that was presented at DDW was the symptomatic response and remission, showing how quickly it works. Already at week 1, we started to see some response. So again, works with speed, may not have to fail other advanced. So this is really another exciting asset that will come to the market, fingers crossed, hopefully shortly. So that is what was presented at DDW when it comes to all the amazing therapeutics. Now we're going to have Sandra come up and talk about the non-therapeutic stuff that went on at DDW, and then I'll come back and give you a state of the art on IBD. Okay.
Marla's very efficient. She not only gives an amazing talk, but she did my job too. But I'll just reiterate, we want to welcome Sandra Park here. She's the GI Fellowship Program Director at UCI, was IBD trained at UCSD, and did her fellowship at Yale. So we're in good hands for the second part of IBD. Sandra.
Thank you so much. Thank you so much for inviting me. I'd like to thank the course directors for inviting me, and Dr. Dubinsky for your help with the slides. Okay, here are my disclosures. So in this study, Prugin and colleagues studied postoperative recurrence of Crohn's disease after ileocecal resection. So currently our guidelines recommend doing a colonoscopy 6 to 12 months after an ileocecal resection, but non-invasive cost-effective tools such as intestinal ultrasound and fecal calprotectin can reduce this burden on patients to get procedures done. In this international prospective observational study across 7 IBD centers, patients who were post-ileocecal resection for Crohn's disease were followed and then underwent intestinal ultrasound and fecal calprotectin measurement at the 3-month mark, and then they had a colonoscopy performed at 6 months. Endoscopic recurrence was defined as Rutgers I2B, and of the 135 total patients, 45% of these patients have previously undergone ileocecal resection, 40% were biologic naive, and 12% were smokers. At 6 months, endoscopic recurrence was observed in 44%, and both bowel wall thickness and fecal calprotectin were significantly higher at month 3 in these patients that ended up having a recurrence at 6 months compared to those without the recurrence. And bowel wall thickness of greater than or equal to 2 millimeters, as well as fecal calprotectin greater than or equal to 192 at month 3 were independently associated with endoscopic recurrence, with an odds ratio of 6.6 for a bowel wall thickness alone and an odds ratio of 3.5 with an elevated fecal calprotectin. Combined, the odds ratio was 11.8 if you accounted for both fecal calprotectin elevation as well as bowel wall thickness. And so therefore, this study presented at DW supports a paradigm shift for using a non-invasive postoperative monitoring strategy for patients. Next abstract, as we know, active IBD during pregnancy is associated with an increase in adverse outcomes. This study was a multi-center retrospective cohort study across 16 hospitals, which included pregnant women with active IBD. And the outcomes assessed were, how did you do with regards to your IBD? Did you have an adverse outcome requiring hospitalization, surgery during pregnancy, or adverse pregnancy-related outcomes? What happened to the baby when they were born? Small for gestational age? Was there fetal growth restriction, low birth weight, preterm birth? 389 pregnancies were studied, and adverse IBD-related outcomes occurred in 25% of women, and adverse pregnancy outcomes occurred in 33%. A dedicated multidisciplinary IBD antenatal care clinic was found to be protective and associated with a lower risk of adverse IBD and adverse pregnancy outcomes. You can see on the left forest plot, on the left side, that variables such as corticosteroid use and severe disease led to higher relative risk of adverse IBD outcomes, while management in the joint IBD antenatal clinic was protective against these adverse outcomes. On the right, you can see on the forest plot on the right that smoking as well as corticosteroids increase the risk of adverse pregnancy outcomes, while management through this joint IBD antenatal clinic was protective. And so identification of these patients who have high risk may help with enhanced monitoring and improved outcomes for pregnant women with IBD. This study was a meta-analysis evaluating the burden of cervical dysplasia and cervical cancer among IBD patients across disease subtypes, as well as immunosuppressive therapies. As we know, patients with IBD, due to their immunosuppression, they face a higher vulnerability because of their reduced ability to be able to clear out the HPV virus. And so patients with IBD may face a higher vulnerability due to this. 33 studies were included in this analysis, and it included 483,000 patients with IBD and 3.7 million controls. The pooled prevalence of cervical dysplasia and cervical cancer in IBD patients were 121 and 2.5 per 1,000 cases, respectively. On the right, on the top, you'll see cervical dysplasia. And then on the bottom, you'll see cervical cancer. Patients with IBD had significantly higher odds of cervical dysplasia with an odds ratio of 2.34, and cervical cancer with an odds ratio of 1.56 compared to controls. There was substantially higher dysplasia prevalence among patients treated with immunomodulators compared with biologics, and that was 57.5 versus 22.4 per 1,000 cases. And cervical cancer prevalence followed the same pattern, measuring at 14.1 among users of immunomodulators versus 1.5 per 1,000 cases among those on biologic therapy. So patients with IBD on immunomodulators have an increased burden of cervical dysplasia, and this reinforces that need to make sure that we're routinely screening our patients and improving vaccination rates as well. What we know that estrogen-based contraceptives and the inflammatory burden of IBD increases venous thromboembolism risk. The authors in this study used a health insurance claims database to identify women with IBD aged 14 to 44 to estimate the age-stratified risk of venous thromboembolism among those initiating estrogen-based therapy versus a non-estrogen-based oral contraceptive therapy. Among the 6,162 patients who initiated therapy, 45% of them started an estrogen-based subtype. VTE incidence was similar between the estrogen as well as the non-estrogen groups. The cumulative incidence was 5.6 per 1,000 person years for the non-estrogen-based initiators versus 8.9 for the estrogen-based initiators. And IBD patients who were under the age of 35 on estrogen did not have an increased VTE risk compared to those on non-estrogen. And while the overall VTE risk did not significantly differ between these groups, there was actually a higher numeric number of VTE incidence in the group of patients aged 36 to 44 who were on estrogen-based therapies. And so the authors encourage shared decision-making when it comes to initiating patients on estrogen-based contraception due to their venous thromboembolism risk, especially over age 35. The Global Consensus Consortium suggests that women with IBD can continue treatment with IL-23 inhibitors during pregnancy, but safety data is limited. This study by Mahadevan and colleagues assessed pregnancy outcomes following maternal guselkumab exposure, and pregnancy data was reported to the Global Safety Database and analyzed for maternal exposure by indication, trimester, pregnancy outcomes. There were a total of 400 pregnancies with known outcomes that were analyzed, and 73% of the women were on guselkumab for psoriatic disease, 3.8% for Crohn's, and 2.5% for ulcerative colitis. On the bar graph on the right, you can see the rates of the pregnancy outcomes on the y-axis, and then the various groups on the x-axis. The red bar shows live births without any congenital anomaly. The black bar on the graph shows elective termination. Gray bar shows spontaneous abortion, and the red hatch bar, which is all the way on the right, shows live births with a congenital anomaly. In the US general population shown on the far right of this graph, 64.9% of women have a live birth without a congenital anomaly, while 17% have a spontaneous abortion, and 3% result in live births with the congenital anomaly. And that's just general US population. You can now compare on the graphs on the left that for all cases in women with guselkumab exposure, the numbers are comparable to the US general population. And so these findings do suggest no major adverse impacts of guselkumab on pregnancy outcomes, but of course should be interpreted with caution due to data limitations. With regards to JAK inhibitors, what about JAK inhibitors during pregnancy? The data on the risks of in utero JAK inhibitor exposures are limited. We know that JAK inhibitors cross the placenta, but safety data in pregnancy as well as early childhood are limited. This abstract was a multi-center retrospective observational study, and pregnant women with IBD exposed to tofacitinib, upadacitinib, or filgotinib were enrolled from 22 centers across 16 countries, and data was collected on the timing and duration of JAK inhibitor exposure and maternal as well as infant outcomes. And among the 55 pregnancies, disease activity was present in 54.6% of women. 16.4% of women initiated a JAK inhibitor during pregnancy, and 70.9% received JAK inhibitor treatment throughout the pregnancy. Discontinuation during the first or second trimester resulted in a disease flare in 56% of women. Spontaneous abortion occurred in 9%, and no congenital abnormality was reported. Among the 45 live births, 3.6% of infants were preterm, and 7.3% were small for gestational age. And you can see on the table on the right that this shows follow-up among the 41 infants. There was no major safety signal in the infants, and normal infant development was reported among this cohort. 1/3 of breastfeeding women continued JAK inhibitor treatment throughout breastfeeding. No adverse events were reported following live or inactivated vaccines. Maternal complication risks were also low among the JAK inhibitor exposed women during pregnancy, and no adverse events among the live births. So further prospective studies are needed in order to further confirm long-term safety. So we're now shifting gears over to, two notable abstracts on JAK inhibitor use among older adults with inflammatory bowel disease. So older patients with IBD, as we know, can be undertreated by providers due to the safety concerns related to JAK inhibitor use and infection risk. One study was a single center retrospective cohort study of 101 patients 55 and older who were on tofacitinib or upadacitinib. And the second study was a meta-analysis of 37 studies evaluating the risk of adverse events among IBD patients 50 to 65 years of age versus those under 50 who were on JAK inhibitor therapy. The authors found similar efficacy of JAK inhibitors across these age groups. Although adverse events were higher in the older adults with the relative risk of 1.9, this was primarily driven by herpes zoster infection rather than other types of infections. There was no increase in VTE, malignancy, or colectomy risk. And on the right, you can see a Kaplan-Meier analysis showing no significant difference in treatment persistence between those on upadacitinib versus tofacitinib, which remained at 75 to 80% at the end of 1 year. So zoster vaccination should be offered routinely among the patients starting JAK inhibitor therapy, and this may help mitigate some of these safety issues that we are concerned about. Next abstract. This was looking at safety data for advanced therapies, especially the newer therapies. They do remain limited, as we know. And in this study, guselkumab safety was studied among IBD patients 60 years of age and older. And in a pooled analysis of 14 phase 2 and 3 trials across all the indications, UC, Crohn's, psoriasis, and psoriatic arthritis, patients who had received at least one or more doses of guselkumab were analyzed. There were 238 IBD patients and 618 total patients all across the board who were on guselkumab. And the safety profile of guselkumab among those aged 60 years of age and older was similar overall to the general population. You can see that on the table on the right. Adverse events such as infection, cardiovascular risk, thromboembolic risk, they were all comparable to placebo, and no TB or death was reported. The value of systematic non-targeted biopsies for detecting colorectal neoplasia during surveillance colonoscopy in IBD is quite uncertain in this current age of high-def endoscopy, where we have clearer picture, we're able to see things a lot more clearly now. So this practice tends to be very time intensive, costly, sometimes insurance doesn't cover, and this may increase bleeding risk in patients who are undergoing this. So this study sought to investigate this question. This was a multi-center randomized controlled trial in patients who had IBD for greater than or equal to 8 years, or any duration of IBD with PSC, and they evaluated whether a non-targeted random biopsy regimen, which we currently do, added value to IBD surveillance in this current era with high-def endoscopy. So 1,300 patients across 12 tertiary centers were randomized to either getting targeted biopsies alone, where when you see a lesion or an ulcer, you take it out, or a polyp, you remove it, or you would get targeted plus widespread, just random biopsies greater than 32 all over the colon, which is our current standard of practice. And the study found that a target-only approach was non-inferior for detecting colorectal neoplasia. The detection rates were numerically higher, actually, in the targeted-only group, 10.9% compared to 8.4% in the random group. So on the right, on the graphs, you can see that the bar graph showing the interventional group, which was the inspection and targeted biopsies, in the red bar right there, it does show a higher ability to detect neoplasia in most situations, with the exception being that if you have a patient who had prior colorectal dysplasia, then perhaps the random biopsies are more helpful in that cohort. And out of the 25,000 non-targeted biopsies that were taken in this study, only 11 biopsies actually detected colorectal neoplasia. So this was quite low yield at 0.043%. So these findings suggest that in IBD patients receiving high-def white light surveillance colonoscopy, perhaps a strategy focused more on targeting sampling is non-inferior to random biopsies for colorectal neoplasia detection. Studies on the natural history of pediatric Crohn's disease are limited, despite the widespread use of biologic use among adults. And this study was a retrospective cohort study using a claims database of commercial plans across 14 US states. So 3,092 incident pediatric Crohn's disease cases were identified, and surgery-free outcomes were studied. 12.5% of children had at least one resection over a median follow-up time of 2.7 years. And among those who underwent initial surgery, post-operative treatment outcomes were studied. So overall, the surgery-free survival was 92% at 1 year, then it went to 87% at 3 years and 85% at 5 years. Surgery risk was higher among children that were diagnosed with Crohn's disease at an age greater than 10. And among patients who underwent initial surgery, 17% required second resection, and that median time to the second surgery was 190 days. On the right, you can see a graph showing patients who started anti-TNF within 90 days post-surgery. That's the dotted line on the top, versus the patients who did not start anti-TNF, which is the solid line. And so surgery risk was lower among those who used post-operative anti-TNF prophylaxis compared to the non-users, with an absolute risk reduction of 13.6% at 30 months. So some benefit in treating patients. We get asked this question a lot in clinic. So the authors sought to answer this question. So this retrospective single center study evaluated whether isotretinoin for acne is safe in patients with established IBD. So among the 37 patients who received isotretinoin, only 11% of the patients experienced a change in IBD status. And in each case, the flare was actually attributable to other factors, not necessarily to the medication itself, but perhaps they switched to biologic or they developed anti-drug antibodies or there was a dosing change rather than the isotretinoin itself. The line graph on the right shows that 92% remained in clinical remission even after initiation of isotretinoin, with no significant change in clinical disease scores or inflammatory markers. And so this study suggests that isotretinoin is well tolerated in patients with well-controlled IBD and was not associated with worsening of IBD activity. This is a particularly relevant finding given the acne that's associated with JAK inhibitor therapy. And the last couple slides will talk about some of the therapeutics in the pediatric IBD. There were 2 abstracts that supported the use of IL-23 inhibitor therapy in the pediatric population. One study was a global retrospective cohort of 96 Crohn's disease patients on risankizumab monotherapy. 49% had failed 2 or more advanced therapies, and risankizumab achieved post-induction corticosteroid-free clinical remission in 41% of patients, with 87% of these patients remaining on therapy at 53 weeks. In another cohort study done on UC patients, 36 UC patients received either risankizumab, guselkumab, or mirikizumab, and 64% of patients achieved a 12-week clinical remission rate, with 89% remaining on therapy in this refractory population, where 58% had actually failed 2 or more advanced therapies. So both studies demonstrated a favorable safety profile with no serious infection, malignancy, or thromboembolic events. And these findings do support IL-23 inhibitors as a therapeutic option for pediatric IBD. With regards to vedolizumab, vedolizumab is not currently FDA approved for pediatric IBD. And this phase 3 trial of vedolizumab in pediatric UC evaluated the efficacy, immunogenicity, and safety of vedolizumab in children as well as adolescents with moderate to severe ulcerative colitis. It's called the Kepler trial. 121 children and adolescents aged 2 to 17 were enrolled, and IV drug was administered as a weight-based regimen followed by a double-blind 40-week maintenance, low-dose versus high-dose regimen. And 41% of patients have previously failed a TNF. 47% achieved clinical remission at week 54, which was the primary endpoint, and 34% achieved clinical remission at week 14. 29% sustained remission at both time points. Efficacy was similar between the low as well as the high-dose maintenance groups, and vedolizumab was well tolerated among this population. Immunogenicity was low at 5.8%. Serious adverse events were infrequent, and discontinuation was low at 5.8%. And this was mostly attributable to worsening disease or infection, not necessarily to the drug intolerance. So these response rates and safety are comparable to those seen in the UC adult trials. Finally, with upadacitinib. Upadacitinib is not currently FDA approved for pediatric IBD, but used off-label in clinical settings. This study was a retrospective multi-center cohort study of children under 18 years of age, children and adolescents, who started therapy with upadacitinib, and clinical outcomes were studied at the end of induction and at 1 year of therapy. There were 106 participants, 22% on dual advanced therapy, commonly with ustekinumab or vedolizumab, and 63% of patients were able to achieve deep remission at 1 year, as shown on the bar graph on the right. Safety appeared similar to that seen in the adult population as well, and upadacitinib was effective at maintaining remission as well as nutritional status, BMI, weight in the pediatric patients. But of course, longer-term studies are needed. Thank you.
Thank you, Dr. Park. So we've reviewed kind of the key abstracts and what has consistently been one of the most exciting areas in research in GI for the past few years. But now Dr. Marla Dubinsky is going to put this in the context of really a paradigm shift in the care of patients for IBD. Marla.
Thank you. So a lot of the themes that Sandra and I sort of highlighted as to where the future is going, I'll try and set the stage about where the need is and what are the pillars of care as we think about moving forward. So there are really 3 pillars that we're going to be focused on, which is optimizing the current treatment paradigm, addressing specific unmet needs, with which Sandra started. Really, her talk was all around special populations and really how we're thinking about not just every individual being who's in a clinical trial. So that really set the stage as well. And a little bit of a hint, as I noted, about the future of IBD therapeutics. So as we know, a lot of why we're so focused on how do we optimize is because we've literally, if you look at every clinical trial, you pretty well see at the end of a year, it's about 37, maybe 40% of our patients in trials. Granted, real world, we always do better than what's in clinical trials because we optimize, we're able to add, subtract. There's some nuances that make it a little bit easier for us, especially in those drugs where we can optimize, like TNFs and ustekinumab and vedolizumab. The newer generation, we don't have to really optimize because they're sort of dosed correctly. But really, it's this ability to think about what are all the parameters that are going to need to be happening for us to actually get closer to that transformative efficacy, which is like 85% of our patients are actually achieving endoscopic remission, like a Mayo score of 0 and, an SCSG score of 2. Imagine. So that's sort of the concept of what are all the parts that need to be in play in order for us to break it. So I'm going to first talk about treat early, and really sort of DDW was framed around this concept that we need to get patients on effective advanced therapies at diagnosis. Treating early, we used to say sometime within 2 years, you should probably move somebody to an approved advanced therapy and match their disease activity to the drugs that are actually approved. For example, mesalamines, although they're used in everybody from mild all the way up to moderate to severe, they're only approved for mild to moderate, yet remain the number one prescription for ulcerative colitis. And in Crohn's disease, unfortunately, steroids and 5-ASA, both of which are not approved, remain the number one prescribed therapy for newly diagnosed small bowel Crohn's. So we've got a huge problem, like a really big problem. And so the idea was set forth by this study called the Profile Study, which got a lot of play over the last year. This year, they presented their 5-year data, but I just want to remind you of their 1-year data, which was presented and said that when you take an individual with Crohn's disease who has moderate to severely active Crohn's, and you give them an effective therapy at diagnosis, so people were randomized within 15 days of colonoscopy diagnosis to either get combination TNF with an immunomodulator, most commonly thiopurine, versus the classic step-up approach, which is I'm going to give you steroids, then I'm going to see how you do, then I'm going to give you more steroids, and then I'm going to add a thiopurine and see if you can get off the steroids. And then here I am going, oh, Lord, you need an anti-TNF. Anyways, that's the step up, which, is no longer in vogue, right? So the idea that they looked at newly defined early, and that was at diagnosis, which is kind of cool. So it was the first study. We all do it in practice where we give people advanced therapies, but this was a randomized study to one sort of creep up versus sort of top down, although they called it step up versus top down. None of us are top downing, right? We're staying on top. Like we're not actually going to 5-ASAs after we give combination. So the term is very outdated, and it was sexy at a time when everyone remembers the pyramid being turned upside down. That was a sexy slide we all did. And then we realized there's no such thing as going down. We just stay up. So this concept of, the notion of giving effective therapy at day one, and lo and behold, shockingly, that when you do that, amazing things happen. You get, close to 8 out of 10 patients in steroid-free, surgical-free clinical remission. You get better endoscopy outcomes. And it's funny, this study was actually done not to this step up versus top down story I'm telling you. It was this idea that we were finally going to have a biomarker. We're finally going to be able to predict who needs stay up therapy versus who you can creep up. And nobody, was under any illusion, especially someone like myself who's made a career on risk prediction and then gave up on it, realizing that you don't need to predict anything. Just give people an effective therapy at diagnosis. Who needs to predict anything? This study confirmed no need to predict anything. That even if you are a high risk biomarker carrier, if you treat low risk or high risk people with effective therapy, it doesn't matter what your biomarker showed, just treat. So that was the basic theme of DDW. There was a lot around just stop the madness and just treat. And that was the theme, and Profile sort of led it. So that was the first, the Lancet paper. And then at DDW, they presented the 5-year outcomes. So are we truly modifying disease? Because IBD is not a week 52. So our clinical trials can't say we modify the natural history because colectomy rates are so rare in the first year after diagnosis. So even a UC trial looking at trying to see if I lower colectomy rates, that's never going to, be the case. You're never going to see it in a short-term trial. So this was actually looking long-term, and you could see that we had a lot less surgeries. We had less hospitalizations, less people who progressed to stricturing. It's not perfect. It's not 100%. So that speaks to why the ceiling needs to be beyond just treating early. It's about combination. It's about a lot of other things that we have a lot of work to do in the next decade as we figure out all of these new therapies and combinations that are coming to play. But this is really sort of a signal to everybody. And no one really believes that it had to do with TNF and thiopurines, by the way. The message is start anything. Any approved therapy, any guideline approved therapy, just start it. It's going to be a lot better than creeping up, right? So that was the concept that was really set forth at DDW. And, the reality is there's such a cycle of delay. And when you look at claims data, which is why I started by saying we've got a lot more work to do, and you would think that the profile study would try and convince as many people. But when we looked at claims data, you could see, and I was noting that, advanced therapies are uncommonly used in the majority of our patients within the first 2 to 3 years, which is the most important time. Because what happens to the bowel wall of Crohn's disease patients? You start to get progressive bowel wall damage, collagen, stricturing. And so timing is really important in Crohn's. In UC, to be fair, although, you still have a very low number of people getting advanced therapy, some of the newer studies suggest that time is not of the essence with UC as much as it is with Crohn's. Meaning there was a study called the Love CD, Love UC study, where in Love CD, which is Vito and Crohn's, so it could be the asset itself, but just hear me out, that in Vito with Crohn's disease, if you use Vito within 2 years, you had much better outcomes for Crohn's than if you waited 2 years plus, right? So there was this idea that timing is important when you use advanced therapies, Crohn's in particular, because of the transmural, the bowel wall damage, why ultrasound is going to be so critical. But in UC, the Love UC study, it didn't look like time was that important, meaning people responded similarly if you waited 4 years to use Vito compared to those who used it within a year. So it appears that even the natural history of Crohn's or UC are very different. But more so, a reminder that there is no approved therapy for moderate to severely active disease that is not an advanced therapy for Crohn's. There is none. With UC, we do have 5-ASAs, but they're for mild to moderate, not for moderate to severe. So there isn't one for UC either. So moderate to severely active, however you want to define it, is an automatic go-to advanced therapy. There is nothing approved other than that, right, for moderate to severe. And so this is very concerning, right, that that more than 6% of people with UC have moderate to severely active, yet they're not getting an advanced therapy. So this is the reality of claims. Now, of course, claims are not 100% accurate, but they are the best we got at understanding practice patterns. Why positioning therapy matters? Well, this graph is going to be like expansive over the next 5 years. Imagine, like there's not even going to be a slide size that is going to be able to fit what's happening in the space with probably 5 new therapies approved in the next 5 years. 5. So this again is an expanding field. And so does positioning matter, right? How do we know which one do I use first? I sort of made the claim that I don't care which one you use first, just use one. That's true. We're not there at a point where we can say this patient, obviously nuances, people with extraintestinal manifestations, you're going to want to use a drug that's also approved for or has been effective in that type of extraintestinal manifestation. Someone who's got psoriasis and IBD, you're going to want a drug that has both positioning for both psoriasis and IBD, as an example. Someone who's got severe eczema and IBD, hey, the only drug we have that's approved for both eczema and IBD is upadacitinib. That's it, right? And so the idea is that we need to start thinking about different nuances that help us position. And there's been many ways and tools that have been put out there to help us try and position therapies. There's network meta-analysis, which are driving guidelines. There are real world data that, of course, in the absence of propensity matching or try and match the cohorts, makes it a little bit biased. And of course, the holy grail is head-to-head trials. And we have very few. In Crohn's disease, we have CView, which was ustekinumab versus adalimumab that showed they're no different in new, naive exposed patients. Then we had Sequence, which was ustekinumab versus risankizumab, and risankizumab was twice as effective as ustekinumab for deep remission, like endoscopic. And we have in UC, Varsity, which was vedolizumab versus adalimumab, which sort of put to bed using ADA for UC, should be, anyways. And then we're going to have another one, which is risankizumab versus vedolizumab in UC. So that's going to be very fascinating to see how the landscape shifts when you're taking the two, powerhouses in a naive UC patient and going, which one am I going to use? So we'll see if there's any difference, but that's it. That's sort of all we got. We do have within the phase 3 trials for guselkumab and for mirikizumab, we do have a arm that has an active comparator with USTEC. So there is that in some of our clinical trials. But other than that, we don't have a lot of head-to-head. So we rely on other things. The AGA, and this is difficult to read, it wasn't the point, it was just to say that the AGA has used network meta-analysis to help guide you as a clinician which one is the highest efficacy, which one is intermediate, and which one is lowest. And, I made the point that adalimumab is the lowest efficacy in a naive patient population. So for UC, we should, again, Varsity sort of said it and all of our network. And now the guidelines say stop using sub-Q anti-TNF, particularly adalimumab, for UC. And so I like the AGA guidelines because it used a way to help clinicians understand you have two types of people in clinic on Monday. You have an exposed or a naive. That's about right. That's it. When you're facing a decision making, and the AGA sort of tells you, like, if you were a TNF exposed patient, which is the bottom box, then you may want to position certain therapies differentially in UC because not every drug works well after you failed an anti-TNF. And that's important to understand, and where advanced therapies will fit in, thinking about a failure, which is why duet is important. And, there's a lot more we need to do to understand sequence of drugs. And your second one is as important as your first. And so understanding the efficacy when it's positioned after a TNF is paramount to be able to get optimal efficacy for your patients so they're not failing that one too. Like, to be fair, vedolizumab and IL-23s are not phenomenally effective in a TNF failure population in UC, but amazing in a naive population. So just understanding that nuance really will help you and your patient make better treatment decision-making. And in Crohn's disease, they did similarly the same thing, trying to explain to us high efficacy, medium, and low, so that when you're having a conversation with your patient who's pushing you on safety and saying, I want a drug that's been out for 20 years and I want a drug that doesn't have a commercial that says I can die. And you're like, well, what's more important, efficacy versus safety? And you have this conversation around how we rank them based on clinical trial data. So this is what the AGA guidelines did. It's very simple. They took the delta between drug and placebo and ranked them. Who had the highest delta? That's basically what happens in this kind of analysis. And so the highest efficacy had the most difference between the drug efficacy and placebo. And then they divided it up into refractory versus naives and where you see the biggest benefit. So that's why understanding the nuances, like IL-23s work amazing, first, second, third. In Crohn's, doesn't matter where you place them. That's not the same in UC. So understand Veto, great first line early, not great second, third, that's for sure in Crohn's. So understanding that is so critical to get your patients to break through, that therapeutic ceiling. The ECHO guidelines took a different approach. They sort of based it on different types of subpopulations, an EIM population, pregnancy population, ANC-SPON population. And, despite it being around since 1998 and everybody trying to push it out, guess what drug has green throughout every special population in a Crohn's patient, which is why anti-TNF, particularly infliximab, remains a big deal in Crohn's disease. So I think even understanding the patient on Monday that has all these different subpopulation nuances is really important. And this paper, again, not for understanding, or being able to read it, but as a reference. This is a great reference where it breaks down first drug, second drug based on subpopulations and which drugs to maybe avoid for safety reasons, for pregnancy reasons. So I like this graphic to sort of help us start to segment our patients. Because again, Lord, with the next two orals and then 3 sub-Q/IVs between now and 2030, how am I going to make a decision about what's next? There's a lot of combo stuff coming out. I'll talk about GLP-1s and that bonanza explosion of GLP-1s and IBD. So just understanding this patient population is really going to be critical. If you're going to practice IBD, you must understand these nuances, or else you're just missing the way the field is going, which is understanding the individual patient. And then when we talk about STRIDE, sort of treat to target, just to let you know, an update that STRIDE 2 was published in 2021, STRIDE 1, which was published in 2015, and we will have STRIDE 3 this year. So we are working on how our vote went and what the literature sort of said. And just to remember, STRIDE 2 sort of hinted that should we in clinical practice use histology as a target for UC? And should we be using transmural healing, aka why ultrasound and cross-sectional imaging is becoming more and more important in Crohn's, because we believe that we need to get transmural to reduce the surgical rate. So STRIDE 3 is really going to be focused on transmural healing and whether there's enough data today to say that that should be a target. There may not be, despite my obsession with it, there may not be enough out there in the literature to make us all buy ultrasound machines for our offices or send all of our patients to MREs. But one thing is for sure, when you look at surgery rates, if someone has no healing at all, in terms of need for surgery, just to show you that 0 individuals in this prospective cohort who reached transmural healing, in addition to endoscopy, in addition to clinical, none went to the operating room versus still people with endoscopic healing, even endo alone, still went to the OR. And of course, if you have neither of the two, bad things happen. So in Crohn's disease, which is why we continue to push the therapeutic ceiling for Crohn's disease, because we are missing the 4 layers of the bowel wall and we only see the inner layer. And probably the most important layers are something we don't see at endoscopy, right? So that's why this transmural aspect is going to change the practice for Crohn's disease. This was another study showing that if you use early versus late, going back to what Profile was saying, that if you use early therapy and you get increased rates of transmural healing, you also get less bowel wall progression, less surgeries, and less need to escalate therapy. So it is clear that that is the target we need to get to. The question is, today, do we have enough data based on the smattering of folks that are interested in transmural, whether we have enough to set the guidelines for STRIDE 3? This is sort of what it's going to be focused on. I'm giving you a little bit of a hint. This is the International Organization of IBD, and we sort of have these consensus along the way, and we felt it was time for STRIDE 3. I'm not so sure the data is going to point to so much of the way we left it in 2021, as I noted with histo and transmural, but it is going to be immensely focused on patient-reported outcomes, fatigue, urgency, nutrition, all the things that we left off, by the way, as an international organization. We said quality of life. Well, there's a lot more than quality of life that the IOIBD should have been putting as a flag. And so you're going to see a lot around fatigue and urgency and pain management, really focusing on patient-reported outcome as being the target for where we really should be shooting for with our treatments. So is fibrosis the biggest unmet need? There is going to be, it sort of links with the transmural story. Of course, fibrosis is a big problem in Crohn's disease. We know we're still operating on ileocecal Crohn's disease. So what do we know about fibrosis? And there was a paper that came out that despite overall surgeries decreasing in IBD, amazing. We've done a really good job of bringing new treatments to the market. We could do better if we treat early and all the, evangelical things that we often say at podiums. But this study showed that even though overall surgical rates are coming down, the rates of surgery for fibrostenosis, ileocecal resection for bowel obstructions is going up. So proportionally, even though all surgeries are going down, we are still operating and our surgeons are very busy still doing ileocecal resection. So we do have a problem. And understanding the mechanisms of fibrogenesis, meaning the process of laying down collagen and what we're seeing, that's all not in what we see endoscopically. As I noted, sometimes you feel it when you put your biopsy forceps on. You're like, this feels like cardboard. Like when you're putting it on, that there's like this sort of fibrotic element to the bowel when you're trying to do biopsies in these patients who have it long-standing, but understand the mechanism of fibrogenesis. And there was a study that actually tried to reverse fibrosis. So this is a Stenova study. It was a phase 2 where they took a drug, ALK5, so that's the mechanism, and they tried to actually reverse fibrosis. We've got a long way to go before we tell anyone we have a drug that reverses fibrosis. We didn't really change the outcomes of people's symptoms that much, and the MRIs were not that transformative when we looked at repeat MRs in this study. There was some endoscopic improvement, which is cool. So this is maybe a new mechanism for endoscopic outcomes, but we really didn't see so much of a difference across the board. We did see a difference in stricture length, and maybe some bowel wall thickness. So we're waiting to see what the regulators are going to do in terms of what's a regulatory path to get a drug approved for reversing fibrosis. We're not quite at the liver stage of fibrosis for IBD, unfortunately, which is why maybe How about if we just treat properly, we'll prevent fibrosis? Let's get into that space because I think that's an easier game to play than reversing fibrosis. And that is why anybody, unless you live under a rock, you have not heard about TL1A, but this is inhibiting a completely different pathway called TL1A, which is tumor necrosis ligand 1A. It is not a TNF. It is not an anti-TNF. And the one superpower that this target has, or what it's touted to have, it not only goes after the same cytokines you are very familiar with all the drugs we have, but it also attacks the fibroblast, the cell that lays down fibrosis. So this ability to go both fibrogenesis as well as inflammation is really the future, and where ties in transmural aspect, because the feeling is if we can go after the fibroblast, we may prevent and solve the fibrosis problem. We will see where this all goes, but there are 3 phase 3 studies. Their phase 2 data were very, very convincing. All 3 are enrolling as we speak. We will see the induction data shortly for one of them, and you will start to get a sense of how does this look differently. What I will tell you is in a week 52 trial, you're not going to see reversal of fibrosis or any change in fibrosis because we won't see it in a year. So you're not going to get the fibrosis stuff. You're only going to get the anti-inflammatory benefits. So we'll see how it looks differently than the IL-23s. Will it position? Will it bump the IL-23s in your preferred treatment choice? There's even biomarkers that suggest that in the phase 2 trials, that they are decreasing the cells that are responsible for fibrosis. So that's good that it looks mechanistically. There's some excitement and it may make sense from a biology perspective. So we wait for future data. Now, probably one of the things we can do also to reverse or prevent fibrosis is treat visceral fat, right? Why do you think GLP-1s are exploding in the immune diseases? There's a reason for it. Is particularly in Crohn's disease, the mesenteric fat, creeping fat, that is visceral adiposity. So our patients, we believe that the fibrosis is happening because of the fat that is surrounding the bowel. So there's even probably a genesis of fibrosis just by visceral adiposity. And this idea that particularly in Crohn's disease, we're able to alter perhaps the natural history of the disease. There is an explosion of GLP-1s across the board. Particularly, there is really this idea that maybe even with increasing obesity, there's increasing cases of IBD. And so there's an epidemiology, there's increasing risks of psoriasis. We know that immune diseases are increasing in the face of obesity. There's a lot of studies looking at it being sort of associated with increasing cases, but there's also a ton of data looking at it actually impacting the natural history of the disease, lower surgeries, less complications, better outcomes, less treatment escalation, less need for steroids. So there's a huge impact of GLP-1s on inflammation. And so there's even a study that said, why are we not using GLP-1s to slow down the motility of patients with pouches? So at a UNC, they gave GLP-1 and lo and behold, stool frequency completely dropped in people who are having high output J pouch, right? Or high output ostomies, microscopic colitis. It's endless. You need to start thinking outside the box. The safety in IBD patients has not been shown to be any different than the general population, despite all of the GI stuff. But I can tell you, many of your patients will appreciate having less stools than what they have with IBD. So it's actually counter to what you actually imagine it to be, and the safety. And the last pillar is how do we break through? I sort of talked about combination. These are all the combos that are actually in trials as we speak. There are sort of tentacle-like trials where they have 6 or 7 arms of different combinations, kind of cool platform studies. And some of the early reports are out showing that indeed there was a report from AbbVie on their quarterly earnings call where they combined alpha-4 beta-7, a sub-Q every 4 weeks with IL-23, showing double the endoscopic remission in patients who are on that combination in Crohn's, refractory Crohn's disease. So who knows what's going to happen next, but lots of excitement around it. And prevention, I want to leave you with sort of this idea that, yes, believe it or not, despite the amazing advances in therapy, despite all of our treatment paradigms we're trying to talk about, believe it or not, there's a whole group of us who are actually trying to prevent this disease from even happening. Let's focus on treatments for the 3 million that have it. 10 million worldwide, and let's focus on ways where we can lower the incidence and prevalence of these diseases. And so what we're looking at, and where really the focus around the world and sort of this idea globally is, can we actually prevent the disease? And so there's a lot of work being done on finding biomarkers in high-risk individuals, so first-degree relatives, high genetic risk, taking them and putting them into dietary interventions, Mediterranean diet, all of the things that we're learning that are very impactful to increase the rates of IBD. And you could look at it based on where do you address it in the general population, first degree relatives, this idea of preclinical people who actually may start to have calpro elevation, have no symptoms whatsoever in these first degree relatives. Can we come in and actually prevent the disease from happening with one of our therapies that we're actually using? And so the fact is that this is happening in real time. Vedolizumab is being used in a high-risk individual, first-degree relative, no diagnosis of IBD, to prevent IBD in Europe. There's a 35 million euro grant to try and prevent IBD, imagine. So this idea that they're using approved therapies we use to get people early who are at risk of developing IBD, that's happening. So there is so much, happening in this space. It's just really a space that is exploding. So much so that prevention clinics are being set up around the world where people come in, first degree relatives, they get an ultrasound, they get a calprotectin, they get a lab test looking at serologies at predicting disease, being randomized to lifestyle versus therapies. Imagine that this is actually happening. So this is sort of like IBD, I've shown you crazy what's happening in the treatment strategy, but the idea that we're actually trying to prevent this disease is kind of a whole other paradigm. So the complete shift in IBD care, it's all about timing, it's all about target, it's about understanding mechanism and dual, and also focusing on prevention and interception. So thank you.
Yeah. Okay, we're going to open up the floor to questions, and I'm going to ask Dr. Park to come back up. So don't be shy. Got a first taker here. Fire away.
So I've read some reports on appendectomy in UC. Is that a real thing, or is that just something coming out of one report?
We left that out, noted. Yes, so Don's talking about, there's a couple of studies that have shown that looking at appendectomy preventatively, we talked about in our prevention program, Don, whether we should actually offer appendectomy. So there was a study out of Europe that showed you can decrease rates of UC, and retrospectively looking at where patients, those who had an appendectomy had lower risk of UC. And there was a study done out of Amsterdam where they actually did appendectomy and see if patients remained treatment-free and could de-escalate their therapy instead of staying on therapy as a treatment.
So you're throwing the surgeons a bone because you're taking everything else away. So
yeah,
you're giving them something.
If they're stuck with hemorrhoidectomy instead of a J pouch, I figure I give them something, like take out the appendix while you're at it or something. But yeah, it's not ready
before the robot does it.
That's right. It's not ready for prime time, but there was some interest also at DDW in it. Yeah.
Dr. Sultani.
Thank you for excellent presentation of a lot of complicated information out there. But basically, in private practice, we see a lot of people coming in for a screening colonoscopy, may have ileitis, no symptoms. Some serologies are positive. You think they have likely Crohn's, that's mild. What do you do with those patients if you're already trying to prevent with vedo? I mean,
good point.
Yeah.
What do we do with these people? You're right. Is that the best preclinical population in a sense? Like if we're deciding that they have the serology, they have a calpro of like 250 or something, that you're right. That is potentially a preclinical population where they're not clinical symptomatically, right? And so I think that, the reports suggest that these people don't progress. To be fair, when you look at the epidemic, there's cohort studies that have looked at over time, I think less than 10% progress to a clinical phenomena. So I guess if only 10%, which 10% progressed? I don't know if they did that kind of digging in their analysis, but I think that you could go either way. You can watch them and like for me, I would do an ultrasound on a patient like that to see if it's transmural. If it's just mucosal, you'd say, well, why don't you try a Mediterranean diet? And that's actually, or a diet low in emulsifier. There's been 2 diet studies, actually. You're bringing up a point that I just remembered. Last year at DDW, they presented a diet study out of the UK where they gave patients a low emulsifier diet versus the standard, westernized diet. And they did actually see a change in CalPro, a change in CRP, and a change in symptoms. So I think that's the patient that you could go either way. We'll wait for the veto intervention study in Europe. It will be interesting to see. Or that patient, I would definitely say a dietary intervention may be a place to start, and then following with your CalPro, et cetera, if it matches. So I think we're at a point where we understand the role of diet. And I think in that patient population, that would be a great study. So study it, because you'll find it more than I will, right? I'm never incidentally doing, I'm not popping in and going, oh my God, you have Crohn's. So we need more of those studies. Yeah.
And just a quick, what I'm taking away from your talks is you don't want to stop any advanced therapy. We have patients 4 years out, 2 years out, they're doing great. Numbers are all good. Do you ever stop? And what are the data in terms of like recurrence in those folks, be it UC or Crohn's? Thank you.
This is what I can tell you is that there's been a couple of studies, mostly out of Europe, because of financials. They tried to, this has been multiple times. I don't know why they keep trying to prove that you can't de-escalate. But in the study, the SPARE study is probably the more recent one out of Europe, where they either stopped the thiopurine or stopped the TNF. Which one do you think did better? I mean, they were on both, right? And they just de-escalated to monotherapy TNF versus stopping the TNF. And even though at a year, it wasn't everybody who flared, but essentially that and the story study, when you followed over time, almost everybody recurred. So the question is there a subset of patients that in any of those studies that didn't recur? The subset analysis didn't propose that someone, if you match them propensity-wise, there was no predictor of who was going to flare sooner or not. There was maybe in the original story study, which was a long time ago, that said if they had low levels at the time of stopping or antibodies at the time of stopping, it meant they probably weren't even responding to the drug. They were well without the drug actually having an impact. They said maybe that's a patient you can stop. There's never been really like good predictors of who you can stop. So as of now, rumor has it you can't, you could de-escalate or stop, but it's going to come back.
I would add that in my clinical practice, I do have that conversation with patients who've been doing well. Maybe they're in remission for a number of years and there's no evidence of active disease. You have that shared decision-making conversation with them about de-escalating or stopping therapy. And, you have those anecdotal patients in your practice who are off therapy and you're following them once a year with MRI or colonoscopy and you watch them, off therapy. So
I think de-escalation is more realistic, meaning if they're on combo or, like you're going to stop the thiopurine. Someone who's on Q4 infliximab, do they need to be on that eternally? Their levels are probably going up. You can probably, it's more about, let me de-escalate you, or even in patients where I have combo, the purpose of it is to try and de-escalate the JAK, right? Maybe I can get you down to 15 because I couldn't get you down to 15 as monotherapy and they were worried about their acne, which is a real problem. Severe acne in some, where we have to use Accutane. So The study that Sandra was from our site where we're using Accutane for JAK, right? So it's so ridiculous that I'm, using something else to help fix this, but it was the last effort. It was the only drug that really got them where they needed. So I think strategies to de-escalate from a safety perspective may be more interesting than stopping therapy completely.
Kelvin.
2 questions. So the first one is recently I have a patient basically with UC on anti-TNF and asking me about planning for live vaccine after delivering the baby and when. So that's when I look into the IBD consensus for this, but the data is actually very low in terms of proof. So where you at in terms of recommendation for live vaccine for patient on any therapy, and then also with rotavirus, there is some new recommendation recently that it's okay to give even right after baby deliver. So that's the first question. And then the second question is pregnant women on planning for, say, formula later on, is there any data in terms of prevention, since you talk about prevention, for their babies developing, IBD later? This whole controversial talk on A1 protein, A2 protein, goat milk, cow milk, that is more immunogenic than others.
Which question you want me to address first? I'll do the ROTA first because that's so easy.
Okay.
Yeah, so our global pregnancy consensus, we used to, as you know, talk about not giving the babies live vaccine in the first 6 months of life. That was sort of our go-to consensus before the global consensus that we published in the last year. And that was because it was a live vaccine. And we said, just like you, we don't give you a lot, meaning to the mom, the conversations. And then the group in Canada actually did the work where they intentionally gave ROTA and saw that the babies responded very well. It wasn't that we felt it would be a safety problem. It just, we didn't think they would mount a response. So we were sort of like, because it's a gut targeted and, we didn't think they would mount a response. So the group up in Canada actually did the work and showed that they mounted the response the same way as babies who weren't exposed to any of our advanced therapies, and that it was safe and effective. So that was one of the two things that came out of the global pregnancy consensus. One is to give all babies now, moms don't have to worry about which one they can give, or we don't have to worry about which one we tell them to avoid and forgot. And then the husband took them at the 8-week visit and the mom is freaking out because they weren't there to say not to use live vaccines. We've saved a lot of marriages, I think, by opening up, is what I've decided, the rotavirus vaccine. So that we've taken away the burden of that. The other one thing, since you're talking about pregnancy, the other one deal breaker that was really new in the global consensus is that all women with IBD need to be started on baby aspirin before week 16 of gestation, typically starting at week 12. That's what the study originally did when they looked at using baby aspirin to reduce the risk of preterm preeclampsia. We're not trying to say preeclampsia is going to be wiped out, but the data suggests that women with IBD have higher rates of preterm preeclampsia, probably driven by just uncontrolled disease. I'm not sure pregnancy and not due to our meds, I don't think. But anyways, because of that, we sort of made a global consensus that all women pregnant start at minimum when confirmed ultrasound pregnancy, meaning at around week 8, but they can start it at week 12. But if you start it after week 16, you've missed your window because the placentation has already happened. So the insufficiency would have already happened. And the dose is no longer 1 baby aspirin, it's 2. So it's 162 milligrams of baby aspirin. All your moms are going to tell you that they were told never to take an NSAID or an aspirin. So you preempt that discussion by saying, I know you've been told or you've read that you shouldn't take NSAIDs, which, by the way, you can, and that's a myth. And then they be mad at you that they suffered through painful periods and swollen joints and wisdom teeth with pain. There's a lot that happens in my clinic. You could see that I'm having traumatic conversations. So I'm like, as I'm introducing, so I preempt and say, I know that you've been told or you may have avoided them in the past. The guidelines are you can take 160 milligrams at night. Starting at week 12, you can start a little earlier, but not before sort of week 8. And it has to be before week 16. So those are the two deal-breaking global consensus, ROTA and baby. Terms of vaccines for live vaccines, you know that the label for Vito actually says that if needed, you can use a live vaccine. So there is one of our drugs who actually took a leap and the regulators sort of allowed them to take the leap that when needed, you can, risk-benefit discussion. That has not transpired over into things like TNF or the JAK inhibitors for sure, or our S1Ps or even the IL-23s, which I think many of us view IL-23 and Vito similarly in terms of safety and immune, whatever we want to call it, suppression or modulation. So, if for some reason there must be a live, which I can't think of, Shingrix was the only one that we were meaning the shingles vaccine is the one we were struggling with a lot, other than MMR, which, again, I'm not sure how much that comes up, or yellow fever, just tell them to avoid the Amazon and Kenya, maybe, I don't know, on their safari. So I'm not really sure when it comes up, but we do miss a cycle and we tell them that we're going to delay it for 3 to 4 weeks before they'll get their next cycle. I don't know if that's worth it. So I'm not sure. Are there specific scenarios that you are pointing to, or you just wanted more guidance from societies on it?
Yeah, kind of more
Okay.
guidance. I did say that to that particular patient also 6 months after, and then just the whole rotavirus is new, and the asthma thing that you said is also a new thing. So even though the data was also low on that one as well.
Yeah. Then you'll
Yeah.
talk about the
They
formula.
mentioned the BCG vaccine as well
Oh.
in babies. Yeah. And that you may want to check serum drug levels in the baby if the mom was on a biologic before you give the BCG to make sure that it's eliminated from the body
Yeah,
in
could-
certain countries.
Yeah, it could be that
Yeah.
they would stop the TNF earlier in pregnancy. So as Sandra said, there's no measurable drug level at time of birth, which is counter to what we recommend, but it is country specific. So we did make some nuance around that in the guidelines. Want to talk about the formula question?
What was the question?
His question on for at-risk babies, like
Yeah,
babies
things you
born-
can do for, babies coming from, mom with IBDs, and they're really concerned about what kind of formula they're going to give, because the whole talk on the A1, A2 protein, as well as, whole milk versus skim milk, goat milk versus cow milk, which one is more immunogenic, that sort of thing.
I don't know that there's much on that, but other than the genetic risk that mom has passing on to offspring, yeah, I'm not sure if there's
these
any
conversations
major,
haven't made
data.
it to our prevention or our preconception, but I will bring it back. But what I will tell you is that we've done studies now where we have 2 pregnancy-related studies. One is called the meconium study, where we looked at the meconium, so the first poop of the baby, and we looked at the microbiome of babies born to moms with IBD versus babies born to mom without IBD, or parent, dad or mom. And the microbiome of the babies born to moms with IBD were just like the moms, meaning very at-risk microbiome. So compared to babies born to moms without. And then what we did is we went into the 3rd trimester and gave moms the Mediterranean style diet, an anti-inflammatory diet. So what we're doing in my preconception and during my pregnancy is I'm just telling the moms that they should start their Mediterranean style diet in the 3rd trimester, because the Melody study, which was a follow-on to the meconium, I guess we like AMS at Sinai, is that we then we looked at the microbiome in the babies whose moms stuck to this diet during the 3rd trimester compared to babies whose mom did a westernized diet or did not stick to the Mediterranean or anti-inflammatory diet. Their calprotectins were higher, the babies, and their microbiome was that what we deem to be an at-risk or a pro-inflammatory microbiome. So all of what I'm showing you is that really diet is where it starts. And yet we're not using diet once the horse is out of the barn. Like, we're not saying to IBD patients who are moderate to severely active, saying, forget advanced therapies, you just need to use, a Mediterranean style diet. So where we believe microbial-based approaches, which diet would be one, would be in the prevention landscape or in very mild to moderate, like the case that you were talking about popping into the TI. So there is a role for diet, either ancillary with advanced if people are very interested in diet, but not as a monotherapy in people who have moderate to severely active. So that's the distinction. And there's the next decade is going to be focused on what is mild Crohn's disease. So maybe that's what mild is. I don't know. So there's a lot of consensus going on. There's a lot of consensus building. There's a regulatory discussion with our FDA on how do you do a study in mild Crohn's disease. So we'll learn a lot more. And I think diet will have a much bigger play in that population.
And I really like the fact that, just kind of piggyback on the question from the previous gentleman, kind of the same concept, preclinical, some TI ulcers with 0 symptom. I recommend the same thing, Mediterranean diet. But also, since some patients are also throw on turmeric or king day as well as another approach, do you use that too for kind of this situation?
Yeah, so do you do a lot of sort of in mild, or do you add it on to even a patient who's like on a advanced therapy?
Yeah, I recommend it, in patients who really are attuned and into some of the naturopathic, remedies, just cautioning them that there are, this is not FDA approved and that there's risk for pulmonary arterial hypertension if you take too much. And so it's not really monitored. And so, if they want to go on, turmeric, they can do it. I rule out other sources for ileal disease, things like TB, Yersinia infection. I may give them a course of steroids for short term to see if it goes away, and then monitor them in a year to see if it goes away. And if you don't have progression of disease, you just watch them off biologic therapy.
I think the in addition to vedolizumab, if there's an oral alpha 4 beta 7, which there's 4 of them being tested in phase 2 trials now. 2 out of the 4 didn't hit yet, so we'll wait to see with better dosing, maybe if it does. And then, of course, the oral IL-23, which would be sort of the question for this preclinical, however we define it, we can better define, including these folks you talked about, the pop into the TI, that I think between GLP-1s and oral IL-23 and then possibly an oral alpha-4, I think it'll be in the water. Like, I really believe that the landscape is going to change entirely in terms of incidence of IBD, and we're only going to see it in our prevention clinics, those that are on GLP-1s versus not. In high-risk first-degree relatives, are we lowering the risk of IBD? Serious. So I think there's a lot of exciting stuff happening in this space, but thank you for your interest.
Thank you.
Thank you for a great session. We're going to meet back up at 11. And please take a look at the exhibit hall if you can. Yeah, if we could all take our seats, I think we're going to begin the lower GI abstract session. Marla and Sandy are getting swarmed, but they'll be available. You can find them somewhere later today. So we begin a lower GI section, obviously something that I do every day, colonoscopy, something that we see every week as a clinician, diverticular disease. We have a world expert in diverticular disease and lower GI bleeding from the University of Wisconsin. Dr. Lisa Straight is really probably one of the best people in the world to talk about diverticular disease, which she'll cover more in her state-of-the-art talk. But first, she's going to take us through some highlights from DDW abstracts. Dr. Straight, welcome.
Thank you very much for that kind introduction and the opportunity to come here to beautiful Southern California. I'm going to talk about, I should have figured out how to do the advancing, best of DDW colon. Dr. Buxbaum and I decided to split this topic a bit, and I'll talk on screening, surveillance, and QI while he'll cover polypectomy and AI. And my talk is less of a whirlwind and more of a targeted talk on a handful of abstracts. This is a brief outline. The first talk, does screening colonoscopy work? An overview of the high-profile Nordic trial. How do we measure colonoscopy quality? A couple of talks on ADR. How do we improve polyp detection? A novel technology I thought looked promising. And what's the broader impact of endoscopy outside of our clinical outcomes? What's the impact on our environment? A really interesting study done by UC Irvine. So first, the Nordic trial, the long-term effects of colonoscopy screening on colorectal cancer incidence and mortality. Why I picked this study and updated RCT evidence on colonoscopy effectiveness with very high visibility and debated results, actually published in The Lancet around the time of DDW. So as we all know, colonoscopy is widely used for colorectal cancer screening, but RCT level evidence is limited as compared to sigmoidoscopy and FIT testing. And the prior 10-year results of the Nordic trial were published in the New England Journal in 2022 and showed a modest reduction in colorectal cancer incidence, but actually no mortality benefit. And there were a number of reasons proposed for why this trial had less impressive results than were anticipated. And one of them was that perhaps the follow-up was too short to see a difference in mortality. And so the aim of this study was to assess 13-year effects of colonoscopy on CRC incidence and mortality. And this 13-year time point for analysis was a predetermined time point in the trial. And essentially, the Nordic trial is a trial of 85,000 adults aged 55 to 64 in a number of European countries. And they were invited to one-time colonoscopy screening. And that was the intervention, an invitation, not the actual colonoscopy itself. And I think that's important to point out, to no screening. And the trial was randomized 2-to-1, so two times as many patients in the no screening arm. And these are in countries that at the time did not have any colorectal cancer screening efforts underway. This, again, was a 13-year outcome on CRC incidence and mortality, and they had an intention to treat primary analysis and then a secondary per protocol analysis. And these two graphs show the colorectal cancer incidence and the intention to treat on the top and the per protocol analysis on the bottom, with the screening being in the red and the no screening in the blue. And in the intention to treat, there was a modest reduction in incidence of 19% relative risk reduction versus 45% in the per protocol analysis. And I think this highlights an important thing, that the benefits of any program depend on the uptake, and only 42% of patients invited to participate underwent colonoscopy in this trial. Much different if you look at the earlier sigmoidoscopy trials where the uptake was much, much higher. And so perhaps that's why we're seeing modest results. And again, on CRC mortality, again, in this trial, just like the 10-year results, there was no statistical significant difference in either the intention to treat or the per protocol analysis in mortality. And I think when they designed this trial, which was actually 20 years ago, these trials take a really long time to design and then a really long time to implement, because you're recruiting patients and then you're following them forward for 10 or 13 years. And when they designed this trial, they had estimated that mortality would actually be double what it actually was due to better treatments for colorectal cancer and other improvements in care. And it's also important to note that the effect of the effect of invitation to a single colonoscopy, not the effect of longitudinal screening. So we would hope that we would see better results with a longitudinal screening program. And there are trials ongoing, even the US and the VA population, to speak of one, that hopefully will give us, I think, more promising results. And I think so. I don't think that this trial evaluates the effectiveness of an invitation to a single colonoscopy, not the efficacy of colonoscopy itself, and that the observed benefit reflects participation in downstream care, not the full impact of optimal screening and surveillance. But I think we may hear about this trial because it is one of the few RCTs looking at colonoscopy published in a high-profile journal. On to the next abstracts I'd like to cover. How do we measure colonoscopy quality, ADR? And I used to think of that in terms of my own ADR, and I would get my benchmarks and be aiming for a higher ADR. But now I think it more globally as a division chief of how is my group doing? Are we offering the highest quality of care? How do I improve care in some individuals or endoscopists that have lower ADRs? And is there a ceiling in ADR, and all these questions that come up? So I chose two papers on ADR that I think add to our incremental knowledge about ADR as a quality indicator. And the first one was entitled Endoscopist Performance and Subsequent Colorectal Cancer Risk Across Baseline Colonoscopy Findings, presented by Jeff Lee and the group from Kaiser Permanente, Northern California. And the second one was Adenoma Detection Rate in Association with Risk of Late Onset Post-Colonoscopy CRC. This was presented by the Dutch screening program. Why these studies? Again, they provide further evidence on the importance of quality of endoscopy as measured by ADR. And as I just mentioned, ADR is a key colonoscopy quality metric, and it's inversely related to colorectal cancer risk after a negative colonoscopy. But there are remaining questions that these abstracts addressed, including how does risk vary across baseline colonoscopy findings, and how does ADR predict late post-colonoscopy CRC? So this is the Kaiser Permanente study, where they had about 138,000 individuals who underwent a first screening colonoscopy, and they grouped them into four groups. The high-risk adenoma group, which were those that had advanced adenomas or greater than or equal to 5 adenomas. The intermediate risk group, which was 2 to 4 adenomas, the low risk group 1 to 2 adenomas, and then the no adenoma group. And they had data to follow these individuals up throughout the period of 2011 to 2023. And again, they compared the ADR, various ADR cutoffs across these different baseline endoscopy findings from the no adenoma to the high risk adenoma group. And they used ADR cutoffs of 25%, 30%, and 35%. The top graphs are the CRC cumulative incidence in percentage across these different groups, with the low detectors being in yellow and the high detectors being in the blue color. And as you can see, those that had have a higher ADR cutoff based on these cutoffs their patients had a lower cumulative risk of colon cancer over time, and that it was seen in the ADR cutoffs across these different 25, 30, and 35%. And in fact, if you look at the cumulative incidence in high detectors in the high adenoma high risk group, for example, the high risk group 35% cutoff, the cumulative incidence was 0.6, which was similar to the cumulative incidence in the low detectors in the low risk adenoma groups. And the same was seen in their adjusted analysis looking at relative risks. So overall, the absolute and relative risks were significantly lower when endoscopy was performed by a high ADR endoscopist compared to a low across all colonoscopy findings. Moving on to the next study, the adenoma detection rate and the risk of late onset post-colonoscopy colorectal cancer. This is in the Dutch FIT screening program where they had 420 colonoscopies performed by 521 endoscopists. And of those, 188,000 were recommended to return in 10 years, and they focused on these individuals. And in those individuals, there were 138 post-colonoscopy colorectal cancers detected beyond 4 years. And the motivation of this study was that the World Endoscopy Association has designated colonoscopies beyond 3 years to most likely be due to de novo polyps versus incompletely resected polyps. And here are the results in one slide. Here, looking at ADR that was dichotomized, looking at the top quintile of individuals who had an adenoma detection rate of greater than 66.8 compared to those in the lower quintiles, groups 1 through 4. The median adenoma detection rate in this study was 61% with an interquartile range of 57 to 66. But these studies were done in the FIT screening program. So these patients were presumably those that had a positive FIT in which we would expect a higher ADR. But nonetheless, even comparing when comparing group 5 to groups 1 through 4, the risk or the cumulative incidence of colon cancer beyond year 4 was decreased in those with a high ADR, indicating that high quality colonoscopy is protective against post-colonoscopy colorectal cancer in the long term, and suggesting that these cancers arriving after 4 years may still be attributable to missed polyps. And again, in my mind, these are high adenoma detection rates, even for positive FIT patients, indicating that maybe higher is better. We have patients in my group, providers in my group who have adenoma detection rates over 60%, 70%. Maybe they are doing good. Even though we think they're just picking up incidental small adenomas, maybe the effect is greater than that. So take-home messages from these studies is that ADR reflects meaningful differences in long-term colorectal cancer risk. And I think as importantly, these data support more individualized surveillance strategies that incorporate both baseline findings and colonoscopy quality. We have a big backlog of colonoscopies, my institution, and we are using a number of approaches to try and reduce that. And one of them might be that someone with a really high ADR, when they find a small polyp, and right now the range is 7 to 10 years. Everyone chooses 7 years, but maybe some of those people could choose 10 years. Same is true for the other recommendations which cover a broad range of years. And I think there seems to be a tendency to pick the lower and to even go beyond that. Oh, I'm going to say 5 years because I'm nervous, or maybe the prep wasn't perfect, but really to give individuals who have a high ADR the leniency to pick to go on the longer end of those surveillance intervals. Moving on to the next study, how do we improve polyp detection? I know there are a number of new technologies out there, but this one caught my eye. And that's called Guiding Endoscopist Gaze Towards the Screen Periphery, Enhancing Colorectal Cancer Adenoma Detection, a multi-center randomized controlled trial. This was out of Japan, 4 centers, mostly in Tokyo. And how do we improve adenoma detection? We know, again, if you look at a graph across an institution, those can range by more than 40%, the adenoma detection rate. And why is that? And how can we improve that? I think we just said that adenoma detection rate is strongly associated with colorectal cancer outcomes. And there have been many efforts to improve ADR, probably the most well-known withdrawal time. But even for the same withdrawal time, endoscopists will have differing ADRs. There are a number of devices we may hear about later today, and the use of artificial intelligence. But what else can we do? And does human visual behavior play a role? Does where and how we look impact what we detect? And I think that's true when you have like AI devices that are only seeing what we're seeing. Where we move the scope and how we see probably makes a difference. And so this is a really interesting study at 4 institutions in Japan, where patients aged 40 to 90 undergoing colonoscopy were randomized 200 to the intervention group, where they got this device that I'll talk about, and then 200 to the control group. And this was an eye tracking device that sat just under the monitor and was tracking endoscopist's gaze and gave a different tone when the gaze was in the periphery than it did when the gaze was in the center. As you can see there on the right, the yellowish orange is the periphery gaze where the gaze was targeted, and the green dot is where the endoscopist was gazing. And when it was within that area, they got a high-pitched sound. And when it was outside that area, a low-pitched sound to indicate that they needed to look towards the periphery. And what they found was that adenomas per colonoscopy improved with this intervention, and that was the primary outcome, but also secondary outcomes, including adenoma detection rate, 53% versus 39%. They actually showed that peripheral gaze did improve, and that the gaze in the periphery was about 34% in those that received the intervention versus about 26% that did not. And other things were also improved: polypectomy, polyp detection rate overall. Interesting, flat polyps were detected more often in the individuals that had this intervention, but not sessile serrated lesions, which could be a power issue. But I would think that this device would help individuals to see those flat lesions that don't protrude into the lumen, but that isn't what they found in terms of sessile serrated lesions. And it did not take endoscopists any longer when they used this device than not. So take-home messages: adenoma detection is influenced by visual scanning behavior and probably by other aspects of our vision as well. If you look at individuals, ADR does not always map to sessile serrated lesions, indicating that there might be something different about how we do endoscopy or how we see the colon that makes a difference, and that this visual behavior, at least the scanning behavior, is modifiable, and that systems that change gaze behavior may improve adenoma detection. This is a proprietary device, but I can see it added to endoscopy systems. And there were questions in the audience about how annoying it might be to be hearing this low or high-pitched. They said that endoscopists overall accepted this fairly well. And then lastly, what is the broader impact of endoscopy? We think about endoscopy outcomes in terms of patient outcomes, and sometimes we think about them in terms of financial outcomes. But what about the environment? And this is a hot topic, and I'm really thrilled to present something done right here locally by UC Irvine. This was presented twice at DDW, both once in a session that was geared towards environmental impacts, and another actually in the plenary, presidential plenary. So environmental impact of a tertiary center endoscopy suite, a comparative life cycle analysis. And again, we know endoscopy is resource intensive, and I always cringe. We use those disposable gowns, and the whole bin fills up just in one of my endoscopy sessions. And I'm one endoscopist across the globe. And so as we improve quality and outcomes in endoscopy, we also need to consider its environmental impact. And endoscopy, as which I learned putting this together, is the 3rd largest contributor to hazardous waste in hospitals, behind the OR and the emergency department. And it's because we use single-use devices a lot. We have high procedural volume. We reprocess our instruments, and we have complex waste disposal processes involving both hazardous and non-hazardous waste. So in this study, 3 days, an average of 3 days of the whole input of endoscopy unit that did approximately 46 procedures per day at UC Irvine were in a really detailed way cataloged, and through this process of inputs and outputs, the environmental impact was tabulated both for general GI procedures and interventional GI procedures. And this slide is the outcomes of that. And the blue bar are the general GI procedures, and in the orange bar, the interventional procedures. And although the impact here measured in kilograms of CO2 equivalents per day was higher in the general GI procedures. The volume was also much higher, indicating that the impact of interventional procedures on the environment is actually higher than general GI procedures, in part due to processing. And the largest environmental inputs are on the table were energy, bedding, and water. And I think we could probably all just pick that off the top of our heads when we think about what we go through in a day of endoscopy. And to put these measures into some context, I asked AI, and one household of 4 would use this amount of energy, 4,000 kilograms of CO2 per day per year. So in a modest size endoscopy unit, every day we're using a year's worth of energy, or the amount of energy taken to drive 2 cars for a year. It's a pretty big amount if you add that up across the globe. And what I was most impressed about in this study is that there are already some interventions going on at UC Irvine to improve this footprint. One is to put solar panels. The other is to turn off parts of the buildings that aren't being used. The energy to maximize the capacity of reprocessors, making sure that the maximum number of scopes go into a reprocessor at a time, using as much reusable equipment as possible, and recycling when possible. And we're trying to recycle in our unit, but it is quite complex, and human behavior is tough. I always cringe when you see like a restaurant that has recycling, compost, and trash, and you see that, even at a hospital, doctors can't figure out where to put those things. So it's all complex, but I think it's something that we need to put our energy into. So in take-home, endoscopy carries a meaningful environmental footprint, and targeted changes in practice can reduce our impact without compromising care. So thank you very much.
Thank you, Lisa. Great talk. It's now a pleasure to bring back a friend of the SCSG and a longtime contributor to this meeting. Jim Buxbaum is professor of medicine and chief of the Digestive Health Initiative at USC. Come on up, Jim.
Always a great pleasure to see everyone at this. Always my favorite meeting of the year. So I had the honor of reviewing and working with Lisa on the lower GI abstracts, the best of DDW. Kind of 3 areas that I looked at was the impact of artificial intelligence on colonoscopy performance and training, a few of the performance metrics, although Lisa hit that pretty hard, and then also some lower endoscopy resection pearls. How do we deal with these lesions as gastroenterologists? So we've come a long way, from HAL and the 1970s to ChatGPT, and indeed CAD-E, of course, is computer-aided detection is really here in our units already. We're looking for it identifies patterns we can look at. CAD-E, of course, CAD-X rather is what we're hoping for in the future. Would be computer-aided diagnoses, which are not quite FDA approved yet. And these things all really kind of show these boxes that signify what we're looking for with CAD-E right now. So there are several big abstracts that came out of DDW this year. Jackie Ho was looking at whether there are blind spots of AI. And the idea is, should you combine AI with other technology to expose the mucosa? And then they point out this was a polyp that was missed, but then when you used a ring over the scope, that you could see it. And so they addressed this question through a multi-center study in Asia and Europe, looking at the combination of a CAD-E system, EndoAid, which is the Olympus one, or CAD or EndoAid combined with EndoCuff. And that's basically combining it with this cuff over the scope. And so they launched this in a large number of about 1,500 patients. And they did indeed find that the combination of AI plus mucosal exposure improves performance overall, and especially for left colon lesions and for flat lesions. And the idea is that these exposure devices may help open up the folds in the sigmoid. And so AI alone probably isn't enough. You probably need to add other devices to really optimize what you need to do. There was also a great study called NAIAD coming from the UK. And the idea, for those who have done work in this area, that the real world experience of AI sometimes isn't quite as good as what you see in the randomized trials. And so what they were looking at was a large, really innovative study where they did a step wedge cluster RCT. So they basically took a very large number of doctors, randomized to using AI for a while, then randomly send them back to not using AI, just to see what would happen in about it was 19 sites and 90 endoscopists. And what's interesting is that there was a substantial increase in adenoma detection rate while using AI in phase 2 of the study, but that it did drop off in the third phase. So this sort of brings this question of de-skilling. If you use AI all the time, will you start to become less skilled? So they really looked at that and they studied what could be impacting this. And what they found is actually people that were low detectors at baseline actually had sustained improvement, in the third phase. Whereas those that were pretty good to start with actually kind of had a drop off afterward and maybe didn't have sustained improvement, or maybe even had a little less than they originally were. So it shows this skilling question is a real one and needs to be addressed more. Another thing is that it looked like endoscopists that had less experience, probably, or were younger. It may have something to do with the younger brain of a young endoscopist. I'm kind of in the middle now, but or in the amount of experience may be more amenable to learning and interacting with AI. So I'm sure much more on this in the future. And then AI and training is this month's GIE. One of our fellows, Pat Chang, and we had a nice paper, about 1,000 patients we randomized on this topic of AI and training. But this was hot at DDW as well. So in the presidential plenary, there was a talk on about 4,000 patients and looking at the impact of AI and training. And they're looking at the combined adenoma and cell detection rate. And this was from University of Alabama, and also using a big national cohort as well. And what they did find is that AI did improve the ADR. It also improved the SSP, that's the sessile detection rate, and also the ADR plus SSP, which was their primary outcome. Interestingly, they looked at patterns, and for the overall major outcome, we saw a lot of improvement with really first-year fellows, but it kind of dropped off later. So those senior fellows are pretty good at finding polyps. But what's interesting is that the adenomas, the classic adenoma detection rates, what really fell off, but actually the second, third years improved a lot more with the sessile. So it kind of shows there's likely going to be patterns. The SSLs are harder to detect. You see Sarah Shabani in the audience. He's brilliant at these. But later in your training, you might need, a little bit more help finding these lesions. It shows where AI could have a bigger impact in training. And this was our conclusion, that there was overall increase, but is substantial gains in training. But again, there's some nuance over the period of training. Okay, so we'll shift a little bit now to some interesting quality metric work that came out at DDW. So Audrey Calderwood at Dartmouth had a really interesting GI quick study. So she used a registry of a huge number, 15 million colonoscopies done by 4,300 endoscopists. And what was interesting is for female endoscopists, a greater proportion of their patients are women, so it's 70%. Whereas it's about 50% for male endoscopists. But this does reflect that overall the colonoscopy workforce is only 18% female. And they had a longer withdrawal time. And initial results suggested that male endoscopists had a better performance. It was 40.9 versus 40.6 for female endoscopists. But what was very important and nuanced and was interesting about this talk was it really reflected that the patients of the female endoscopists are much more predominantly female, and they have a much lower adenoma rate than males. In reality, female endoscopists actually outperform males in both categories, both with female patients and male patients. And the take home here is when you look at this data that's published on endoscopist performance, you really do have to look at patient sex and proportionality to get a true representation of what's happening. There's also a nice abstract from a former UCLA grad who used to be around at this meeting quite a lot, Phil G., and he's at MD Anderson now, and did an interesting study looking at characterization of polyps and reports and how that has an impact. And they looked at basically the MD Anderson experience of patients that were seen by a colorectal surgeon referred back to endoscopists for resection. And what Phil found is that a lot of the polyps were described as a mass, but were actually polyps. And there was a high rate of misclassification. And indeed, this can have an impact given that colorectal surgery for polyps has significant morbidity and mortality. And really advocate using the Paris, or the Borman classification of polyps to really correctly assign these. This is an example. This is a true Borman type 2 or fungating polyp. This needs to be resected surgically. Versus this was one that was called a fungating mass, but in reality, it's just a sessile spreading polyp, and this could be removed endoscopically. And so careful description, really may guide appropriate decision making, and he advocated its use as a quality metric. And of course, Tanya Kaltenbach, who always has something interesting to say at DDW, presented the VA experience looking at cold snare use. It's now a quality metric to use cold snares for 90% of polyps less than 1 centimeter. And she looked at basically the VA database for this in her talk and built out a multivariable model looking at the appropriate use of cold snare for those polyps less than 1 centimeter. And what Tanya found was that there was quite a bit of variability. So in the West Coast, we're doing pretty good, and in the Midwest, the rate is close to 90%, but in the Southeast, it's 77%. It also matters whether it's surgeons or endoscopists. Surgeons only use these for about 40% versus gastroenterologists, 85%. And it also has to do with training. Those that are more recent graduates are using the cold snare more. And indeed, this is true. Some of our fourth-year fellows have definitely encouraged us to use cold snare in our unit as they've come out of good training programs around the country. So the idea is that this may help targeted quality improvement projects in this area. And finally, Asma Showkat reviewed the newest guidelines. I think are important to review it, and to hit on these. So there's a new benchmark of ADR. It is now 35%. It should be greater than 40 or greater in men, greater than 30 in women patients. And it should be greater than 50 if the patient has an abnormal Cologuard stool test. There's also now, for the first time, a serrated sessile lesion rate, SSLDR. So the benchmark is now 6% for this. Oops, okay. And it's now advocated that all endoscopists should have a report card, which really lists your metrics. You can see here, this is actually Asma's report card. She's pretty good, 90%, but not perfect though, but pretty good. And what they've shown in multiple trials now and also systematic review is that just having a report card leads to improvement in ADR performance. And some units do post these, in surgical centers on the wall. She advocated prep now, either split prep or actually prep the day of the procedure. And the new concept is really runway time. You want to minimize the runway time of the prep before the procedure, but you still need to have about 2 hours just because of the anesthesia considerations. And the new metric is that if there's an adequate prep, it has to be done within 1 year, ideally sooner, but there's not really that much wobble room. And Asma also emphasized the withdrawal time has now been increased from 6 minutes to between 8 and 9 minutes. And it's based on studies that show that the optimal sweet spot is in the 8 to 9 minute range. Beyond that, it actually falls off, and before it's not quite good enough. And it's also important to have good technique, which really is segmental inspection, looking at every area of the colon versus just looking at the cecum and quickly pulling out. And she pointed out that even with the time isn't even so important, but it's really the technique score that matters. A few other points that they're emphasizing is now either devices like the endocuff or AI should be considered as well, both technology and new devices to optimize performance. Okay, so now we'll shift a little bit to removal. There's 2 great sessions, one really on EMR where all the masters came together and discussed all the latest approaches. I thought this was helpful, and then one of the ESD we'll talk about next. So what was interesting, Michael Bork, gave an interesting talk, and we were, at least I was trained in fellowship, we see pedunculated polyp to do a hot snare. Really now for less than 10, this should be done with a cold snare. And the idea is to go close to the colon wall, squeeze first, and that basically desiccates the stalk so it won't bleed, and then remove. And if it do bleed, put a little gentle pressure with the scope first. And this helps avoid using unnecessary clips. It should be less than 3% for the clip rate. For larger ones, it's still recommended to do cautery. It's recommended though that emphasize it's very important to go very low on the stalk, given the risk of invasion, and also to use clips or have a low threshold to use clips with these. For sessile polyps, even up to 20 millimeters, it's now generally, the approach is slowly being recommended to use cold snare for these and even do overlapping cold snare. And the big concept at the meeting from number of abstracts is that you want to have a wide range, a wide margin with cold snare. Given its low risk of bleeding, low risk of perforation, you can actually go way around the polyp. And so if you have to do overlapping applications, this allows you to get clearance without a lot of risk. I'll skip that. And then for sessile ulcerative polyps, again, they really recommended this use of cold snare. The one exception is when it appears dysplastic. And there's a lot of emphasis in several abstracts. A dysplastic SSA, this is a standard sessile ulcerative adenoma, but a dysplastic one has a look of the flat pancake look, but then will have glands or complexity seen. And with these, it is recommended to still do the hot EMR, kind of classic EMR approaches. And then it was recognized that there is limits. There is, there are limits to what you can do with EMR. And this is one of ours. It could be really large. Some of it's really either really large or really indented. You can see you can leave polyp. Then have to deal with this later. So that's where ESD comes up. So there was quite a bit at the meeting on ESD. I think the most important, one of the most interesting sessions was they got all these emerging masters of ESD. Hironi Yamamoto gave a couple of talks. He's the inventor of ESD. And the concept of ESD that started this was that you can get very large unblocked resections. And he pointed out he invented this long cone to kind of begin the field. And initially they would just, raise a huge raising a lesion. He'd use this cone then to dissect and then use a huge snare. But ultimately this evolved into the whole cadre of knives that we now have. And I think for this group in Southern California, I think what's important is to start to learn the lexicon and these terms, because you're going to see more and more papers, but also as this emerges in the real world. So Hironi Yamamoto and Edward Despot talked a lot about pocket ESD. So pocket ESD, there's a couple of abstracts on it, but the general idea is you go in underneath the lesion and you keep the pocket so that it stabilizes you while you then dissect all around the lesion. And they recommend this term of water immersion. So it's not exchange, it's not flooding, it's a very gentle water flow to kind of clear out the material, and it should be done with saline to allow conduction with your knives. So water immersion and pocket is a approach. The conventional ESD, of course, is we cut around and then that's how we all learn to do it, and then dissect off the lesion. Now the pocket's recommended. The other one is the tunnel, is where you go underneath, kind of like we do with POEM. You go all the way underneath the lesion and create a tunnel, and then you can widen out your tunnel and remove the lesion. Now, bridge and tunnel, you're not talking about New York, but this came with Faith Aslan and Shamai Okoli gave quite a bit on this. And the idea of these tunnels is if you have a huge lesion, that circumferential, it's kind of like a snake skin. You can like peel the whole colon out. And then there's these gross videos where you could pull the whole colon wall out, these special graspers, or you could pull the whole esophagus out. But the idea with this is you can do multiple tunnels, and then you connect the tunnels in the submucosa, which can allow basically a huge amount of polyp to be removed safely, as long as it's not cancer. And then a bridge is basically you do almost a tunnel, but you don't actually complete, you don't go all the way to the other side. And that's kind of what the bridge looks like. So you'll see these terms come up. Finally, there was a couple talks by Dennis Yang looking at traction. And traction is a concept, of course, of triangulation or surgical terms. It's where you basically pull the lesion, so it allows you to work and dissect and gives you tension to do what you need to do. And it's kind of like with cutting a steak. Currently with ESD, if you do the classic circumferential approach, it's kind of like you're trying to cut a steak with just a knife. But the new idea is you want to pull the steak so you can access it. And that's what these techniques are. Of course, pocket tunnels are really making traction away. But more of the approaches like that they're currently using, and we utilize these in our lab right now, as we use bands where we put a clip, get a band, go somewhere else, clip that band in place and use traction, cut, or we put a string and we come out the mouth and we cut. But the problem with these is that as the case goes on, the traction decreases. And so it's recognized now as probably one of the biggest areas for robotics and endoscopy. And there was a couple of talks on this. So basically the robotics, as you work the ESD and you remove the tissue and you loosen it, the robot will know to tighten up the traction to countermand that, so you don't lose the traction in the case. So we have best of DDW. Artificial intelligence does improve ADR, but there's certainly a role for mucosal exposure devices. These are synergistic with AI. They help you see the fold, and the AI helps you identify the polyp. There is a real world impact, but there is also a risk of de-skilling for endoscopists. There's a role in training, and it's graduated. It probably helps you find the basic polyps your first year, but then it may help you find the really flat, Sarah Shabani polyps later in third year. Quality improvement. ADR is obviously critical, as Lisa beautifully described in the last talk, but it's important to break it down by the proportion gender in your practice. If you have more women patients, your ADR will be lower, and so you shouldn't be dinged for this. Cold snare is here to stay. It's now a metric for small polyps, should be used greater than 90% of the time. Biopsy is really out. There's evolving metrics. Again, the cold snare, 90%. ADR, sorry, should be 35, not 34%. And there's now cell-saturated lesion detection rate should be 6%. You should be doing an 8-minute withdrawal, not a 6-minute withdrawal. For EMR, cold EMR with that cold snare is now your workhorse to use. You should do wide margins though. It's quite safe, but the way to make sure you don't have a lot of recurrence is to go pretty broad around your polyp. Hot EMR is still the way for bulky or pedunculated polyps, but cut low on your stock and consider clips. And for ESD, there's definitely an evolving science and art, a whole new lexicon that I think we all need to learn. There's pockets, saline immersion, tunnels, bridges, triangulation, and traction. So it's a great meeting, and thank you all for having me here again today.
Thank you, Jim. Okay, now it's a pleasure to bring Lisa back up to tell us about paradigm shifts in diverticular disease, largely based on her work. Thank you.
Yeah, thank you very much. There was a little bit at DDW on diverticulitis, but it still is not taken hold in terms of the number of groups or people doing research in this area. So shout out please, it's an area where there's so much that we don't know and we need a lot more research. So some of this isn't so new, but I feel like when patients come to my clinic or I have patients referred to me, this disease is one in which you can see how long it takes from something new in the literature to trickle through and overcome what's longstanding dogma. So this talk, I'll go a little bit into theories of pathogenesis and disease mechanisms, because understanding that, or at least proposing new theories that have some support, have changed the way that we look at this disease. And then I'll move on to management of uncomplicated diverticulitis and walk through a patient that we might typically see in our clinics, both treatment of that episode and then whether or not we recommend colonoscopy, and then talk about prevention of recurrence, which is probably another group of patients that we're seeing in our clinic. And then a little bit about SCAD and SUD, two acronyms that are thrown around. And I don't know if either of these diseases exist, but I want people to know a little bit more about them so they don't just use these terms inappropriately. And so old thinking about diverticulitis was that it was all due to low fiber intake, and individuals who had low fiber intake had harder stools and slower transit. And that led to both increased pressure within a diverticulum, but also trauma. And that's where the theory that nuts and seeds and popcorn might provoke diverticulitis. And that this disease was either treated with antibiotics or with surgery, and there was a really low threshold for patients to be referred to surgery based on understanding of the natural history of the disease. Now we have data that suggests that maybe that way of thinking about the disease isn't true. And one is a study of nuts, corn, and popcorn. One of the first studies I did, it's now, like I said, very old. And here's the adjusted relative risk on the y-axis, and then nuts, corn, and popcorn. And this was in a very large group, 51,000 men that had over 20 years of follow-up data on diet, other covariables and outcomes. And in fact, individuals who ate more nuts or more popcorn were less likely to develop diverticulitis. So making us think that maybe it's not all about trauma to a diverticulum, or maybe it's not all about nuts and popcorn. And then, constipation, there've been a number of studies now. I showed two, one by Ann Peary looking at diverticulosis. They did surveys of individuals before they underwent screening colonoscopy, and then they looked at findings of diverticulosis or not. And in fact, people who strained at stool, had incomplete bowel movements or hard stool, were not more likely to have diverticulosis on colonoscopy. And likewise, individuals who reported fewer bowel movements per day or per week were actually less likely to have future diverticulitis than those who reported more than one bowel movement per day. So I think it's important for us to start to think about the pathophysiology, but also many patients with diverticulosis are quite paranoid about their bowel habits and think they need to take a laxative to prevent diverticulitis, and that's probably not true. And then an update on the natural history that's, I think, also changed our thinking about this disease is that although most adults will develop diverticulosis as they age, and all of us who do colonoscopies know that, very few will actually develop diverticulitis. It used to be thought based on barium enema studies that about 25% of patients would develop diverticulitis, but it's actually a much lower number. The best study out there is by Brennan Spiegel using a VA population in Southern California. And that of those that have diverticulitis, about fewer than 15% will develop complicated diverticulitis, meaning perforation or abscess. And so understanding this disease as being less aggressive has led us away from a more aggressive way of treating the disease. So new thinking is that diverticulitis is a very complex disease that likely has to do with genetics, diet, lifestyle, medications, an altered microbiome, a pro-inflammatory state, not only in the gut, but systemically. And so it's a disease of inflammation, not infection, and that the course is not aggressive. And this has led us to medical versus surgical treatment. And so more and more of these patients are going to end up in our clinics. And that because it's not an infection, we're sort of taking an anti-inflammatory approach versus an antimicrobial approach. So to start with the first case, this is a 33-year-old male with no significant past medical history who comes to my clinic with left lower quadrant pain, or actually to the emergency department. We don't usually get the incident. That's the primary care and the ER. He had a mildly elevated white blood cell count. He was afebrile, no peritoneal signs. He reported mild constipation since onset. And I think that's where this correlation between constipation and diverticulitis comes up, because the colon does get swollen in diverticulitis, and patients often during the episode are constipated, but that doesn't mean that constipation caused or was related to the diverticulitis. But in this case, I want to go over our antibiotics necessary. Our thinking really has changed over the last 10 or 15 years in this area. Based on multi-center trials, all of them done in Europe, Europeans are more skeptical of antibiotics. And so I think it makes sense that they were the first to try this based on observational data. The patients who didn't receive antibiotics tended to do well. And I'm presenting just one of the randomized trials here, the OVID trial of CT-confirmed uncomplicated diverticulitis. So we're not talking about an abscess or a perforation. And they looked at outcomes including abscess and recurrence, which I show here in the top table. And they were no different between the 300 and so patients who didn't receive versus those that did. And if you look at the bottom, these were graphs that looked at symptom resolution, including pain score, temperature curve, and abdominal tenderness, with pink being the group that received antibiotics and the blue dotted line, no antibiotics. And as you can see, those curves basically exactly overlap, indicating that antibiotics didn't have any impact on the course of the disease or improvement in symptoms. And 4 trials in this meta-analysis of about 1,800 patients found the same, with a fairly high, either high certainty or moderate certainty, that antibiotics do not impact mortality, surgery, complication risk, readmission, or recurrence. So based on these data, several society guidelines now recommend that selective use of antibiotics for healthy immunocompetent patients with uncomplicated diverticulitis. And it's important to point out immunocompetent and healthy. The ACG guideline will be the most updated guideline and will be coming out soon. So look for that to guide all aspects of care in diverticulitis. But what about high-risk patients? I think it's hard to do nothing in a disease where patients present with pain, fever, et cetera. So we really need to understand better what patients we would select an antibiotic, and certainly in immunocompromised patients, in frail or elderly, although many of these trials did enroll patients up to the age of 90. Significant comorbidity, pregnant patients that were excluded from all of these trials, or no reliable follow-up. In these individuals, they're at higher risk of adverse outcome, and I would tend towards antibiotics. And then severe presentation, even though many of the trials did do a stratified analysis of those that presented with higher white counts, higher temperature, higher CRP, and found similar findings. In general, people who really seem to be presenting with inflammation, I tend to treat with antibiotics, certainly those with signs of sepsis, even if they don't have complicated disease on CT. And part of that is because we know that the more severe the inflammation is on the incident attack, the more likely they are to go on to have recurrent disease. And so maybe like in IBD, perhaps if we treat early, we prevent some of that downstream complications. And certainly in people with smoldering or refractory disease, and I could devote a whole talk on that, even though most of it's just from my experience, there's not a lot of data, but in individuals who tend to have disease that lasts for a long time and doesn't go away, I use antibiotics. And which antibiotic? Well, there are really no head-to-head trials. And now that there are trials indicating we don't even need to use them, I doubt there will be. But I do choose my antibiotic based on its safety profile. In this study by Ann Purian group, using a large nationwide administrative database, looked at outcomes both of diverticulitis and safety in comparing amoxicillin clavulanic acid to metronidazole plus a fluoroquinolone, and found that the clinical risk of hospital admission or surgery was no different between these two groups, but the 1-year risk of C. diff colitis was higher in fluoroquinolones, particularly in elderly patients. So I do try to avoid repeated courses of fluoroquinolones or fluoroquinolones overall in older patients. So what do I do for my low-risk patient? Most of the patients that are seen in our clinic have had more than one episode, but they haven't. I think CT confirmation of the disease is important. And we don't have the best studies to indicate this, but I think we do have studies saying that when a physician thinks it's diverticulitis, they're right only 65% of the time. So about 45% of the time we're wrong, and we don't want to be missing an alternative diagnosis. So once we are pretty sure, and that's not for recurrent events, patients tend to know this is exactly the same as it was the last time. I don't think we need to be repeating CT scans for every episode unless it seems different or more severe and we're worried about complications. So once we're pretty sure it's diverticulitis, I think there's a lot of shared decision-making. I talk about the trials. I talk about the risks of antibiotics. There are patients that want them, that feel that they get better with them, and I generally give them antibiotics in that case, but I start with a really short course because we're not treating inflammation. What we're likely doing is altering inflammation, the microbiome, et cetera. And I tend to use amoxicillin clavulanic over fluoroquinolone-based regimens. And if someone's not better at 4 days, I might extend, but I don't just give them a 14-day course of antibiotics. And then for pain, I use antispasmodics and acetaminophen, as I'll show in some upcoming slides. NSAIDs and opiates are both related to diverticulitis risk, and in particular perforation. So I really try to avoid them. And I use a clear liquid diet for 1 to 2 days. There's only been one study on diet, and that was a study where they let people eat whatever they wanted, and then they compared the outcomes to outcomes reported in the literature. So we really don't have data on this, but I think patients don't feel well. I think their colon is swollen, it's inflamed. They often have, systemic inflammation as well, and so they feel better on a really gentle diet. And then I ask them to advance as tolerated, with the ultimate goal being a high fiber diet that I'll talk about later. And a special case that I think can sometimes be classified as uncomplicated is microperforation. And we need to be careful when we read a CT report to be looking for that. It's about 15% of cases of diverticulitis, and about 18% evolve to an abscess, and 6% of those require surgery. So in those patients, I do follow them closely. I do treat with antibiotics, and I have a low threshold for repeat imaging if their symptoms don't go away. So continuing on the case, another thing that we tend to do traditionally in patients with diverticulitis is to recommend a colonoscopy. So this 33-year-old who otherwise would not qualify for a screening colonoscopy, he's asymptomatic. Should we recommend a colonoscopy or not after his incident episode of diverticulitis? And our guidelines have traditionally been that, yes, we should do a colonoscopy in everyone who has an episode of diverticulitis. And this was based on a number of studies that showed that the risk of colon cancer was higher in those who had an episode of diverticulitis. In this study, the odds of colorectal cancer on the y-axis, and then the number of months following out on the x-axis. And when you just look overall, it does look like, wow, patients with diverticulitis have a high rate of colorectal cancer. And there are a lot of risk factors that overlap. And maybe for a number of other reasons, they might be at increased risk. But when you look at the timing, most of those colorectal cancers are in the first 6 months. And it turns out that most of those cancers were actually a misdiagnosis of diverticulitis when colon cancer was actually present. And the most recent best study we have is a meta-analysis of 31 studies and over 50,000 patients that new guidelines are based on, that broke down patients into complicated and uncomplicated disease. And there have been other studies that confirm this. And the risk of colon cancer was 8% in individuals with complicated diverticulitis versus 1.3% in those with uncomplicated diverticulitis. And these studies use different methodologies, but the overall recommendation based on this work by the American College of Physicians and the upcoming guideline by the ACG will be that after an initial episode of complicated left-sided colon diverticulitis, we should do a colonoscopy, but in uncomplicated disease, only if the individual is not up to date on screening or has concerning features such as, the symptoms are not going away, the colon looks unusual on CT. And I think these guidelines haven't necessarily trickled out to radiology. And often there's a reflex that says to do a colonoscopy, and we're stuck in the situation of deciding whether or not that's necessary. But if the colon really does look concerning on CT, then we definitely should do a colonoscopy. We generally want to wait until symptoms resolve. There's some thought that there's an increased risk of perforation, but also patients are uncomfortable with colonoscopy prep and colonoscopy if they still have acute inflammation. What about recurrent diverticulitis? Again, I think this is what we're seeing mostly in our clinic. So the same patient presents to your clinic with recurrent diverticulitis. He's since had 4 episodes. Every time he said he felt pretty much the same. He knew he was having diverticulitis. He had a CT done for 2 of them, finding sigmoid uncomplicated diverticulitis, same as his first episode. All episodes resolved promptly. In fact, a couple of times he wasn't given antibiotics and he got better, but he's really concerned, in fact, preoccupied with the fact that he might have another episode and have some serious event. He travels around the world and he really is starting to get reluctant to do that. And he wants to know how to prevent episodes and what his risk really is of having a serious event. So we do know that once someone has an episode of diverticulitis, their risk of having another episode, a second episode goes up and a third episode goes up. So when a patient comes to my clinic and they've had 5, 6, 7 episodes, the risk of them having a recurrence is very, very high. And the risk of recurrence is thought to be higher in an individual who's had a complicated episode. And that's really what's driven the surgical recommendations for the patients with abscess undergo surgery. Some of that thinking is changing, though that the data is still incomplete about whether or not the risk is higher with abscess. But this whole idea that this disease is a progressive disease that back in the 80s and 90s and even the early 2000s drove patients to get surgery after a couple of episodes and certainly after a complication is now changed with some of our understanding that perforations tend to happen in the first couple of episodes. So if a patient's had 5, 6, or 7 episodes and they've been uncomplicated, they're very unlikely to present with some catastrophic complication. And the surgeons tend to think that this disease, a lot of the inflammation happens outside the colon, and there's a lot of scarring, and they tend to think, or several surgeons have told me, that this sort of encapsulates the colon and decreases the risk of perforation. Whether or not that's true, I don't know, but the data are that perforation is more likely early on in the course of disease, and I think that's reassuring to these patients who suffer from these unpredictable episodes. So what can we do to prevent the disease? Well, in terms of having a magic pill, unfortunately, we don't have that. There have been a number of things that have been tried, 5-ASAs such as mesalamine, rifaximin, and probiotics. The trials of rifaximin and probiotics were really small and poorly done, and so I don't think we can make much of them. And so far, guidelines don't recommend them. And there have been 6 randomized controlled trials and several meta-analyses looking at 5-ASAs that indicate they don't work, unfortunately, so they're also not recommended. Surgery, there have been a number of trials, although it's really hard to recruit patients for surgery trials. I think patients have an idea of whether they want surgery or not, and I don't know if I'd want to be randomized to a surgical trial. But anyway, this trial done in Europe of 109 patients that they followed forward for 5 years. And these were patients that either had ongoing symptoms or burdensome recurrence. And they looked at outcomes, and I've showed a few of those on this slide. But I like to think of the decision to undergo surgery as there are a lot of upfront complications in the short term versus potential long-term benefits. And in this trial, it sort of shows that. The risk of having a stoma long-term is quite small. At 5 years, only 2 of the patients randomized to surgery had a stoma, but overall there was a large number of patients who required them. And surgery for this disease is complicated. The colon is abnormal, as we can see endoscopically. These anastomoses tend to leak much more than they do, for example, anastomosis for cancer. So there are more anastomotic leaks, more wound infections, et cetera, in surgery of this disease. But the potential long-term benefits, it does seem to be that surgery decreases recurrent diverticulitis, but it doesn't eliminate it. And I'm very careful to tell patients that at 5 years, the recurrence rate in individuals who underwent surgery was still 11%. And if you look at the literature, it's anywhere between 8% and about 15%, compared to 30% of individuals in the non-surgical arm, but in those, 46% actually underwent surgery. So the risk of recurrence is probably higher in this group of individuals who's already got recurrent disease. And quality of life did look like it improved significantly in those who underwent surgery. So I think in the right patient, surgery is an option. It's just a very complicated decision that I'll try to get to in my last slide. We certainly need more evidence to guide us and to help us to structure our conversations with patients. But we do have some things to do, and they sound really basic, but there's a lot we can do to modify diet and lifestyle risk factors for diverticulitis. And most of my research has been in this area. But we know that a lot of things that we eat and a lot of our behaviors increase the risk, including the intake of red meat. Even 2 to 4 servings a week increases the risk. A low fiber diet, sedentary behavior, alcohol, particularly liquor, and really high consumption of alcohol, not your standard couple of drinks per week, smoking, and being obese with a BMI over 30 are all factors that increase risk. And on the flip side, eating a high fiber diet, particularly fruit, for some reason, that we have some data to suggest that fruit impacts the microbiome in this disease in a positive way. Physical activity, and in this disease, it tends to be activity that really raises your heart rate and makes you sweat, not just strolling or walking, and having a normal BMI. And this is a study that was one of my favorite studies to do, and looks at these risk factors in aggregate. Here, the relative risk of diverticulitis and the number of low risk factors, here being BMI in a normal range, eating fewer than 4 servings of red meat per day, eating at least 23 grams of fiber, exercising 2 hours per week, and not smoking. And men, in this case, it was a study of men who adhered to all of these had a decreased risk by 75%, or relative risk of 0.25 for incident diverticulitis. This isn't recurrence, but we think these factors have a similar impact on recurrent disease. And if you look at a population level, about 50% of population attributable risk was due to these risk factors. And as we know, many Americans don't have healthy behaviors, and this is an opportunity to really change people's behaviors. When someone said they have high blood pressure, they don't feel it, they take a pill. But when they're having recurrent episodes of painful diverticulitis, they're more likely to change their behaviors. Medications are perhaps a more easily modifiable risk factor, and there have been a number of them that have been associated with increased risk that I show on this slide. And I have the circle around ones that have been particularly associated with perforation, NSAIDs being the big one. I know NSAIDs are the best way to treat pain from a number of different sources, but many patients take these very liberally. And if we can instruct them to take Tylenol instead, we may reduce their risk of diverticulitis. But not all factors are modifiable. We know that genes play a role. This is an early study done in the very robust Danish nationwide patient and twin registries that indicate that monozygotic twins were at 15 times greater odds of diverticulitis if they had a co-twin that had it. Similar with dizygotic twins, although a lower risk, indicating that there's a genetic component. And that was also true of siblings of individuals who'd had diverticulitis versus the general population. And we now have GWAS studies targeting over 100 risk loci, although we still don't have really specific genes or mechanisms. I think that future studies using genetic markers will help us to risk stratify, but also to identify why diverticulitis happens and how we might come up with better means of treatment. And just a couple words on SCAD, segmental colitis associated with diverticular disease. In my experience of more than 25 years of having a clinic full of these patients, I've actually never seen a case. So if it does exist, it's really rare. I think most of these cases are an overlap with something very common, diverticulitis, with something less common, IBD. But if you look at the literature, SCAD has this specific appearance of crescentric fold disease where you see the ulcerations happening on the colon folds. I've never seen it, but if it does exist, that's what it is. It is not what I show here on the left, which is this edematous erythematous, but not ulcerated. finding. We see that a lot, even incidentally on colonoscopy. That's what diverticulitis looks like if we scope someone with diverticulitis, although often you'll see purulence coming from a diverticulum. So you should not call that SCAD. SCAD presents with bloody diarrhea, much like ulcerative colitis. SCAD, this isn't diverticulitis. You can see asymptomatic diverticulitis at screening colonoscopy. And if you biopsy it, it most likely will show normal findings. So I tend not to do anything for these patients, but I don't label it as SCAD. And then SUD, symptomatic uncomplicated diverticular disease, is even a more difficult term, I think. It's thrown around that people who have symptoms but don't have evidence of diverticulitis, but I don't think we often have the best way of knowing whether we're not always doing CT scans, for example. And in my experience, I don't think CT is perfect for some of this subclinical inflammation. And so when I see someone who has ongoing symptoms, I want to know two disease categories that I think about: irritable bowel syndrome. Although Ann Perry's done some really great work showing that patients with diverticulosis don't have symptoms. So diverticulosis itself shouldn't cause symptoms, but people who've had diverticulitis can have post-diverticulitis IBS, and that is something that we know about. Or they can have smoldering refractory diverticulitis. So rather than give someone the diagnosis of SUD, I want to look for those two things. Do they have irritable bowel syndrome and really don't have any evidence of ongoing diverticulitis? Or do they have evidence of ongoing diverticular inflammation? Because I treat those two differently. So just to follow up on this case, he had no colonoscopy performed because he's a 33-year-old that didn't have any other reasons to have a colonoscopy. He made multiple diet and lifestyle changes. He's eating a Mediterranean diet pattern. He's jogging, going to the gym almost daily. He lost 35 pounds so far, and he's feeling great without any recurrence. But we all know that that doesn't happen. And I know I'm running towards the end of time, but I threw in some slides about the alternative ending when the patient continues to have recurrent events that impact their quality of life. And in this case, as I alluded to in the earlier slide, I really look at it as a risk-benefit analysis. I have a 90-year-old in my clinic right now who has refractory smoldering disease. I really hesitate to refer that patient to surgery. But if it's a 33-year-old and they have evidence of ongoing diverticular inflammation and it's really impacting their quality of life, then I would want to rule out that this is IBS, and that's often a really hard thing to do because there's overlap, and then refer to a thoughtful colorectal surgeon who just won't do surgery on everyone, but wants to think about that risk benefit. And in gastroenterology, I published this figure that I think is how I think about the disease. It's not all evidence-based, but some of it is, that I don't refer this is all for uncomplicated disease, although the surgeons are sending me so many complicated cases, they want to avoid surgery, and I'm trying to figure out what to do in those patients with a large abscess that's not resolving other than antibiotics. But anyway, we should not refer anyone to surgery unless they've had more than 3 episodes of uncomplicated diverticulitis. And then you want to think about, does that really impact their quality of life, both in terms of number or severity of the episodes? We want to make sure, again, that the symptoms are attributable to diverticulitis and not IBS. None of us refer IBS patients for sigmoid colectomy. And then we want to really think about what the risk benefit is, both in terms of their risk for surgery, surgical complications, et cetera, and then refer to a thoughtful surgeon. And so I'll wind up the take-home points. Diverticulitis is an uncommon complication of a very common disorder, so it is common. Most diverticulitis is uncomplicated, and most complications happen early on, which is really helpful for us in lowering the anxiety level in our patients and in choosing less aggressive treatment modalities. We don't need antibiotics for uncomplicated disease, but if you do choose antibiotics, you try to avoid repeated courses of fluoroquinolones in older patients, and I opt for shorter courses versus longer. We don't need to do colonoscopy in everyone, certainly not after every episode of uncomplicated disease, but after an initial complicated episode, or if there are concerning features or they're not up to date on screening. And then diet and lifestyle and medications are modifiable factors, and it really is an opportunity to motivate our patients to change our behaviors. Probably here in Southern California, you have lots of fit vegans, and even if they get diverticulitis, they're even more upset, and you can let them know that genetics plays a role. And there are studies indicating that even in those at genetically high risk, these modifiable behaviors can still decrease risk, and that these are beneficial behaviors for their entire health. And so I think that's the approach that I take to motivating these patients. Thank you very much.
Thank you, Lisa. Is Jim? Yeah, Jim, come on up. We'll do a Q&A. Anybody can approach. A really comprehensive approach, and I like that you threw in the Hollywood alternative ending. We're still waiting for the Marvel post clip, though. Is it coming? No. Okay, question.
Hello, I have a question in regard to colonoscopy, surveillance colonoscopy intervals for patients who have malignancies other than colonoscopy. The current guidelines is like 10 years for patient who has 2 or less adenomas if they have great PrEP, right? But when a person has personal malignancies like others than colonoscopy, would you move it to a shorter interval, like 5 years, 7 years?
I want to repeat the question. Is it that they have
Extra colonic malignancy in a
Right,
patient who
correct.
has adenomas found, would
Right,
you
correct.
change the surveillance interval based on the prior existence of extra colonic malignancy?
Correct.
And not as a part of a familial syndrome or?
No,
Yeah, I think
no.
the important thing would be, and we have John in the building. I am not an expert in colorectal cancer screening and surveillance. Sorry. I might have to defer to John Inadomi in the audience. I don't think that our guidelines ask us to modify based on extracolonic malignancies unless they're part of a hereditary syndrome like Lynch syndrome or FAP or the myriad of other genetic syndromes that have an increased risk of colon cancer.
You're getting a head nod from Dr. Inadomi, so
Yeah.
I think you're
Okay,
good.
thank you.
I looked at the slides this weekend and I thought somebody had an abstract about MTA, marginal thermal ablation after EMR. And I've always thought that that was an interesting concept. I do it now just because I'm told to do it. But I've always thought that if you mark the margins beforehand and you complete the EMR, I don't get the benefit of just burning around the periphery. And I'm wondering, like the one, I think it's Bork's group and other people who are kind of doing, in a way, kind of selective cohort comparisons, and like they'll cut out 5 years and they'll do it very early versus most recent data, which to me is the learning curve with EMR. They've gotten way better at it. And I'm just wondering if you do it and if you really are convinced that it adds benefit versus just doing a wide margin, like you referred to with cold snare. I would do it with hot snare as well. I mean, you lift it, take it out.
Yeah, I tend to agree with you. If you have a good wide margin, I'm not sure it helps that much. The studies are somewhat conflicting about the ablation. They are doing, though, the true multi-center study in Australia right now that'll really hammer that question. So I don't think we totally know the answer to it yet. I think some of that is because of piecemeal EMR, obviously, but also the cold snare movement where there was more recurrence with cold snare. We do know that if it's not adequately done with the big margins, I think that's what led to that piece, but I think it's going to be answered. They said it would have come out next year, so we'll see what happens with that.
Oh yeah, question.
Yes, my name is Sadiq Salmasi. I'm a family physician and also board certified anatomic and clinical pathologist. So that's why on my patients, male and female, after age of 40, always once a year, I do on them test for cancer. For male and female, for the stomach cancer and for the colon cancer, stomach cancer CA19-9 and colon cancer CEA. And for female, I do also for them the ovarian cancer, which is CA125. And for male, I do also the prostate cancer PSA. So the reason I'm saying that, because my patients that they have positive tests for colon cancer, when I ask them to do colonoscopy, 50% of them, they don't want to do it. So what I do, I send for them a Cologuard. I ordered that. It goes to their home. It is it's a container. And they put their stool in that and send it back to the company, and they test it for cancer of the colon. So I just wanted to tell you that's what I usually do. I use the Cologuard for patients they don't want to do colon cancer, which is 50% of them.
What do you do if it's positive? Can you able to convince him to go forward with colonoscopy?
Yeah, well, when we get positive tests in the Cologuard, I tell them that you had it positive, although the CAA also was positive. It's always, you can tell that the CAA is when it's positive, they have the cancer. But I repeat the test in a month for them, so that's why I send them for sure when I tell them that you have it. So they have to they make sure that then they have to do a colonoscopy.
I mean, Cologuard is one of the options for colorectal cancer screening that detects
Yes.
cancers and maybe advanced lesions. It's versus a preventative test colonoscopy, but I'm not sure that checking some of those other cancer markers are part of a standard recommendation. They would reflect the existence of cancer, but Cologuard is an option.
Yes.
Heavily used in Madison, Wisconsin, where Exact Sciences.
Thank
Yep.
you.
What you're
Free
seeing,
samples, right?
Yeah, free samples. Yes.
it's interesting though, there is now a metric though that for those that have a positive Cologuard, for example, the ADR that we should be hitting is 50%. So it's a higher level expectation.
Yes.
What? Oh, we've got another question. Yes.
Dr. Straight, thank you for your talk. I'm just curious for our patients who have had a colonoscopy confirmed not to have cancer. They have uncomplicated recurrent diverticulitis. How would your approach be for someone who's had, say, 4 or 5 episodes spread over 2 years versus someone who's had 3 or 4 episodes spread over 3 months? In terms of your approach to antibiotic use, are there any adjunctive therapy that you would recommend in those cases?
Yeah, in terms of colonoscopy, I would treat them the same. And I actually, just anecdotal evidence, there are a couple case reports, but I sometimes hesitate to do a colonoscopy on someone who's had a lot of attacks because there's some evidence that our prep or our colonoscopy might incite another episode, maybe changes the microbiome, et cetera. But yes, I would treat them very differently. I mean, if someone's had scattered attacks, they have, 1 a year, I tend not to refer those patients to surgery. But if someone's had multiple every month, they likely are never completely resolving that inflammation and have what I indicated as smoldering disease. And I would treat that patient with a long course of antibiotics if you had evidence of diverticulitis. They often have focal tenderness. They don't feel well. I send fecal calprotectin quite often as trying a non-invasive approach, and it can be quite high. And then I would treat that patient with a long course of antibiotics, like 14 days, to see if I can get that disease under control.
Thank you.
I'll ask one more while the question's going up. Do we have any good real world data from, like, say, Kaiser Northern California or NetX claims-based database on what the uptake of your recommendations on the treatment of diverticulitis are? Because my sense dealing with my ER and my primary care physicians is that everybody gets antibiotics, everybody gets a referral.
I'm doing a study of that now, both in our institution, a QI study, and then using one of those large databases. I have a sense it's nearly everyone gets antibiotics. Occasionally someone comes and I'm like, wow, who saw you? The ER actually didn't give you antibiotics because it's longstanding dogma and people don't want to do nothing for someone who feels terrible. So, yeah.
Yes.
So I think most of us would feel like the Cologuard problem is that it's finding cancers, but it's not preventing cancers. Mm-hmm. And I know we call it colon cancer screening because it helps with our coding, which is really a misnomer for what we're doing. So my question is, are there any national initiatives from our societies to combat what I feel like are somewhat misleading commercials all the time, or primary care doctor education programs? Because it feels like I see patients and either they come in saying I have cancer because I had a positive Cologuard, or I see people who are so happy they have negative Cologuards, but as has been pointed out, there's 50% adenomas in many people. So it feels like it's all very misleading. And I think a lot of false negatives for what we're trying to do, but it feels like we're being hit by commercials that are great, but we don't do anything to support an idea that makes more sense to me. So anything going on?
I don't know about nationally. I know the home of Exact Sciences, we're combating this right now. They had this huge campaign and I think missold Cologuard in the informational material, making it equivalent to colonoscopy, not making the distinction of diagnostic, picking up cancer early versus preventing cancer with polypectomy. But I don't know nationally. Maybe someone else in the audience knows if there's a messaging campaign to try and
FIT test
educate
is less
patients.
than $1 and
Yep.
it has similar efficacy. So
Yeah, I mean, in the New England Journal trial, there's a fair number of missed, cancers, missed polyps, and that they reported even for the basis for Cologuard. Anecdotally, I've had several patients who had a Cologuard the year before. We find a carcinoma the next year. So, I mean, on the flip side, patients will do absolutely no screening. If they're willing to do a Cologuard that's positive, that may ultimately help them. So I don't think it's totally a bad thing, especially for those that won't do colonoscopy no matter what. So
yeah, and there were talks at DDW I didn't cover about this, and John Nadomi's work has highlighted this, that you want the uptake of screening. And so however you can get a patient who's at average risk to screen for colorectal cancer, whether it's Cologuard, FIT, less optimally a blood test or colonoscopy, the more patients we get in and the more frequently they're hit by one, either colonoscopy or a stool test, the better our outcomes are of our programs.
I mean, a positive Cologuard that scares someone into screening, it's good, even if it's negative when they get the screening. So.
Great. Dr. Mans.
Quick comment, and that is that there is significant disparity between colonoscopy availability for the rural population or in the South. And so we tend to congregate because all of us have ASCs. You don't find ASCs rurally. You don't find ASCs in large parts of the South. And therefore, our family practitioners and our internists have to depend on, unfortunately, other means of trying to screen for this problem.
Excellent point. Great session again. There is applause.
Now we're going to move into our next session and the advanced endoscopy abstracts. So we'll have 2 sessions talking about abstracts, and then we'll have a state-of-the-art talk as well. So our first speaker, it gives me great pleasure to introduce Dr. Rajiv Attam from the Southern California Permanente Medical Group. Dr. Attam is a gastroenterologist in the Southern California Permanente Medical Group. He specializes in advanced endoscopy, pancreaticobiliary diseases. He has expertise in ERCP, endoscopic ultrasound, and complex gastrointestinal disorders. He's active in clinical research, medical education, and advanced endoscopy techniques and care, as well as patient outcomes. So he's going to take us through the first round of abstracts, and then we'll go from there. Thank you.
Thank you, Eric. Good afternoon, everybody. Thanks for joining us. So I have picked about 12 abstracts from this DDW, and I've categorized them in 3 categories: Tier 1, Tier 2, and Tier 3, based on their impact, the methodology, the evidence, the data, and all. So we'll start with Tier 1, no relevant financial disclosures for me. Tier 1 of the 5 abstracts which I found with hard endpoints likely to change clinical practice. Here, this was reserved with the high quality data, effect size, clinical relevance, and I feel these abstracts will change practice guidelines in the years to come. We'll start with CLIMB-1 study. CLIMB stands for confocal laser endomicroscopy as an imaging biomarker. 6 tertiary US centers, prospective enrollment since 2018, led by Somshekhar, selected for ASG presidential plenary presentation this year. The technique uses Cellvizio probe passed through a 19-gauge USFNA needle to obtain real-time microscopic imaging of the cyst walls. Total of 623 patients underwent US NCLE. The diagnostic analysis is restricted to 263 patients with definitive surgical histopathology as a gold standard. 54% had mucinous cyst, mean cyst diameter of 3.9 centimeter, mean age 66 years, 55% patients are female. The study showed 92.8% accuracy. That's pretty high for mucinous versus non-mucinous classification. 93% sensitivity and 92.6% specificity, all high numbers. This is a clinical meaningful improvement from CEA plus cytology plus glucose, which stands at 82.6%. NGS molecular testing came back at 76.2%. So why does this matter? The current biomarkers for to detect mucinous cyst are imperfect, as you all know. Standard cyst fluid analysis includes cytology, CA, and glucose. That reaches only 82.6% accuracy in the real world data set. NGS molecular analysis comes at 76%. CLIMB lifts the diagnostic accuracy to about 93% with high specificity. Safety, 4.5% adverse events dominated by self-limit acute pancreatitis and 4.3%. No severe outcomes. The study is large enough with clean methodology that'll change practice guidelines. Important caveats here, it requires equipment most community centers don't have, interpretation and expertise. It'll add time to the procedure. Adoption will hinge on workflow, integration, and reimbursement, and not just clinical evidence. Moving on to next. ELEMENT and DROMBO were the two large randomized controlled trials comparing US-guided choledochoduodenostomy using LAMS to standard ERCP for malignant distal bile duct obstruction. Both the studies stopped at 12 months. This is a combined long-term extension of both trials, and of 299, retrospective beyond month 12. The results, there was no significant difference in stent dysfunction, adverse events, or mortality between the two arms. Both strategies were equally durable beyond 1 year. So how does it matter? Survival is improving with modern pancreatic cancer regimens. Patients are living longer. So long-term stent performance now matters. Equivalence at greater than 1 year removes the main reservation we had about first intent EUS choledochoduodenostomy. In centers with EUS bile duct drainage expertise, this now is a true first-line option, not just a salvage treatment. One caveat, the data are post 12 months are retrospective. They're not RCT level quality as the DRAMBO and ELEMENT trial. The third abstract I chose was the ACT-EUS. ACT-EUS is the largest direct comparison of the two strategies after failed biliary cannulation. Either escalate to advanced cannulation techniques like pre-cut, double wire, needle knife synchrotmy, or pivot directly to EUS-guided drainage. 30 international centers, 939 propensity matched patients. This was a retrospective study with IPTW analysis. It was restricted to dilated CBD over 12 millimeters where USBD is technically feasible. The traditional teaching has been to exhaust advanced endoscopy or advanced cannulation techniques before moving to EUS. This study challenges that reflex. The results, adverse events halved, technical success was higher, both favor early EUS bile duct drainage pivot. Clinical success was comparable, 96% to 94.5%. So patients get drained either way. Post-ERCP pancreatitis of 12% in advanced ERCP arm is a dominant driver of difference in the adverse events in the two groups. Fluid 2 study. So post-ERCP pancreatitis remains the most common serious complications of ERCP, about 10% across the board. Both ASG and ESG recommend rectal NSAIDs and PD stenting only after multiple unintentional PD cannulations, pancreatic cannulations. The question Fluid 2 raises is, does even a single unintentional pancreatic cannulation deserve a prophylactic stent? The design was 275 patients who had pancreatic stent placed compared to 262 historical Fluid 1 controls who got NSAIDs alone. Stents used were pigtail or straight, 5 French, 5 centimeter long with no internal flange. Results, there was a drop in pancreatitis rate, 19.8% pancreatitis in NSAIDs alone versus 12.4% when a stent was also placed. Pigtail stents were preferred as 76.7% of these passed out spontaneously within 2 weeks. So why does this matter? Even with single unintentional PD cannulation, Fluid 2 shows benefit from adding a pancreatic stent. The rates of post-ERCP pancreatitis dropped from 19.8% to 12.4%. This is a large effect. This is likely to drive guideline change in the next ASG, ESG guidelines. One caveat, the comparator in this group is a historical Fluid subgroup. It's not a parallel randomized arm. AI is now everywhere. So this is picked this study. It was very well done. AI for digital cholangioscopy. This is the first large multi-centric real-world validation of AI-assisted digital single operator cholangioscopy analysis. 14 centers across 6 countries, multiple device platforms, 138 prospective examinations. The model performs both detection, identifying suspicious regions with bounding boxes, and differentiation between benign and malignant. It showed an accuracy of 86.2%, sensitivity of 86.9%, and specificity of 85.7%. These are robust numbers across multi-centric data set. Negative predictive value was pretty high, 89.2%. This is a clinically actionable number. It's a strong rule-out tool for indeterminate strictures. IOU of 70.3%, meaning AI lesion detection aligned well with the expert annotations. Moving on to tier 2 high impact studies, these are likely to refine our practice, if not the guidelines. Bile metabolomics for indeterminate strictures. Northwestern's group has been working in bile-based liquid biopsy for several years. This is the largest prospective collection to date. 89 patients, bile collected at routine ERCP and analyzed with liquid chromatography and mass spectrometry. As you know, cancer metabolism is well described. Tumors shift nutrient utilization in a characteristic way. 4 metabolite panels of 3,7-methylguanine, butyric acid, quinodeoxycholic acid, and urea, they're elevated in malignancy. So these were checked with bile aspiration. The results, the combined 4 panel had a better AUC of 0.924 than any single marker. The positive predictive value was 90.6% and negative predictive value of 84.2%. Again, these are clinically useful numbers. This is a research finding for now, but if it replicates in real world, you could imagine a future workflow where bile is routinely sent for metabolomics at ERCP for any indeterminate stricture with results back in 24 to 48 hours. So this will improve your diagnosis of indeterminate strictures. EDGE, should we preemptively close fistula? As you know, in EDGE, these are procedures performed in patients with altered anatomy, such as Roux-en-Y gastric bypass, where a gastrogastric fistula is created by placing a lumen opposing metal stent. The question is that once you remove the stent, some patients develop a persistent fistula. So should we close the fistula when you remove the stent or let it close on its own? This was a multi-center retrospective study of 108 Roux-en-Y gastric bypass patients comparing spontaneous versus endoscopic closure. Primary outcome was persistent fistula rate and procedural cost. Persistent fistula rates were comparable between the closure and the non-closure groups. The cost was about $54,000 per patient in the closure arm. So there was no outcome benefit, just an additional cost. Diabetes was a predominant predictor of fistula. Patient selection here matters the most. Takeaways, do not routinely close the fistula after a lamb's removal in EDGE. US-guided hepatogastrostomy study from Italian multicenter data. So most published US hepatogastrostomy experiences come from Eastern centers, Japan, Korea, and Hong Kong, where the uptake has been rapid. Western adoption of US HGS has lacked due to safety concerns. This is a study of 183 patients across 6 Italian tertiary centers from 2017 to October of 2025. Predominantly malignant biliary obstruction, all failed ERCPs. EUS SGS was performed using a partially covered self-expanding metal stent. Primary outcome studies were technical success, clinical success, adverse events, and 30-day mortality. Results, technical success of 95%, clinical success of 92.5%. Adverse events that were seen were stent migration 5%, bile leak of 3.75%, and cholangitis of 2.5%. These numbers are very comparable to the best Asian series. So, the procedure is pretty well safely done in Western world also. There were no procedure-related deaths. 30-day mortality was 1%, which likely reflects the malignant population of the study. This is a abstract on pre-cut sphincterotomy. The study compares two main techniques of pre-cut: transpancreatic pre-cut and traditional needle knife pre-cut from PapLab. The Prince of Wales Hospital is a high-volume tertiary center in Hong Kong with more than 9,000 ERCPs over 8 years, 399 required pre-cut. It was a single-center retrospective study, but a clean comparison, the largest direct comparison of two techniques that I'm aware of. The novel aspect of the study is stratifying by both the pathology, meaning benign versus malignant, and endoscopist experience, less than 1,000 ERCPs or more than 1,000 ERCPs. Results: the first session success was 90% with transpancreatic sphincterotomy versus 76% with needle knife. This was a significant finding. In the malignant subgroup, the difference was even larger, 93% versus 73%. There were comparable adverse event rates between the two techniques. As per these results, transpancreatic sphincterotomy should be the default pre-cut technique for difficult biliary access. One caveat: this is retrospective, single center study, so I don't know if you can generalize to a wider population. Tier 3 were abstracts which I found interesting. This methodology was not the best, but they were hypothesis generating signals. EUS LAMS versus PTBD for distal biliary malignant obstruction. This is the largest comparison of EUS LAMS versus PTBD after failed ERCP for malignant obstruction. Trinetics Global Research Network, 6,040 patients after 1:1 propensity matching, 2016 to 2024 cohort. The cohorts were defined by CPT codes. Outcomes were clinical success, adverse events, 30-day mortality, 90-day mortality, and reintervention at 30 days. The results: clinical success was higher in EUS LAMS, 92% versus 80% in PTBD. Reintervention rates were lower in LAMS patients. 90-day survival was comparable, 81% to 76%. Bile was lower in patients who had EUS LAMS versus percutaneous approach. And that, I think, drives the difference in survival. Pancreatitis was higher with EUS LAMS, 1.9% versus 0.6% with IR-guided therapy. This may be related to the ERCP that was performed before the LAMS was placed. Bottom line: when EUS LAMS is technically feasible, it is likely the better choice for drainage. EUS FNA or FNB on anticoagulants. We really don't have any guidelines on stopping anticoagulants before EUS FNA or FNB. So this is a TriNet X US retrospective study evaluating safety of EUS FNA, FNB on active oral anticoagulation. And of 1,412 matched pairs from 2000 to 2025, 5-year period, anticoagulants were used within 1 day of the procedure. Outcomes studied were GI bleeding, ICU admission, 30-day mortality, and transfusion within 30 days. Results: GI bleeding was higher in patients who got anticoagulations within 1 day, of 4.5% to 2.3%. Relative risk was about 1.9. ICU admissions were higher at 5.6% versus 4%. Again, relative risk was 1.4. These are both significant numbers. Mortality and transfusion were non-significant. The message we get from this is active anticoagulation warrants a real pre-procedure conversation with the patient, and it's best to delay the procedure if possible so that the risks of bleeding go down. Hot lamps versus hot lamps for gallbladder drainage, 1-year outcomes. So EUS-guided gallbladder drainage with cautery-enhanced lamps is now a mature technique for high-risk surgical patients with acute cholecystitis. The question the study addresses is durability at 1 year. Single-center retrospective study, January 2022 to December 2024 cohort of 60 patients with mean age of 82.7 years, so all elderly, all Tokyo residents with 2018 non-malignant acute cholecystitis, all deemed too high risk for surgery. Kaplan-Meier analysis of stent patency with failure defined as recurrent cholecystitis or cholangitis due to stent dysfunction. There was 100% success. Total procedure time for lamps deployment was 6 minutes. Puncture to deployment was only 2.5 minutes. Early adverse events of 3.3%, mostly from food occlusion of the stent. Zero serious procedural complication. At 1 year, 87.3% stents were patent. This is a reassuring number for permanent indwelling strategy. In the frail 80-plus-year-old patients with acute cholecystitis, EUS biliary drainage by gallbladder drainage by placing a LAMS is now, I think, the standard of care in experienced centers. I have two bonus picks. Again, these had some meaningful data. The first is the disposable versus reusable duodenoscope for EDGE procedure. Again, EDGE is a procedure where we create a gastrogastric fistula between the remnant stomach and the gastric pouch to allow ERCP for patients with Roux-en-Y gastric bypass anatomy. This is the first outcomes-based comparative study for EDGE specifically. Single-use duodenoscope versus traditional reusable duodenoscopes. It's a multi-center retrospective review from 2022 to 2025, 3-year period. 52 consecutive Roux-en-Y gastric bypass EDGE cases. 23 were done with Exalt, which is the disposable scope, a single-use scope. 29 with Olympus reusable scopes. And the LAMS suturing was comparable in both the groups. There was zero intraprocedural LAMS dislodgement with the single-use or Exalt scope versus 25% in the reusable scopes group. This is a big number. This alone changes how I'd schedule EDGE if both options are available. Overall adverse events, excluding dislodgement, were also different. 4% in the single-use versus 20% in the reusable scopes. There were comparable clinical success between the two arms. So you don't lose efficacy with single-use scopes. It is unclear as to why they had lower dislodgement because the two scopes have similar size. My take on this, for elective EDGE, especially in high-risk patients, the dislodgement number is reason enough to prefer the disposable scope platform when available. Plus, infection control is an additional bonus that you get with this. This is a umbrella meta-analysis on EUS gastroenterostomy, a pretty well-done study. So EUS gastroenterostomy has now become the most rapidly adopted EUS intervention for the past 5 years. Multiple meta-analyses now exist comparing it to enteral stenting and surgical gastroenterostomy. This umbrella review synthesizes 8 of these meta-analyses through November 2025, approximately 3,600 patients. They used AmStar 2 quality assessment, 3 high quality and 5 moderate quality studies, mean score of 81%. Random effects were pooled to estimate random effects pooled estimates throughout the study. Results: pooled success of EUS gastroenterostomy was about technical success was 93%, clinical success 90%, and overall adverse rates were at 9%. If you compare it to enteral stenting, like a duodenal stent, it showed superior clinical success, fewer adverse events, and 78% relative reduction in reintervention, which is a big number. When you compare it to surgical gastroenterostomy, again, it was comparable in clinical success, but 83% reduction in adverse events. So surgical gastroenterostomy has higher adverse events and shorter length of stay of 3.76 days. The evidence for EUSGE is now solid enough to call it its standard of care where the expertise is available. I've summarized these, and it should be in the handout, all the studies with their results. And that's it for this year. Thank you so much.
Thank you so much, Rajiv. And Dr. Atama will be coming back for our state-of-the-art talk. And now it gives me also great pleasure to introduce Dr. Jason Samarasena from UC Irvine. He is a professor of clinical medicine, gastroenterology, and hepatology at UC Irvine and nationally recognized expert in advanced endoscopy. His work focuses on interventional endoscopy, Barrett's esophagus, pancreaticobiliary disease, and endoscopic innovation. He has authored numerous publications and is active in advancing GI education and minimally invasive procedures, and he will take us through another round of abstracts from DDW. Thank you, Jason.
Thank you, Eric, and the organizers for the invitation. This has been a great conference so far, and hopefully I can share some really interesting studies that I thought this year's DDW was just sort of exceptional in terms of sort of the newest and the greatest. And I think some of these luminal abstracts are really actually pretty groundbreaking. Some of my disclosures. So the first one I'm going to talk about is GERD themed. So laparoscopic hilar hernia repair followed by transoral incisionless fundoplication, CTIF, versus Nissen fundoplication for pathologic gastroesophageal reflux, a prospective multicenter randomized blinded study. And this is Dr. Abudaya and colleagues. So lap hilar hernia repair followed by Nissen fundoplication is really the accepted gold standard in surgical therapy for GERD, but it still has some clinical side effects, and the technical complexity of this makes it sort of variable among surgeons. So laparoscopic hilar hernia repair with consecutive transoral incisionless fundoplication, that's TIF, so it's a CTIF, provides a potentially less invasive, more reliable technique to anatomically restore the anti-reflux barrier. But there's no randomized trials, and this is the first one. So adults with pathologic GERD were randomized over 6 years to CTIF versus traditional lap Nissen. The primary endpoint was a change in the GERD HRQL, the quality of life questionnaire at 6 months. Secondary endpoints included a 90-day major complication reoperation rate, GERD HRQL at 12 months, acid exposure time, Demeester score, GI quality of life index, PPI discontinuation, and bloating scores. So the results, 132 patients underwent intervention, 68 in the CTIF group, 64 in the lap Nissen group. Serious adverse events were similar amongst both groups. Both groups had a large GERD HRQL improvement at 6 months, as well as 12 months. At 6 months, the acid exposure time, the Demeester score normalized in both groups with no significant differences. And more than 90% of each group discontinued PPI therapy at 6 months and 12 months. And the GI quality of life index improved markedly at both time points without between group differences. Mean dysphagia scores improved at 6 months and 12 months, but I think the only major notable difference between the groups was severe dysphagia being rare, but new onset worsening dysphagia was significantly lower in the CTIF group at 6 months at 2.6% versus 32.3%, as well as 12 months at 5.7% versus 28.6% in the surgical group. So in this multi-center trial, CTIF was non-inferior to lap Nissen in GERD-related quality of life improvement and objective normalization of esophageal acid exposure. And so I think this is something sort of interesting to think about. All of these CTIFs were performed at truly expert centers, and it may not be generalizable to CTIF outside of these academic centers. And a lot of CTIFs are actually happening in the community as we speak. The next study I'm going to talk about is within the endobariatrics theme. So endoscopic duodenal pulsed electric field therapy demonstrates favorable safety and dose-dependent metabolic improvements in adults with type 2 diabetes. Integrated results from Regent 1 Australia and Regent 1 US studies. So this is Dr. Abudaya as well. The duodenum plays a central role in nutrient sensing and metabolic regulation, structural and functional abnormalities of the proximal small bowel. Diabetic duodenopathy may contribute to insulin resistance and disordered glucose homeostasis in type 2 diabetics. Endoscopic pulsed electric field therapy is a non-thermal catheter-based modality that induces controlled duodenal recellularization while preserving tissue architecture. And this study evaluated the safety, feasibility, and the metabolic effects of PEF therapy in adults with type 2 diabetes inadequately controlled on non-insulin medications. So this was actually an integrated analysis of 2 prospective multi-center feasibility studies, Regent 1 in Australia and Regent 1 in the US. Adults were 18 to 70 with type 2 diabetes with hemoglobin A1Cs ranging from 7.5 to 11%, BMI ranging from 24 to 40. and treated with non-insulin glucose lowering medications. And they underwent PEF therapy, initiated in the second portion of the duodenum, and then advanced segmentally in a distal direction, really with the goal to get all the way to the ligament of Treitz. So this was almost like a dose finding study. So they had 3 energy dose cohorts: Gen 1 single application at 600 volts, Gen 1 double application at 600 to 750, and Gen 2 double application at 750. So the primary endpoint was device or procedure-related serious adverse events, and secondary endpoints including glycemic outcomes, continuous glucose monitoring metrics, weight, and metabolic parameters through 48 weeks. So the results, 71 participants underwent the procedure. Procedural success was achieved in all participants, and there was a clear dose response relationships observed. So at week 48, hemoglobin A1C reductions were 0.2 in the Gen 1 single, 1% in Gen 1 double, 1.5% in Gen 2 double, and there was corresponding fasting plasma glucose changes also in sort of a stepwise fashion, and weight also decreased in a stepwise fashion across those different dose cohorts. Continuous glucose monitoring showed early and sustained improvements in time in range and time in tight range across all the cohorts. So endoscopic duodenal pulse wave electric field therapy was safe, technically feasible, and associated with durable dose-dependent improvements in glycemia, insulin resistance, and body weight through 48 weeks. So a very promising procedure-based intervention that GI doctors can do to help patients with type 2 diabetes. Moving on to resection. So I've got 2 abstracts touching on endoscopic mucosal resection. The first one is titled Predictors of Recurrence After Piecemeal EMR and Clinical Outcomes of Margin Thermal Ablation in Routine Practice, a comparative cohort study. So recurrence after piecemeal endoscopic mucosal resection of large non-pedunculated colonic polyps, LNPCPs, remain a major limitation of the technique. Margin thermal ablation reduces recurrence neoplasia in randomized trials, but evidence in its effectiveness and predictors of recurrence in routine clinical practice is limited. So this study evaluated the recurrence after piecemeal EMR of LNPCPs before and after implementation of margin thermal ablation in a single high volume center. So this was a retrospective comparative cohort study with patients undergoing piecemeal EMR for LNPCPs greater than 20 millimeters during 2 time periods, between 2013 and 2015, where they didn't do any of the margin thermal ablation, and between 2022 and 2024, where they were always doing systematic margin thermal ablation. So patients were treated with piecemeal EMR, and the primary endpoint was local recurrence at the first surveillance colonoscopy performed 4 to 6 months after resection. And recurrence was defined as either an endoscopic or a histologic evidence of adenomatous tissue. So between 2013 and 2015, 108 LNPCPs were treated with standard piecemeal EMR without margin thermal ablation. And during 2022 and 2024, 124 LNPCPs were treated with piecemeal EMR with systematic margin thermal ablation. So recurrence occurred in 9% of the lesions in the thermal ablation group versus 26% in the non-thermal ablation group. And this represented a 17% absolute and 66% relative reduction in recurrence. Local recurrence was significantly associated with lesions greater than 30 millimeters in size, granular mixed type lesions, and high-grade dysplasia. So this sort of confirms what we had sort of deduced from the randomized trials, that margin thermal ablation following piecemeal EMR significantly reduces local recurrence in routine clinical practice. Moving on to a problem that we're seeing more and more of, rectal neuroendocrine tumors. This study is titled Efficacy of Endoscopic Submucosal Resection with Ligation Device for Small Rectal Neuroendocrine Tumors, a multi-center open-labeled randomized control trial, the BANDIT trial. Love that name. And so this was a study performed in Japan, And so endoscopic resection is widely accepted for these rectal neuroendocrine tumors, less than 10 millimeters, but the optimal technique remains unclear. So endoscopic submucosal resection with a band ligation EMR system, like the Cook-Duet system, has shown histologically complete resection rates comparable to ESD in retrospective studies, but there's yet to be any multi-center randomized controlled trials. And given that band ligation EMR is so simple and so quick, this was a very meaningful study. So this was a prospective open label, multi-center, non-inferiority randomized control trial that was conducted at 32 institutions in Japan. So patients were endoscopically diagnosed with rectal neuroendocrine tumors less than 10 millimeters in size and randomized to ESD or the band ligation EMR. The primary endpoint was the rate of en-bloc resection with histologically tumor-free margins. Secondary endpoints included en-bloc resection, procedure time, hospital stay, and devices and agent costs and adverse events. So the results, 130 and 127 patients were included in the main analysis in the ESD group and the band ligation EMR group respectively. There were 60 experts and 33 non-expert endoscopists participating in the study based on their ESD volume. Mean tumor diameter was 5.4 millimeters in both groups. R0 resection rates were 92.3% in the ESD group and actually a little bit higher in the band ligation EMR group. The en-bloc resection was achieved in all cases, but procedure time, hospital stay, costs were significantly lower in the band ligation EMR group. So looking at the time, 28 minutes for ESD versus 5.2 minutes for band ligation EMR. So for rectal neuroendocrine tumors less than 10 millimeters, band ligation EMR was non-inferior to ESD. For R0 resection, provided shorter procedure time and reduced hospitalization and was lower cost. Sticking with the ESD theme, this was a study titled Comparison of Endoscopic Resection and Surgery for Early Gastric Cancer with Undifferentiated Histologic Type, the ERASE-GC trial. And so when you see a small cancer in the stomach and we take a biopsy of it and it comes back poorly differentiated and it's less than 2 centimeters, in Japan, the guidelines will say that this is an absolute indication for ESD. And that basically means that a surgeon should not go and take this out. It should absolutely be an ESD. And that was a change made in 2021. It was sort of a gray zone. It could go surgical, it could go ESD, but that data really was, that decision was driven by data that showed that these less than 2 centimeter poorly differentiated cancers have extremely low risk of lymph node metastasis. In Korea, the guidelines still stand that it's very much a gray zone. And this was a clinical trial to compare the outcomes of ESD versus surgery in these undifferentiated type early gastric cancers. So it was a multi-center, pragmatic, randomized control trial that enrolled patients with undifferentiated early gastric cancers. So this could be signet ring cell carcinoma, what's called poorly cohesive carcinoma, or poorly differentiated adenocarcinoma, meaning the ESD indication of less than 2 centimeters in size without any ulceration. And this was done at the National Cancer Center and 8 university hospitals. So in this study, 344 patients, 54 patients were in the ESD group and 354 in the surgery group. Of the patients that underwent ESD, a large number of them ended up not being curative resections. So that probably means that there was a positive margin or the depth of invasion was too much to call it curative. And in that group, 84.5% of the non-curative ESDs actually went on to surgery. So there's a lot of patients that went on to surgery where we had a lot of information about lymph node status. So the lymph node metastasis rate was found to be 4% in the patients who underwent initial gastrectomy and 5.9% in the 153 patients who received additional gastrectomy after non-curative ESD. So in patients with undifferentiated early gastric cancer meeting the ESD indication on diagnostic evaluation, ESD achieved a low curative resection rate, and the risk of lymph node metastasis was not negligible. So I think, surgery to me seems like a very good option for these patients. This is another study about early gastric cancer and ESD, and there's currently no consensus on the optimal surveillance strategy or subsequent treatment of metachronous gastric neoplasms occurring beyond 5 years following ESD. And this is titled Necessity of Extended Endoscopic Follow-up Beyond 5 Years Following Endoscopic Submucosal Dissection for Early Gastric Cancer. So in this group, or in this study, they retrospectively reviewed patients who underwent ESD for early gastric neoplasms between March 2005 and June 2020. And metachronous recurrence was defined as a new gastric neoplasm detected at a different site more than 12 months following ESD. So in this group, in this study, 5,571 patients treated with the ESD, but 877 patients were included in the study, and they were followed for less than 5 years in 68.8% and more than 5 years in 31.2%. And the recurrence rates within 5 years was 9.5% and increasing to 14.5% when follow-up exceeded 5 years. All recurrence lesions were stage 1 with no advanced cancers observed. And predictors of late recurrence were intestinal metaplasia and histologic upgrade. So for metachronous gastric neoplasms, I think you should consider increased surveillance beyond 5 years. It's not like some of the other cancers where after 5 years you consider it a cure and you can stop surveillance. So I think the message here is we should continue surveillance. The next study is hitting on a theme that Rajiv spoke about. This was another very well done international randomized trial looking at endoscopic ultrasound-guided gastroenterostomy versus enteral stenting for palliation of malignant gastric outlet obstruction. And so when a patient presents with a gastric outlet obstruction, really there's two options: duodenal stenting or the placement of an EUS-guided gastroenterostomy. And this was a randomized, multi-center, 1-to-1 trial looking at unresectable, symptomatic metastatic gastric outlet obstruction, randomized to either EUS-guided gastroenterostomy or endoscopic stenting for 1 year. The primary endpoint was 3-month gastric outlet obstruction recurrence, defined as recurrent symptoms with endoscopic or radiographic confirmation of stent dysfunction, and secondary endpoints included procedure-related adverse events, with serious adverse events defined as moderate, severe, technical success, clinical success, and gastric outlet obstruction recurrence at 6 and 12 months. So 112 patients from 5 institutions were randomized. The median age was 63 years in both groups. And recurrence rates were 0% in the EUS-GE group versus 3.8% in the endoscopic stenting group. And procedure-related adverse events occurred in 8.8% of the EUS gastroenterostomy group versus 7.3% in the endoscopic stenting group. So in this international randomized trial, EUS gastroenterostomy achieved similar technical and clinical success to endoscopic stenting in patients with gastric outlet obstruction with a significantly lower recurrence and reintervention rate. This study was covered earlier, looking at life cycle analysis across general and interventional procedures. And this is work done at UC Irvine by my colleague, Francis Dang. So I was happy to see that presented this morning. The last paper I'm going to discuss is something that I've been involved with, and talking with Lisa Straight earlier. She wanted me to present this, even though it could have been in the lower set of abstracts because it deals with colon. But because I was involved, I'm going to present it. So this was colonoscopy with a robotic endoscope care study, 50-patient first-in-human experience using a novel robotic colonoscopy system. So this was a prospective single-arm, non-randomized, single-site first-in-human study. 3 endoscopists highly experienced in manual colonoscopy, and the study included adults greater than 22 years in age with the indication for screening, surveillance, or diagnostic colonoscopy. So in this study, we did a initial phase lead in to evaluate the safety in 10 patients. And then we did a phase B in 40 patients with really only robotic colonoscopy. And we included removal of polyps less than 2 centimeters in size. Major adverse events, including perforation, bleeding, and hospitalization within 48 hours, and successful completion of colonoscopy. And you can see the secondary endpoints here. So just to talk about the robot a little bit. So this is the graphical user interface. So on the top left, you can see this force and torque indicator. And the bottom left, you can see this inserted length indicator. I'll explain that in a little bit. And then on the top right, you can see this shape indicator, which is a little bit like scope guide. And then on the bottom right, something they call the flower, which is looks at steering range and roll. And so here's a little video showing kind of us navigating to the cecum. This is sped up at 3x. And so you can see in the bottom left, this is the scope excursion outside of the overtube. And this is a dual dynamic rigidizing scope system. So the scope can rigidize, and then the overtube will basically copy the scope shape. Then the overtube will rigidize and the scope will move forward, and the scope will rigidize and the overtube will catch up again. And so basically you do that sequence till you either get to the cecum or if you want to make a reduction. So one of the great things about the robot, it's very, very stable. You can see the scope is sort of looped up there, but even in the cecum, you get really, really fantastic control of the scope tip, and we basically made it into the IC valve on every single patient. So now everything that's we typically do manually is now basically loaded onto a controller, and it's a button. And so doing kind of retroflexion is actually really really easy. Just hit the button and it just sort of it kind of goes around. So, and then the other thing that is really easy to do with the robot is roll. And so here you can kind of be at the cecum and you can roll, and you can keep rolling and you can keep rolling, and it's kind of fun. And so it's really strange to have this level of stability at the cecum. And so for kind of therapeutic endoscopy procedures in the right colon, I can imagine this is going to be really, really nice. In terms of polypectomy, in this case, looking at the bottom left, you can see that this is a polyp at 63 centimeters. And so somewhere in the ascending colon. And even though the video is sped up, I think you can probably appreciate that, it's very stable, and, doing kind of polypectomy and EMR and other things, it's going to help, especially with that roll and stability. So in phase A, the cecal intubation rate was 100%, no adverse events. In phase B, the cecal intubation rate was 100%, no adverse events. And 79 polyps were detected. Adenoma detection rate with the robot was 54.2%. 77 out of 77 polypectomies were completed, 2 lesions not removed because they're bigger than 2 centimeters per protocol. In terms of mucosal injury, there was 1 mucosal break greater than 5 millimeters. That's considered a grade 3 injury. That happened during a retroflexion on one of my procedures, and that happened at patient number 9 out of 40. And we made a modification to the retroflexion protocol, and there was no further events after that. We looked at the NASA task load index, so looking at the physical and mental demand of doing colonoscopy. And with the robot, it was definitely easier. So here's a picture of me sitting in front of the console. And, my comment here is, after you've done 3 weeks of robotic colonoscopy, it's really difficult to unsee or unfeel how easy that was. And when I came back and was doing manual colonoscopy, I was not enjoying it. So in this 50-patient first-in-human study, the Triton system demonstrated excellent safety and feasibility with 100% cecal intubation and no adverse events after 14 days. The stability provided by the dual dynamic rigidization with robotic precision enabled comprehensive inspection, effective polyp detection, and safe resection while providing a comfortable ergonomic experience. Thanks very much.
Thank you so much, Jason. And now we'll have our state-of-the-art talk by Dr. Atam, and then I'll invite both doctors back and we'll do our question and answer. Let's see. There we go.
Once again, good afternoon. So in the state of that talk, I chose EUS and ERCP, or endoscopic therapy for chronic pancreatitis. As you know, the role of ERCP and EUS has changed greatly over the last, decade or so in management of chronic pancreatitis. We're using more of interventional EUS. So I'll show some cases, show some data, and we'll go over the management of chronic pancreatitis using endoscopic therapy. No financial relationships to disclose. Why endoscopic therapy? Endoscopic therapy targets the mechanical drivers of pain in chronic pancreatitis: obstructed ducts, stones, strictures, and duct leaks. 60 to 80% patients respond to endoscopic therapy with careful patient selection. Endoscopy does not change the disease course, but can help by improving the quality of life. Surgery still remains the most durable option, especially when endoscopic therapy fails. Before we embark the endoscopic therapy pathway, get onto the pathway, it is essential to obtain high quality imaging, especially EUS if you can, discuss lifestyle changes of the patients, get them on right analgesics, try and avoid opiates, pancreatic enzyme replacement therapy for exocrine insufficiency, and set realistic goals in terms of pain relief. This approach requires a multidisciplinary team effort. So you need to have your surgeons, your radiologists, interventional radiologists, all on the same, in the same room or on board for taking care of these patients. We'll start with pancreatic stones. These are 3 patients who have large obstructing stones in the head of the pancreas. You can see all 3 have big stones with dilated duct upstream, but only one person has symptoms. Can you guess which one? It's hard to say. It's only one patient on the right who had symptoms. The other 2 were found incidentally. This goes to show that imaging does not always correlate with symptoms in chronic pancreatitis. And we're not treating the imaging, we're treating the patient. So we have to intervene only when there are symptoms present. What are the indications therapy? Indications are primarily, pain. It's usually in patients who have upstream ductal dilation, recurrent pancreatitis, or duct leak. Stones in the tail usually do not warrant intervention unless causing a duct leak or recurrent pancreatitis. The treatment options for pancreatic duct stones include a standard ERCP, ERCP combined with S-wall, or ERCP combined with pancreatoscopy with lithotripsy such as EHL or laser. The small stones, less than 5 millimeters, floating in the main pancreatic duct can safely be removed with standard ERCP techniques. The procedure involves cannulation of main pancreatic duct, sphincterotomy, balloon sphincteroplasty if needed, and extraction using a stone retrieval basket. We tend to avoid balloons as the balloons push the stone fragments into the side branches, and then that adds to the problem. In some cases, you may require dilation or downstream stricture before you can remove the stone. And in many patients, what we've learned is that you require multiple procedures. These are the steps of ERCP for removal of stone. You'll see a normal appearing papilla, pancreatic sphincterotomy, balloon dilation for balloon sphincteroplasty, wide open pancreatic orifice, stone removal with a basket, and you can see the stone fragments coming out. The small stones can be removed with simple ERCP, but for larger stones, you need some mechanism to break them into small sizes, fragment, and then take them out. S-wall in this situation is a very good option. S-wall involves high energy shock waves which are delivered extracorporally to break or fragment these stones before proceeding with the ERCP for clearance. Stones are targeted by fluoroscopy if they're radiopaque. If they're radiolucent, we place a pancreatic stent before performing S-wall so that the stones can be targeted. Typically 4,000 to 5,000 shocks are given per session, and most patients require about 1 to 3 sessions to break down these stones. ERCP then follows to extract or remove the stone fragments from the main pancreatic duct. What are the outcomes? This is the largest study of reported series. Over 5,000 patients in the series. Stone clearance exceeded 70% with pain relief at 6 months of over 80%. Complications are mostly minor and self-limiting. There's a very good meta-analysis on ERCP and S-wall, which achieved a drug clearance of 70% and fragmentation in 86%. Pain-free rates at follow-up were about 64%. Post-procedural pancreatitis occurs in about 4%, which is comparable to a standard ERCP. The combination outperforms either modality, S-wall alone or ERCP alone, for large main pancreatic duct stones. Moving on to the third or the next powerful tool in our arsenal, that's ERCP with pancreatoscopy with EHL or lithotripsy to break down the big stones. EHL is performed under direct pancreatoscopic vision with saline immersion, which is required for hydraulic wave to fragment the stone. The probe is positioned about 1 to 2 millimeters away from the stone surface. We start at lower power level and slowly ramp up as needed. After fragmentation, stone fragments are cleared using a basket or sometimes balloon sweeps. The procedure involves sphincterotomy first to allow the introduction of cholangioscope. Sometimes you have to dilate the pancreatic orifice. We maintain low irrigation with saline to allow the hydraulic waves. We tend not to push too aggressively in the first session to minimize complications and always leave a pancreatic stent at the end of the procedure to reduce the risk of pancreatitis. This is a video of EHL of stone fragmentation using EHL. You can see the EHL probe, which is positioned about 1 to 2 millimeters from the stone surface. And with shocks, you can see the stone fragmenting into smaller pieces. The aim is to have pieces less than 5 millimeters in size so they can easily be removed with a basket or a balloon sweep. So what is the success rate of EHL pancreatoscopy? Technical success exceeds 91% in experienced hands. Fragmentation rate exceeds 86%. Single session complete clearance was seen in about 62%. So many patients require more than 1 session. Adverse events of 14%, mostly driven by pancreatitis, 8.7%. Serious side events are less than 5%. EHL versus laser, how do they compare? Both are very similar in their technical success, clinical success, and adverse events as shown in the schematic. So it all depends on which modality you have available in your endoscopy lab. Getting laser is more difficult than EHL. So we tend to fall straight to EHL. This is a treatment algorithm that I made for management of pancreatic duct stones. Smaller stones, less than 5 millimeters, no proximal stricture, ERCP with sphincterotomy, balloon sphincteroplasty, and stone extraction using basket. For larger stones, you could go to S-wall first, followed by ERCP. Some places we're doing S-wall, ERCP, same session in the same endoscopy suite. Or you could go for EHL and fragment the stone and remove the stone fragments. The question is, who does better, endoscopy or surgery for treatment of chronic pancreatitis, especially stones and all? In every trial, randomized controlled trial so far, surgery has been found to be superior for durable pain relief, superior to endoscopic therapy. But if you look at the data, when you analyze the data of patients who actually had complete duct clearance, the pain relief was very similar. So somehow maybe we are failing in getting complete duct clearance And that's why our benefit is not as good as surgery. So if you aim at complete duct clearance, our results approach the level of surgical results. So what do the guidelines say about pancreatic stones? ESC has strong recommendations about using SWAL for larger stones and ERCP for smaller stones. IAP, APA, European Pancreatic Club, and Japan Pancreas Society have low conditional quality guidelines against saying SWAL for larger stones. Moving on to the next complications of chronic pancreatitis, pancreatic strictures. Again, before you start endoscopic therapy, we really need to have high quality imaging, especially EUS, because you could be missing malignancy. If somebody is presenting with jaundice prior to having abdominal pain, think of malignancy, not chronic pancreatitis. And ERCP with stent placement is indicated in patients who have symptomatic pancreatic duct strictures, just like the pancreatic duct stones. The steps of ERCP are similar, synchrotmy if needed, dilation of stricture, placement of pancreatic stent. We start with a smaller size stent and gradually go up. And in failures of endoscopic therapy, definitely have to consider surgical treatment. And the goal of treatment is not indefinite stenting, it is sustained stricture resolution and symptom control. Strength strategies, we start with a lower, we aim to get up to 8.5 or 10 French stent, leave it for 2 to 3 months and exchange. Multiple stents are used for difficult strictures, and it's been shown that multiple stents help treat refractory pancreatic strictures. Fully covered self-expanding metal stents are rarely used because of high risk of migration and risk of trauma or injury to the side branches. Some strictures in pancreas are refractory, meaning they persist beyond 1 year after with endoscopic therapy. So the strictures are not resolving with 1 year of pancreatic endotherapy. They're qualified as refractory pancreatic duct strictures. Treatment options for such strictures include multiple pancreatic stents placed side by side with progressive dilatation. Fully covered self-expanding metal stents can be used, but again, they're poorly tolerated. Patients present with pain, stent migration, and blockage of the side branches. Multiple pancreatic stent is the preferred first-line therapy for these patients. And in some patients who fail endoscopic therapy, you have to discuss it with discuss this with surgery for surgical resection. What are the results of multiple stenting of refractory strictures? This Costamania series showed 95% resolution and 84% long-term pain relief with multiple plastic stents. Median of 3 stents were placed and removed at 6 to 12 months. This was simple and reproducible. These are the best long-term outcomes reported so far. This supports multiple pancreatic stents as a standard of care before escalating to surgery or fully covered self-expanding metal stents. Moving on to bile duct strictures, 3 to 10% of patients with chronic pancreatitis present with biliary strictures. Many of these resolve on their own as the inflammation goes down, but some present with cholestasis, jaundice, elevated LFTs, pruritus, and these can happen years after onset of chronic pancreatitis. Strictures persisting for more than a month or rising LFTs, cholangitis, these mandate intervention. But before, again, starting with endoscopic therapy, it is essential to rule out malignancy. It's critical before you put a stent in to have some sort of a tissue diagnosis to make sure there's not a cancer sitting there. What are the steps? Similar to other procedures, you start with biliary cannulation, biliary sphincterotomy, get a good cholangiogram to delineate the stricture, balloon dilation of the stricture, and then stent placement. Stent exchanges every 3 months is critical to prevent occlusion and cholangitis. Multiple plastic stents are the best evidence. Catalama showed 90% resolution at 12 months using multiple plastic stents. Fully covered self-expanding metal stents have a definite role in management of biliary strictures from chronic pancreatitis, as they can be left in for 6 to 12 months, thereby reducing the number of procedures for these patients. How to escalate from ERCP with plastic stents to metal stents and then surgery. First, rule out malignancy. Get brush cytology, US fine needle aspiration or biopsy. And if you have intraductal ultrasound available, that's another good modality to use. Never stent a new biliary stricture without getting tissue diagnosis first. First line is treatment with single 10 French plastic stents, exchange every 2 to 3 months, escalate to multiple stents, or fully covered self-expanding metal stents before sending to surgery for hepatic-osteogenestomy. Now, moving on to US-guided interventions, this is the new field of advanced endoscopy where US is being used more and more for managing complex situations, especially with pancreatic interventions. We'll talk about US-guided celiac plexus first. US-guided celiac plexus block is used for refractory pancreatic abdominal pain. It involves injection of a local anesthetic and steroid near the celiac plexus. Response rates are moderate, around 50 to 70% pain relief. Relief is temporary. You may have to repeat the injection in a few months, but it's repeatable. However, risks increase with repeat injections while the benefits dwindle. So that's why we don't really like using USCPB for chronic pancreatitis, because over time the risks go up, side effects go up, and the patients don't do well. US-guided biliary drainage. US is now the standard for let's see. US-guided biliary drainage. When ERCP fails, US comes handy. It provides us alternatives. There are two options for biliary drainage using EUS techniques. You could use EUS rendezvous, where a wire is passed, it's captured, and you access the biliary system, or direct choledochoduodenostomy, where a stent is placed across the duodenal wall, or in sometimes, gastric wall to gallbladder by change, and that changes the anatomy and directly bypasses the blockage. Choosing rendezvous versus CDS depends on the anatomy and accessibility. This is a patient who presented with a mass-forming lesion in the head of the pancreas, causing both biliary obstruction and gastric outlet obstruction. The ERCP was not possible because the papilla could not be reached because of the gastric outlet obstruction from the mass in the head of the pancreas. So in this one session, we performed US choledochoduodenostomy by placing a lumen-opposing metal stent across the duodenal wall into the dilated bile duct, passed the wire down further, and placed US gastroduodenostomy. So thereby, in one session, he had palliation of both biliary and gastric outlet obstruction. You can see the stents, it's the CDS stent lamps on the top and the US GJ stent on the bottom. How about fluid collections? In US is now the standard for drainage of wall-off necrosis and pseudocyst. Pseudocysts resolve in over 90% of cases with simple stent placement. Wall-off necrosis have necrotic material, so it requires more work. It requires necrosectomy and may require multiple procedures. But over the last decade, the whole space has been changed or revolutionized by the placement of lamps. Lamps has made the procedure so much safer and easier. How about US-guided pancreatic duct access? There are scenarios where patients present with pancreatic duct obstruction and standard ERCP is either not possible or it fails. In those cases, US-guided rendezvous preserves anatomy. Transmural drainage can also be performed by placing a pancreaticogastrostomy stent to allow drainage directly into the gastric lumen. These are technically demanding procedures and best performed in high volume centers. This is a case of US-guided pancreatic duct access. This is a 57-year-old male who has history of alcohol and tobacco abuse with recurrent admissions with abdominal pain and pancreatitis. As you can see, the pancreatic duct is diffusely dilated and has multiple filling defects of pancreatic stones. You can see calcifications leading all the way to the head of the pancreas. The duct is dilated all the way to the head of the pancreas. So he had an attempt at ERCP. It failed. They could not cannulate the pancreatic duct. So they went ahead and did a rendezvous technique where the pancreatic duct was accessed across the gastric wall. And the duct in the body of the pancreas was accessed. They passed a wire into the duct, but the wire would not come out. It would keep coiling in the dilated pancreatic duct in the head of the pancreas. So now we have failed with the ERCP and we've failed with US-guided access. So what do we do next? So this patient was then referred to us. We took a slightly different approach. We used a different site for puncture and injected contrast. And as you inject contrast, you could see the contrast was actually leaking from the minor papilla. So the patient all along had pancreatic divisum, and what we were seeing was a dilated duct going into a cystic dilation in the head of the pancreas. So this defined the anatomy for us. Using a 22 gauge needle, 018 wire was passed and advanced through the minor papilla into the duodenum. Now, because the wire that was exiting was at a short distance from the puncture site, we could not dilate over the existing wire. We could not see the minor papilla because of so much inflammation. We passed a second wire besides the exiting wire, and this is a small 018 wire that's being passed besides, and we pass it all the way to the tail of the pancreas. So now we have two wires, one that is placed by EUS guided rendezvous, and second wire, which is now a working wire that goes all the way to the tail of the pancreas. And we place after dilating, we place a plastic stent over the wire that went to the tail. This is a picture with the biliary stent and the pancreatic stent through the minor papilla. And after 3 stent exchanges and stone clearance, this is how the pancreatic duct looks now. Earlier, it was severely dilated all the way down to the head of the pancreas. Now you can see the change of chronic pancreatitis, but the stones are gone, the ductal dilation is gone, and the patient is doing much better. The pain has resolved and no more admissions for abdominal pain and pancreatitis. How about in altered anatomy? In altered anatomy, EUS guided rendezvous really helps us a lot. In these patients, getting to the pancreatic jejunostomy is difficult. So EUS rendezvous gets us the access to the main pancreatic duct. This is a 47-year-old male who had Whipple for ampullary cancer, and now he's presenting with recurrent pancreatitis. MRCP, you can see, shows a dilated main pancreatic duct in the body and tail of the pancreas. Attempts at identifying pancreatic jejunostomy with deep enteroscopy were unsuccessful. So in this case, again, we went for transgastric rendezvous. The duct was accessed across the gastric wall, and contrast was placed into the main pancreatic duct. The stricture at the pancreatic jejunostomy was very tight that a straight wire would not go. So we had to use an angled wire and had to maneuver it across the tight pancreatic jejunostomy, almost like a fish swimming up a stream, and then finally got through it. Once we had the wire in the jejunum, it was easy afterwards. The pancreatic jejunostomy, the wire was secured, and over the wire, pancreatic jejunostomy was dilated using a balloon dilator, and 2 plastic stents were placed. So that helped with his strictured pancreatic jejunostomy and recurrent pancreatitis. For pancreatic stones, when retrograde access is not available, we go antegrade. And I'll show you this case where this patient who had Whipple for a neuroendocrine tumor now presents with with recurrent acute pancreatitis and new pancreatic duct stones. Here on the CT, you can see dilated main pancreatic duct with a large bright stone. So we started, again, regular ERCP with EHL, like I showed earlier, is not feasible in this patient. So we started with rendezvous. The duct was accessed in the body of pancreas across the stomach wall. And after puncturing, the tract was dilated using a balloon dilator. Now we have transgastric EUS guided access into the main pancreatic duct. So this gave us a working channel. And over the wire, then we passed the cholangioscope to allow for EHL. Here you can see the spyglass scope going from the stomach directly to the pancreas body. And through the cholangioscope, we could pass the EHL probe. And here you could see fragmentation of the main pancreatic duct stone in the body of the pancreas. The stone fragments are cleared. And after that, we left 2 stents, which will stay long-term. And it's been 4 years since this procedure, and the patient has done well without any recurrence of symptoms. Lastly, for disconnected pancreatic duct syndrome. Disconnected pancreatic duct syndrome occurs, it can occur after necrotizing pancreatitis, where part of the pancreas gets disconnected from the other part of the pancreas, meaning head would be draining across the major papilla or minor papilla into the duodenum, but body and tail have no place to drain. So these patients can be very difficult to manage because the disconnected duct that's in the body and tail cannot be accessed by a regular ERCP. So this is a 56-year-old woman with known chronic pancreatitis who was admitted with one more episode of pancreatitis and a large pancreatic ascites. You can see on the CT scan, the whole abdomen, there's a lot of fluid around. And CT and MRI both showed duct disruption. ERCP, when it was performed, showed leak of contrast in the region of body and tail of the pancreas. So we could not access the disconnected tail of the pancreas. So here we are going for EUS-guided direct access of pancreatic duct in the disconnected body and tail. Because the duct was leaking into the collection, it was small in size. We accessed with a 22-gauge needle and 018 wire. You can see the wire going into the area of leak. So we coiled it there. And over the wire, we place a 3 French pancreatic or gastrostomy stent. It's a very small stent, easy to push through a gastric wall, and it could be left in. So patient did well, the symptoms got better. But then she presented a few weeks later with abdominal pain and fevers. CT was obtained in the ER, and now you can see a fluid collection between the stomach and the pancreas. Now, why is that? And you can see the pancreatic stent going through it. This is because the gastric body is not connected, or there is movement between the pancreas and the stomach wall. With respiration movement, stomach wall would move away from the pancreas. When that happens, there can be a leak at the site of pancreaticogastrostomy stent. So we took out the stent and we chose a different site for pancreaticogastrostomy stent placement. If you look at stomach, antrum of stomach is actually, or pylorus and antrum, that area is actually relatively stuck to the pancreas. There's very little movement between the two as compared to the body of the stomach. So we chose a different approach. We went through the gastric antrum and got into the disconnected duct of the body and tail and placed a long stent going all the way from the antrum to the tail of the pancreas. And this helped her a lot. And I'll show you it helped her a lot. It led to resolution of ascites and all the fluid collections that she had around the pancreas. And she's done well now for the last 4 years. So what's next? There are a lot of new technologies coming out. We spoke about AI earlier today. US RFA for chronic panc is in the works. It is being used for neuroendocrine tumors. There's also some studies on pancreatic cancers. We spoke about pancreatic juice markers earlier today, which may over time become available for all of us. And also US-guided targeted drug therapy for pancreatic lesions. With that, I'll say thank you.
Thank you so much, Rajiv. And Jason, if I can invite you back. That was a tour de force, a good anatomy lesson for all of us. And now we'll take some questions and have some discussion for any of you who has questions about the interventional endoscopy section before we take a break. Chuck, I know you have a question. Kick us off.
Dr. Tom, that one randomized trial looking at, precuts versus not, 20% complication rate from precuts seemed to me to be very high, not in my personal experience. And I just wondered, I think it was your second case that the second high, recommendation of.
It was a tier 2 study, the transpancreatic versus needle knife. Are you talking about that one?
Yes.
Yes.
I mean, the needle knife complication rate seemed to me to be very high, 20%. Wrong?
I think it was 19% in the needle knife versus 12% or so.
Correct.
Yeah.
That's correct.
Yeah, it is. Yeah. Yeah. And if you look at the pre-cut data, they actually have a higher pancreatitis rate for many reasons. One, you are not placing a pancreatic stent if you're,
Right.
because these patients have multiple attempts at biliary cannulation. Many times
Right.
they have a wire that's passed through the pancreatic duct, and they don't end up getting a pancreatic stent, one. Two, you're delivering cautery at the
Right.
pancreatic orifice. That again leads to risk of
Right.
pancreatitis. So these are real world numbers. King of Wales Hospital, 9,000 ERCPs. It's a
Right.
big center, and these
Agreed.
are also expert hands.
Yeah.
So you can imagine how numbers are in community.
Yeah.
Okay, thank you. It looks like we have another question.
Yes, a question for Dr. Smarcena. With regard to the Triton system, and does it have the software capability for deep learning such that if you did 10,000, 100,000 colonoscopies using the system, could it learn to be autonomous without human use?
Thank you for your question. So the current iteration of that robot essentially takes all the manual control of the colonoscope and puts it in the controller, but there's really nothing autonomous. And I think, one of the things when we hear the term robotic, I think our mind kind of goes to autonomous when really it's almost like a motorized colonoscope. That's sort of where the state of the technology is. It's just taking what we do with our hands and our wrists and our shoulders and making it motorized. And there's motors and that are moving things and deflecting the tip of the scope. There's motors that can move the tool, but there's really nothing that is really AI related in the robot currently. But I think when you think about something that's motorized, you think, well, the next logical step is to make it automated, and I think that is a possibility, and I think there's people that are concerned about that, and I think they should be, but I think also having a platform that kind of moves consistently, moves the same way, visualizes things, and also can be sort of controlled and layered like AI algorithms on it. I think that can help actually improve quality as well. There's I think the current iteration though is really just a motorized colonoscope, and we're not seeing any we're not working on anything related to AI yet.
Can I ask a question, a follow-up to that? In terms of advancing the scope, can you describe, did that change at all? I mean, are you advancing it using the controller?
Yes.
Okay.
Yeah.
And then what was the pace? I don't know if I caught that in terms of the pace of the advancement versus, because you were mentioning the kind of doing complex right colon, procedures. I can see the, kind of the need to be very kind of methodical and slow, and just tell us a little bit about that experience.
Yeah. So it's in this first trial, everything was slowed down.
Mm-hmm.
Like the motors were very slow. Everything was really slow, frustratingly slow. For somebody that's we're the three of us.
It's like self-driving mode in your Tesla.
And you're in chill mode like the whole time. You're in sloth mode, chugging along. But the next trial, we're going to do some where the focus will be like cecal intubation time and that sort of thing. I think they are going to kind of, it's not going to be Mad Max, but it's going to be getting there.
Right.
Yeah.
Because it seems like just like Gareth and I were talking with like robotic assisted surgery, like prostatectomy, the fine motor control is what the surgeons rely on. It's not like it's replacing their surgical skill, but it is enhancing it so that they could be very specific with the margins, for example, for a prostatectomy. So it seems like maybe that's also another why that slow kind of methodical movement could be very useful if you're kind of taking out a large polyp or doing something more complicated, in particular, like in the right colon.
Yeah, I think, therapeutic endoscopists, especially resectionists, are always looking for like better control. And I think, now I use that Pathfinder device to do like a right colon, EMRs or ESDs like regularly, because I think it's just a nice stable platform to do these things. But I think, the therapeutic resection space is too small a market for a robotics company to go after. And so I think going after sort of general endoscopy, also makes sense. So I think a lot of the things that, make it a good therapeutic robot actually make it a pretty good, diagnostic colonoscopy robot as well. But I think the speed is something that everyone's concerned about.
So in case anyone else has any questions, feel free to come up to the microphone. Otherwise, I'm going to ask another question. It's kind of related to what, Rajiv, you were talking about during many of your abstracts, and it's related to this concept of using the robotic assistance. Do you think that it could be helpful also for things like complicated cannulation, difficulty, or maybe even helping with stenting, and you have a patient that might be moving a little bit, you have breathing kind of variability. I don't know, that seems like another useful kind of potential.
Yeah, I think the technology is either there or it's being developed. And what I see now is that technology is ahead of us and we are following, actually. We are slow in adopting. But if you look at all these big companies who are working on these newer techniques and newer devices, they're much ahead of us. So there'll be a day, I think, in a few years maybe, where robotics or AI-assisted cannulation and stent placement would be there. And why not? Because it makes the procedure safer and increases the technical and clinical success rates. So it should be there. What do you think, Jason?
Yeah, I think we sort of kind of gone through this a little bit, and with the AI story as well. You're trying to train an AI to be, as good as the gold standard, and in a lot of cases, the gold standard can be really, really good, like pathology. But whenever the gold standard is not so strong, like it's like, one expert or 5 experts, then it's a little bit more difficult to train. And I think the problem with cannulation is it's such a nuanced, procedure, which requires almost like subconscious things happening. And I mean, I think, it's one of those things where, I've seen like really, really amazing endoscopists like try to cannulate, and then, we've had fellows come from different countries and cannulate, and they're training on EUS, but they're really good ERCPs in their home country, and then they can't get in. Then John Lee walks in and like 30 seconds he's in. It's like there's something to that, but we can't like download John's brain onto a computer and like
yet
Neuralink,
so, John's brain.
Yeah, but I think but there's definitely other tasks that are absolutely trainable. And then, one of the things that I'm going to get into a little bit in my AI talk is like Barrett's dysplasia detection, which is like, I think if you look at, the general endoscopy community, I think this is one skill set that probably that everyone would admit, like, yeah, I could do better at that.
Right.
And can you train that? You can, because pathology is the gold standard. You've got lots of experts that can call dysplasia better than other experts, or better than others, and you can definitely train an algorithm to do that. And would that be clinically helpful? Yeah, I think it would be.
Yeah, Jason, to your point, like what if you had a device that had real-time EUS along with fluoro imaging, So there, the technique or the technology will help you cannulate much faster, much better, right? You can easily see where the cannula is going, and the device itself would do all the interpretation. Even you don't even need a human eye to interpret, So yeah, the technology is rapidly changing, and it's just mind-boggling,
I think, a lot of these sort of ideas that they kind of don't reach the surface because a lot of these things aren't commercially viable. And so there's so many things we could do with AI that don't require FDA approval, don't require any regulatory, but would they help patients? Absolutely. Would anybody buy it and pay extra money for it? Probably not. And that's where everything just stops.
Right.
And so I think now though, I think the startups have sort of like sorted themselves out, they've partnered with who they need to. And I think now, I think it's time for academic institutions to kind of get together and sort of work on these meaningful things that are actually going to help the field and help patients. And, if they're not commercially viable, that's okay. But I think there's a lot of work to do in the AI and robotic space that I think it can definitely improve quality and help patients.
Okay, everyone, we're going to get started for our last session. And we have a couple of really great sessions in terms of our abstracts of our upper GI and motility studies from DDW, as well as a couple of state-of-the-art talks. So we're going to bring it on home. It gives me great pleasure to introduce another one of our visiting speakers, Dr. John Inadomi, who is the chair of internal medicine at the University of Utah and a leading expert in gastroenterology and health services research. His work focuses on colorectal cancer screening, esophageal diseases, healthcare quality and evidence-based care, basically everything in GI. He's going to be talking about a group of abstracts and then a state-of-the-art talk. He's authored numerous publications, held leadership roles in basically every major GI organization. And another person who came to UCLA as a visiting professor, I remember I was a fellow. He looks exactly the same, and I've aged exponentially. So please welcome Dr. Inadomi here.
Thanks so much, Eric and Gareth. I grew up right around the corner here in Costa Mesa. Actually, is there anybody here actually from here? Oh my gosh. And does anybody know where Estancia High School is? No. Everybody here talks about Newport Harbor High or Corona Del Mar, or even I saw Edison, but like nobody knows where I went, which is Estancia, the home of the Eagles. Anyway, but it's nice to be home. And thanks so much for the invitation. And so I'm splitting my time with Amanda. We're talking about the upper GI. Turns out I'll do everything Barrett's, and Amanda will do everything else in the esophagus. Okay, I actually don't have any financial disclosures. So I have one thing in EOE, because I figured it was pretty cool they have injectable fluticasone. And I'll see how many I get through, because I certainly want to make sure that we don't go overtime, all right? So this is one. This is actually, most of the time in EOE, and Amanda's going to go to this, but, swallowed kind of steroids or other types of things. This was actually using fluticasone injections. And basically it's a single baseline injection, but it was kind of a dose ranging and a safety study. So they did 1 milligram in 4 quadrants up to 8 milligrams in 4 quadrants at 5 levels. And they followed the patients up from 24 to 52 weeks, depending on the cohort. And they did endoscopy at baseline and then endoscopy at follow-up. Now, it wasn't a clinical outcome study, so it wasn't like dysphagia or things like that, but we looked at the peak eosinophil count and the EOE histology score. And the bottom line is that the peak eosinophil count was reduced by up to 80% at week 12 and 65% at week 36, and about 59% actually achieved remission, which is less than 6 EOs per high power field. And then I don't know much about the score, but the bottom line is in both these things, the score of eosinophils inflammation also reduced. So the conclusions of this is now we perhaps will have a endoscopic therapy, injectable fluticasone for EOE. We're going to go very quickly through this thing. So the other part is that H. pylori. You know, this idea that, H. pylori chronic infection causes atrophy and parietal cell atrophy, reduced gastric acid, and can protect against Barrett's esophagus and esophageal adenocarcinoma. And so there's a concern at the reverse, right? If you got HP that was protecting you and then you eradicate it, then, acid comes back and then you're going to get reflux disease and you get cancer, right? And so this is a study that was Northern California Kaiser looked at over 817,000 people tested for HP, and it compared three groups: people who are HP negative, and then people who are HP positive who are treated or untreated, right? And so the bottom lines here, the graph on the right, or table, no, it's a graph on the right. You see the baseline is people who were negative for HP. That's a reference, that's the top little dot, right? And then what they really did is compare to the bottom part, which is the people who are HP positive and treated. And what they said was, look, statistically, there's no difference in the incidence of esophageal adenocarcinoma after Helicobacter pylori eradication. So, hey, no worries. I think that's true, but if you look at one thing, they don't really call this out, but if you look at that middle one, that's a positive untreated, it actually looks like they have a lower rate. Now, the confidence intervals are really wide, but numerically, it looks like, wow, if they had a few more patients, maybe that would be protected. So anyway, but the bottom line, statistically, there was no difference. And in this case, if you got HP, treat it. There's no good HP, right? And that's the bottom line there. Let's move on. Oh, so this is interesting. It's a molecular age of Barrett's esophagus. You may think, like, what, this is a really pointy head kind of study. Why would you even bring this up? Two reasons. One is it's done by one of my, when I was at University of Washington and the Fred Hutch, I was on the dissertation committee of a PhD student in applied mathematics, Curtius, not a physician. Brilliant. Anyway, but she had done some studies looking at kind of the age of Barrett's. Could we predict the age of Barrett's? And now she's a faculty member at UC San Diego. And so what they did is they took a bunch of patients and they looked at biopsies of Barrett's esophagus as well as the surrounding normal squamous tissue. And what you do is you look for what we call clock genes and methylation of clock genes. Now, methylation is this epigenetic thing. And if you methylate stuff, you can turn genes on and turn genes off. All right, that's really all you know about epigenetics. And then it's not like a oncogene, which is a gene that turns on the cancer, right? Or a tumor suppressor gene that prevents cancer. These are clock genes, but it kind of basically tells you how old the tissue is, or the clone of tissue, right? So what they do is to compare the squamous tissue to the Barrett's tissue and look back, and through some mathematical modeling, they can determine when did that clone of Barrett's arise. And it's kind of a cool thing. I'm not going to go into a lot of details, but basically on the figure here, every column is an individual patient and every row is a different kind of one of these genes. And all you want to know is that the vast majority of these things aren't hypermethylated, and that's the blue stuff, right? But the stuff that gets kind of orange and yellow, that's the stuff that has the methylation of these clock genes. And what they find, if you got to understand, I'm not going to go into all the wonky math, but the bottom line is that you can actually see when that clone of Barrett's tissue arose. And we find right here is that the predicted BE onset age was about 29 years. So young, right? And so that means a couple of things. One is that Barrett's start pretty young, right? We don't actually know why it starts, by the way. We know it has to do with reflux disease and maybe some genetics and things, but it's interesting. A couple of things. One is that most likely if you start screening people at, let's say, 50 or 40, you're going to find Barrett's in anybody who's going to develop it. And most of the time, if you try to screen later than that, not many people actually develop Barrett's after that. So a couple of things. One is probably one-time screening is enough. You can probably do it early. And once people have, if you don't have Barrett's when you're young, you probably won't develop when you're older. Okay. This is actually so Rebecca Fitzgerald is the one who did the cytosponge. You probably heard about her. So cytosponge, for those of you who don't know, is kind of like a little, well, it's a sponge, like a little Brillo pad. It's in gelatin on a string. And it's supposed to do endoscopy. What they do is you swallow the little gelatin capsule, goes in the stomach, the gelatin dissolves, that little sponge like pops open, and then you pull the string out through your mouth. I've done it myself. It does kind of, I wouldn't say it hurts, it's like, little uncomfortable when it pops out. What it does is collect cells of the esophagus. also of the cardia. And it looks for something called trefoil factor 3. And what that is a Barrett's it's a marker for intestinal metaplasia, not dysplasia, but for intestinal metaplasia or Barrett's esophagus. And so basically what they did here, the best 3 was actually a study looking at a screening population, and the people who were positive got an endoscopy, and they published these things. But if you don't do an endoscopy in everybody, and they actually didn't, right, then you don't really know the sensitivity because you don't know who you're missing, right? And so what happened is that they followed these patients for a median follow-up of 6.9 years. And I want to go to a lot of details, but the bottom line is they look at the people who were negative, and only a small proportion have actually got endoscopy. But they figured if they follow them for like long enough time, right, they'll see whether or not they missed anybody, even if they didn't do endoscopy. And the nice thing is they see here is that on the bottom graph, you can see that over follow-up, that only 1 cancer was found. That's actually a gastric cancer, not esophageal cancer. So what this group now says is, hey, look, even though our original study, we didn't scope everybody, so we didn't know what the actual sensitivity is. Certainly after about 6 years, we know that if you're negative by the cytosponge, you're not going to develop cancer. So that's what their overall conclusion is right there. Okay. I'm going to be having a little bit of a discussion about this because I'm going to talk about the AJA guidelines in my next talk. But the big question is, what is a risk of esophageal adenocarcinoma or high-grade dysplasia in people who have really ultra-short segment Barrett's, meaning intestinal metaplasia and columnar line esophagus less than 1 centimeter, or let's say at a irregular Z line or the GE junction. I know we all biopsy that stuff, right? Well, what is the risk of cancer there? And so this is a really important thing because it questions is like, well, should we actually do surveillance in this group? So when they did this, I want to just point this out. And if you look at this, there's on the top, it's ultra short segment, which is less than 1 centimeter of the tubular line esophagus. And then below that, the 2 rows below that, it's 1 centimeter more of Barrett's. And you can see here, there's like 100-fold increase risk in people who have more than 1 centimeter or more compared to people who have less than 1 centimeter, or who have just an irregular Z line, or who we biopsy the GE junction. And so the bottom line here is that if you look at this, it's like 0.043 per 1,000, which is like, 4 per 10,000 versus 757 per 10,000. Now it's still pretty small, even if you have longer segment Barrett's, but it's 100 times less common to get high-grade dysplasia or esophageal adenocarcinoma if you have short segment Barrett's. We'll come back to that when I talk about the guidelines. All right. The other part is like, when should you stop surveillance? So once you have a patient, we did a lot of screening, we got a whole bunch of patients with Barrett's. What point does it become kind of pointless to actually continue surveillance? And it says current guidelines recommend surveillance intervals, but don't define a stopping age. Prior modeling studies suggest surveillance discontinuation should vary by age, sex, and comorbidity. Actually, I did some of those old modeling studies that suggested that. But this particular group actually, and this is Satchawani of University of Colorado, who really studies this a lot, looked at a population-based cohort study, and it's from Norway, Sweden, Finland, Denmark, which is again, particular region that has a high incidence of Barrett's esophagus and esophageal adenocarcinoma. And what they looked at is basically kind of time trends in the incidence of esophageal adenocarcinoma and the mortality. And they stratify by age and sex, comorbidity, and those kinds of things. It's a complex graph on the right, but I wouldn't worry so much. The top part of the graph is all men. The bottom part of the graph is all women. And you can see here the different columns are, what's the risk of this combined high-grade dysplasia and cancer at age, I think it's like 73, 75, 77, 81 or something like that. It's kind of a weird intervals. But there's a couple things you want to know here. First is that once you get to age like 75 or 80, the incidence of non-esophageal adenocarcinoma far outweighs any risk of esophageal cancer. That's the first thing. So you're far more likely to die of other things, heart disease, lung disease, getting hit by a car, all those things, much more common than dying of esophageal adenocarcinoma, even if you have Barrett's esophagus. That's the first thing, right? Second thing is that if you look at the data, I'm not going to go into each little detail, but you can see that the increase in comorbidity is a much greater indicator of mortality than age. And now that I'm 64, it makes me feel good, right? So it's actually, it's physiologic age, not chronologic age, that really determines your outcomes. And so here what we recognize is that you just can't use chronologic age as a reason, oh yeah, we can stop screening, let's say in colon cancer, be 85, forget it. Here, especially in people with Barrett's esophagus, you usually have a lot of other comorbidities because the things that cause Barrett's and esophageal cancer, things like obesity, things like smoking, other things that probably indicate diseases like cardiovascular disease, neurovascular disease. And it's a comorbidity that really should indicate when you should stop screening as opposed to your chronologic age. So I think that's actually really important to know because it does indicate, let's think more broadly, let's just not think about the actual chronologic age, but the comorbidities of patients, all right? Okay. Oh yeah, and to that end, here's one abstract. Actually, this is by Sachandwani again. And so what they did here is they tried to figure out, well, we've been screening and surveilling and doing a lot of stuff in Barrett's for, 20 years. Seems like if we're doing this, we should have some kind of effect. Like maybe there should be a reduction in esophageal adenocarcinoma incidence or mortality or something, because we're doing a lot of endoscopy, a lot of expense. All right, so what they did here is they looked at SEER. SEER is this national database of cancers that actually kind of samples something like 85% of the US population. And in this, looked at these SEER data, and about 22,000 patients esophageal adenocarcinoma. And they basically look back and say, hey, what's the age calculated or age adjusted incidence and mortality rates? And they did some statistical stuff that I really want to go into, but they really want to look at time trends and incidence and mortality from esophageal cancer. Okay, and so these graphs, again, on the top, that's the incidence of esophageal cancer. On the bottom, it's the incidence-based mortality. And basically, what they really want to show is the things that diverge quite a bit. You see that men have a much higher incidence and mortality from esophageal adenocarcinoma than women, which are on the bottom. And the blue line is actually the average, which I think we talked about at one of these lectures. Probably shouldn't average it because there's a big difference between men and women. And then each of these you can see actually also by race. So it's the black people, white people, non-Hispanic white people, and other groups. And it really is, you can see that it's the white men that actually do have the highest incidence and mortality. But the thing that's actually concerning to people who write guidelines and do this stuff is we haven't done anything to impact the incidence or mortality from esophageal cancer. If you look at this, it's like the same incidence, it's the same, it's pretty depressing. So the conclusion really is that current efforts at screening and surveillance really have had a little limited, if no impact, right, on getting earlier stage esophageal cancer diagnosis. And these, again, the other part is that there's, the question is, why is it that we're not making a difference? And I'm going to talk a little bit out. My next talk is, I just think we're screening the wrong people. We're screening the wrong people, we're doing surveillance on the wrong people, and we get a lot of stuff going on, and we're not making an impact. And this particular study actually kind of illustrates that we're not doing much in the way of impacting this. All right. I'll make this my last one. That way we can get going. And so I know the next talk, every talk has something about AI. So hell, we got to have AI, right? So the question really is real-time AI. A lot of these studies about AI and endoscopy are using videos or static things. This is real time. Like when you're doing endoscopy, what happens when you use some kind of AI? And we had a talk earlier, and it's great. I'm learning tons of stuff, but computer-aided detection, that's just, can you detect Barrett's or Barrett's neoplasia? And in this case, also diagnosis. Can you actually characterize, can you characterize this? And can you figure out whether people have dysplasia or cancer? Can you figure out whether or not people actually need therapy? So this is a multi-center prospective study across 3 tertiary referral centers. And basically the gold standard was expert endoscopists, which is a little bit odd. It's wow, how do you know that they're the best? But this is what they did. Expert endoscopists, white light endoscopy with narrowband imaging, right? And then they used the CAD detection, really, to look at this thing, as well as the CAD diagnosis. And to cut to the chase, it was a small study, 182 patients. If you look at the kind of flow diagram, it's interesting that the AI device detected about 91% of the lesions that an expert endoscopist detected, right? So you think, well, AI is not as good as detecting these lesions as an expert endoscopist, right? But maybe we can get people who aren't expert up to the level of experts using this AI. And you can look at some of these things, and there's a certain amount, and the yield was, off and on, a couple of cancers, more hyperdysplasias, more low grades. The other part that's quite interesting is looking at the people who didn't have a visible lesion, but actually did have a detected lesion on the AI. And so in that particular case, the CAD diagnosis reduced the false positive detections from 0.63 to 0.31, so about in half, but the false positives were pretty minimal to begin with. So, part of the problem here is we don't know what the gold standard is. It probably should be a combination of endoscopy and biopsy and things like that, but it's hard to know when you have a new device and you don't know what the gold standard is. But the conclusions of this really is that CAD for detection had a high sensitivity, acceptable false positive rates, and the diagnosis part substantially reduced the false positive without really losing much in the way of true positives. So why don't I stop right there, because I said I think I have a lot more to talk about in my state of the art, but thanks so much for your attention. So.
Thanks, John, and thanks for coming back home to your old stomping grounds. Now it also gives me great pleasure to introduce one of my colleagues at UCLA, Dr. Amanda Kraus, who is a gastroenterologist and assistant clinical professor of medicine in our division. She did her esophageal and motility fellowship at UC San Diego, and she specializes in esophageal disorders, including GERD, motility disorders, and swallowing conditions. And her clinical and research work focuses on integrating dietary, lifestyle, and behavioral approaches to improve patient-centered GI care, and she will continue the theme of upper GI and motility abstracts.
Thank you so much for the kind introduction, and thank you for inviting me to speak. So I am going to talk about upper GI top 10. Oops. There we go. No relevant disclosures. I will say this is in my opinion, so take with that what you will. All right, so the first one I wanted to talk about was botulinum toxin injection in the UES for retrograde cricopharyngeus dysfunction, or RCPD, the first results of a triple-blind randomized controlled trial. So this was a very hot topic at DDW, so I thought it was appropriate. So RCPD is something called abelchia. So it's essentially when patients can't belch, and so they get a lot of gas and bloating because they can't release that trapped air. There's been a couple studies looking at Botox or botulinum toxin injection into the UES, and it's promising, but there hadn't been any randomized controlled trials until now. So this was a randomized triple-blind sham-controlled trial, and they included patients who had symptoms suggestive of RCPD, and they diagnosed them using a belch provocation protocol, which is essentially when they have a patient drink a carbonated beverage and they watch as they are unable to belch that out during manometry. The primary outcome was a 50% or more improvement in the ability to belch on the visual analog scale at 12 weeks. And then they looked at this questionnaire called the Sydney Swallow questionnaire, which assesses for oropharyngeal dysphagia, which is a potential side effect of botulinum toxin injection. So 50 patients were randomized, similar baseline characteristics. So you can see here that the botulinum toxin injection group had much better outcomes at week 1, 4, and 12 compared to the placebo group. And there was actually an 84% difference at week 12, which was significant. They did notice that initially the SSQ scores were a little bit higher in the botulinum toxin group, but they were similar at 12 weeks. So the bottom line here is that botulinum toxin injection into the UES is effective up to 12 weeks for RCPD, and the side effects generally improve by 12 weeks post-treatment. The next one was, again, into our AI theme, AI-assisted endoscopic grading of reflux esophagitis and polyp detection with convolutional and transformer networks. So we know that inter-observer variability in grading of reflux esophagitis is pretty poor. We know that it's very hard to detect differences between A and B. There could be mistakes made between B and C, and these can have clinical implications. So this research group developed a learning pipeline for high precision multi-class classification of reflux esophagitis and colon polyps. They used a curated data set. These were still images and they were single institutions images. They expanded the data set. They put the images into a trained validation and a test set. And they had 6 architectures fine-tuned under a unified training protocol. And then they used performance was assessed on held out test set using overall accuracy, class-wise confusion matrices, qualitative error inspection, and graded weighted class activation mapping visualizations. So you can see here that they performed very well. I mean, the most, I guess, efficient was the efficient net with a 99.84 accuracy. And there was near perfect discrimination between grades, and they were able to separate this from the polyp images that were also included. Errors were sparse, but I guess similar to endoscopists, it was mostly between LA, A, and B. So the bottom line is that maybe there is some hope that we can one day get some AI assistance to differentiate esophagitis classification. The next abstract was looking at GLP-1 receptor agonist use and its association with an increased incidence of GERD. And this was results from a 1-to-1 propensity match study. Since GLP-1s are a hot topic, I thought this was good to include. We know these have been associated with GERD. This study aimed to determine the incidence of new onset GERD after initiating a GLP-1. So this was 3 tertiary centers that were included. Inclusion criteria was if patients were highly suspicious of having GERD, an EGD and or wireless pH monitoring while on GLP-1 use for greater than or equal to 1 year. They excluded if they had this prior diagnosis of GERD, foregut surgery, a large hiatal hernia, opioid use, or PPI use within 3 months. They compared patients with EGD, who had an EGD who were not on a GLP-1, and then they used multivariable logistic regression analyses and 1-to-1 nearest neighbor propensity score matching based on gender, age, BMI, smoking, and diabetes. And they used the Lyon consensus to define GERD. So here you can see the difference in the demographics. There was more females in the GLP-1 group, and then there was also, as anticipated, more GERD in the GLP-1 group. So you can see in the adjusted analyses that GLP-1 use had a higher rate of objective GERD. And then they also found that diabetes was actually remained positive among all the analyses. And they looked at the different GLP-1s and they found that there was a consistent GERD association with the different types. So the bottom line is that GLP-1 receptor agonist is associated with an independently increased risk of objective GERD. So informative for our patients. The next abstract was budesonide oral dispersible tablet is superior to pantoprazole in patients with eosinophilic esophagitis, presenting initially with a food bolus impaction. So I thought this was very relevant since I think we all see this a lot in GI. So they were looking at the budesonide oral dispersible tablets and to find if they were superior to pantoprazole. This was a multi-center study, open label, randomized controlled trial. They randomized patients either to the budesonide oral dispersible tablet, 1 milligram BID or pantoprazole 40 BID for 8 weeks. They looked at histologic remission as a primary endpoint and then some histologic and symptom scores as well. Baseline metrics were similar. There was 40 in the budesonide group and 35 in the pantoprazole group. You can see here that there was a statistically significant higher response rate, I should say, in the budesonide group versus the pantoprazole. They found that both treatments actually improves the EREF score and symptom scores. And they looked at in the patients who didn't respond to pantoprazole, they then put them on the budesonide, and actually 92% had a complete response when they reversed that. So in the 6 budesonide patients who didn't respond, who were then put on pantoprazole, they had a 50% complete response. So again, bottom line here is in treatment naive adults with EOE who present with the food bolus impaction, budesonide was more effective than pantoprazole in achieving histologic remission. The next one is about PCABs, and they're associated with low rates of short-term adverse events, a global cohort study comparing PCABs versus PPIs. I think this is, again, one of those hot topics that people are interested in, given the new kids on the block. So this looked at the short versus term risks of vonoprazan versus matched cohort of PPI users. So this was a retrospective study using the TriNetX database, which has been used in a lot of research. They specifically looked at GI infection, pneumonia, and AKI because they were looking for some short-term effects. You can see the inclusion and exclusion criteria. They balanced patients based on demographics, medication use, and medical history. So this is just to say that the baseline demographics were similar. So there was about 8,000 per group, and there was significantly shorter mean follow-up in the PCAB versus the PPI users. You can see here, though, that the PCAB users had lower rates of AKI, GI infections, and pneumonia, but when they looked at the hazard ratios, the only difference were with AKI and pneumonia. And in sensitivity analysis, the treatment effect estimates were stable across all outcomes. So I think we can, say in this global cohort study, the risk of AKI, pneumonia, or GI infection was low with PPI or PCAB, and in a matched cohort, the risk of AKI and pneumonia was lower in the PCAB versus PPI users. So I think this is good information that we can prescribe, we can talk to our patients about, but obviously long-term risks are probably what people are also quite concerned about. All right, the next study was on neuronapride and idiopathic and diabetic gastroparesis. This was results from a phase 2b randomized control trial. I think we all struggle with gastroparesis, and so I wanted to include this study because this sounded pretty promising. So it's a locally dual-acting 5-HT4 agonist and D2 antagonist with GI prokinetic activity. It's been shown to improve gastric emptying, GERD symptoms, and constipation, and it has a pretty favorable safety profile. So this was an international randomized placebo-controlled phase 2b study in adults with moderate idiopathic gastroparesis, and they were randomized to either neuronapride 10, 20, or 40 TID for 12 weeks or placebo. So 328 patients were randomized. You can see that essentially this is the 10 milligram, the 20 milligram, and the 40 milligram doses, and then the placebo. So when compared to placebo, there was a significant improvement in the GCSI scores of the 20 milligram and the 40 milligram dose. And it also improved quality of life and gastric emptying. There wasn't actually any benefit of the 40 over the 20. And there was adverse effects were minimal. There were some dose-dependent GI motility effects, which would be as expected. There was higher discontinuation rate with the neuronapride versus placebo, 10% versus 2%, but serious adverse events were pretty uncommon. And there was no cardiac or prolactin-related signal versus placebo, which is, I feel like, great for a gastroparesis space. So the bottom line is that neuronapride at 20 and 40 milligrams significantly improved gastroparesis symptoms and accelerated gastric emptying, and it's pretty well tolerated. So this is really hopeful, I think, because I know gastroparesis is challenging to treat. So this next abstract I thought was very fun. Is singing therapy versus diaphragmatic breathing for supragastric belching. This was a multi-center randomized controlled trial. So we know that our patients with supragastric belching have, significant quality of life impairment, and diaphragmatic breathing is a first line intervention. And so the authors of this paper were talking about how this is like very non-engaging. People have trouble following this. And so they suggested that perhaps singing therapy would be more engaging. So this was a small study, 72 patients. They diagnosed with supragastric belching. They were randomized to structured singing therapy or diaphragmatic breathing. They looked at a 50% or more reduction in belching on visual analog scale. And they assessed at baseline 1 week and 1 month post-treatment. So they found that singing therapy had led to significantly higher response rate versus diaphragmatic breathing. Superiority was maintained throughout follow-up, and that the secondary outcomes yielded persistent improvement. Predictors in response were singing therapy, older age, and higher baseline belching scores. So another option in our toolbox of treating these supragastric belching patients, especially if they're having trouble keeping engaged with diaphragmatic breathing. This next abstract was dupilumab improves esophageal distensibility in adults with EoE. The 24-week results from the randomized placebo-controlled trial, remodeling with dupilumab and EoE. So we know that EOE can lead to pretty bad fibrosis, leading to reduced esophageal distensibility and esophageal stenosis. And so this was adults were randomized to 2-to-1 to dupilumab versus placebo, and they were looking at the change from baseline in the esophageal distensibility plateau versus placebo at week 24 as measured on EndoFlip. So we can see here that the groups were pretty similar from their baseline characteristics. So 69 patients were randomized. Stratification was based on the dilation history. We found that there was an absolute change in the distensibility plateau, percent change in distensibility plateau, and the difference in the EREFs, the histologic scoring, grading, and stage scales were all improved more significantly with the dupilumab versus the placebo. So dupilumab was well tolerated. There were no serious adverse events. And so the bottom line here is that in adults with EOE treated with dupilumab, they had significant improvements in esophageal distensibility at 24 weeks when compared to placebo. And significant improvements were also seen with endoscopic and histologic parameters. So something to consider when we're treating our EOE patients. All right, number 9. So transforming amoxicillin therapy into a grade A eradication regimen with vonoprazan and bismuth, a multi-center randomized trial. I was very interested in this study because I feel like I do see a lot of patients coming with H. pylori, and if this is a pretty effective therapy, it sounds like it might be pretty well tolerated compared to some of our other regimens. So performance of the high-dose amoxicillin PCAB for H. pylori therapy is variable. So they were looking at comparing the efficacy and safety of a 14-day bismuth amoxicillin PCAB, which they termed as BAP triple therapy, with amoxicillin PCAB dual therapy, AP, and then clarithromycin-based triple therapy, or CAR, for H. pylori. So this was a multi-center randomized open label trial in adults with H. pylori infection from 7 different centers in Taiwan. The primary endpoint was eradication in the modified intention to treat population. 390 patients were. The antibiotic resistant rates were 1.7% to amoxicillin and 26.2% to clarithromycin. So you can see here that in the intention to treat, the modified intention to treat, and the per protocol, the rates of clearance of H. pylori was quite high with the bismuth, amoxicillin, and the vonoprazan triple therapy. And that was significant when they compared that to the AP and the CAR therapy. The adverse events rates were pretty similar. So I certainly hope this can get added into our guidelines at some point, but this study basically showed that amoxicillin, vonoprazan, bismuth increases eradication of H. pylori compared to both just the vonoprazan and amoxicillin dual therapy or the rabeprazole, amoxicillin, clarithromycin triple therapy. The last study that I wanted to talk about was blown out myotomy in short versus standard myotomy during per-oral endoscopic myotomy, and these were 3-year follow-up rates from a randomized controlled trial. So a blown out myotomy is essentially this like pseudodiverticulum or outpouching that forms at the prior myotomy site. It's thought that longer myotomies may predispose patients to developing this. It can cause persistent symptoms in patients with treated achalasia. So this was 64 patients with type 1 or type 2 achalasia. They were randomized to either a short 4 centimeter or a standard 8 centimeter myotomy. They defined a blown out myotomy as a 2 centimeter larger diverticulum at the prior myotomy site with a greater than 50% increase in esophageal diameter on the time barium esophagram. They did follow-up testing at 6 months, and then again, if persistent symptoms. They defined success as an Eckert score of less than or equal to 3, and failure of the POEM as an Eckert score of greater than 3. So here you can see the standard length myotomy and the short length myotomy differences. Baseline were pretty similar. I guess there was slightly longer symptom duration in the standard myotomy length. And then when we look at the results from 6 months, there was pretty similar rates of a blown out myotomy. They weren't significantly different. But then when you look to the long-term follow-up, it's trending towards significant difference with the standard myotomy at 23% versus 5% in the short myotomy. So the bottom line here was that there was no difference in Eckert score between short and standard myotomy, but there was a trend towards higher BOM in standard myotomy, and 50% with BOM had POEM failure. So I think more work needs to be done in this area with larger studies, but I think this is an interesting finding and certainly something that's highly relevant to our patients undergoing myotomy. So that is all I have. Thank you for your attention.
Thank you, Amanda. And now I'll invite Dr. Inadomi back for his state-of-the-art talk, and then we'll invite Dr. Kraus back and we'll do some questions for both of them. Thank you, John.
Okay, if you didn't get enough Barrett's the last time, you're going to get a ton of it here. And the reason is, among the things I do, I've been working with the AGA, and it's, here we go. On the newest AGA guidelines for Barrett's esophagus. So we've had, we're working on our third one right now. So it's kind of nuts. This whole process is called the grade. It's a very rigorous thing, but we've been meeting, I don't know, every Tuesday at 7 a.m. for the past 3 years. And you're going to look at this like, oh my gosh, John, what a waste of time. But anyway, what we're trying to do is really have as best evidence we can for both screening, surveillance, and treatment of patients with Barrett's to prevent esophageal adenocarcinoma incidence and mortality. And so I'm going to start with back in 2011, which was the last time we actually had the AGA guideline for Barrett's esophagus. At that time, you had to have heartburn symptoms, and most of the time, you guys realize that's the trigger: heartburn symptoms, acid regurgitation or heartburn, plus something else. In this case, maybe age greater than 50, male sex, white race, obesity. Sometimes you put smoking, family history. Need something in there, right? But everybody in general starts with, okay, only people with heartburn symptoms. I'm going to challenge that, right? And then back in 2011, we said, if you don't have dysplasia, then somewhere between 3 and 5 years, which is, let's make up your mind. Is it 3 or 5? So we'll get to that. In low-grade dysplasia, again, back in 2011, it was mainly suggested to do surveillance. A couple of reasons. One is difficult to know what the actual natural history of low-grade dysplasia was. And the second part was, how good is therapy, especially in this case, I would say radiofrequency ablation, EMR, ESD, and we have some more information. And then treatment here, really high-grade dysplasia was a trigger for endoscopic eradication, not low-grade dysplasia, and esophagectomy for cancers. So that was then. And now here's a 2025. Actually, I was going to say 2025 and 2026. We have 3 different guidelines. I will tell you a couple things. So even though I couldn't write this down on the screening part, as I said, we've known for like 20 years, maybe 25 years, ever since Jesper Lagergren had a great epidemiological paper showing that 40% of people who develop esophageal adenocarcinoma never report severe reflux symptoms, right? So the whole point is that we've been trying to focus our screening and then surveillance, of course, on people with reflux. Now, yes, reflux symptoms increase your risk of esophageal cancer, but 40% of people don't have it. And so this has always been bothering me, right? So what we've done now, and then in the process of it, and hopefully you'll see this when we finally get it published, is that we're using new scores, and the one we're using is a Kunzman score. In the past, it's been kind of cumbersome to use, but now with AI and everything in the electronic record, it's pretty easy to be able to load all this stuff in it. And it's not rocket science, right? It's age, sex, BMI, smoking, and reflux symptoms. So reflux symptoms are there, but you can also, if you have enough other factors, such as, let's say if you're a 50-year-old man and you're obese, and you don't have reflux symptoms, we still think you're at high risk. You should get screened, all right? So I can't show you all these things right now, but the new guideline from the AJ will say there's ways to trigger screening even if you don't have reflux symptoms, right? So we'll get to that. And again, it'll be, I think I believe that'll be the biggest way to be able to expand the population of patients who are eligible for screening. A couple more things is that we now say anything less than 1 centimeter of Barrett's, we don't do surveillance. And again, I saw that abstract. I'll show you even a larger systematic review of this that really does support that. If you have Barrett's that's between 1 centimeter and 3 centimeters, 5-year interval. And if it's 3 centimeters or more and no dysplasia, it's a 3-year interval. Now we're actually, once you have low-grade dysplasia, that's actually confirmed, and I'll talk about what that means in a second, but low-grade and high-grade really should trigger endoscopic eradication therapy. And even with T1-8 cancers, endoscopic eradication with EMR or ESD really is a standard of care, and other more advanced forms of cancer trigger esophagectomy. So a lot of new changes there. The ACG is very similar. I'm going to say that basically their updated guidelines came out. And the same kinds of things, but they're very similar recommendations, with the exception of that using endoscopic eradication therapy for actually all kinds of diseases. But in terms of the ACG, I'm going to skip most of this stuff. But even there, basically, it was saying chronic reflux symptoms and 3 or more additional risk factors as male sex, age greater than 50, white race, smoking, obesity, or family history of Barrett's or esophageal adenocarcinoma. Again, what I'm proposing, and you'll actually see this when we do publish, is that I think reflux symptoms are important, but there are people who we can screen who do not have reflux symptoms. This is just to remind me a couple of things. One is that when we do actually do screening and surveillance, a careful endoscopic evaluation is necessary. Just like when we do colonoscopy, we should be able to detect certain things, right? A couple of things here is that everybody should get high definition white light endoscopy, plus also chroma endoscopy. Now, you don't have to put on dyes. It could just be a virtual chroma endoscopy. You just flip on your MBI. Every endoscopic manufacturer has their form of enhancement, but NBI is one of the easy ones, right? So high definition white light, use chroma endoscopy, either dye or virtual. And the other thing you see here is using a cap. All right, the cap actually is just almost like a little banding cap, a little bit shorter. But the reason you use that is because when you want to inspect things, when you're doing endoscopy, that you get your face into the side of the esophagus, it's really hard to see. But the cap actually keeps it away from that. It stabilizes the area of visualization. And you can really detect a lot more dysplasia. Almost all dysplasia, I say almost, but almost all dysplasia you can see endoscopically if you actually look hard enough. It's just a matter of we're not looking hard enough, not spending enough time. So quality is a huge thing. Now, again, I talked a little bit about an abstract. This is actually the cytosponge. There's 3 different devices. Actually, cytosponge is not available in the US, but there's actually EsoCap and EsoGuard. There's a variety of things, but these are non-endoscopic, swallowable, either catheter-based or sponge-based devices. There's office-based, no sedation, and actually we find that it improves detection versus usual care, which is actually just using endoscopy based on reflux symptoms, right? So this is actually the guideline now for surveillance, switching from screening to surveillance. I'm going to go into more details. You don't need to memorize this part. But again, looking at once you have Barrett's, what should we be doing? So the language I know when we look at the grade process, it looks it's a little bit cumbersome, right? So in patients with non-dysplastic Barrett's esophagus, the AJ suggests performing endoscopic surveillance compared to no surveillance. It's a conditional recommendation. So when we say suggest, it means conditional. It means it shouldn't be like a quality measure. If we say recommend, that's actually a higher level, right? It's a higher level of recommendation. But because the data are not perfect, of either low or very low quality, we're not comfortable saying that this is a actual recommend. It's a high level recommendation. So we're saying suggestion here. But almost everybody does surveillance. Otherwise, why would you do screening? And so I talked a little bit about that one abstract about, supporting not doing surveillance in people with less than a centimeter of columnar lined esophagus. And this is something, this is a meta-analysis we did within the AGI guideline group, looking at a variety, in this case, 6 studies, looking at the risk of high-grade dysplasia or esophageal adenocarcinoma as a composite endpoint in people with less than a centimeter columnar lined esophagus. And you can see here that if you look at this is the summary. You don't worry about if it's common or a random effects model. But the bottom line is about pooled incidence about 0.1 per 100 patient years, right? So basically, it literally is 1 in 1,000. So with a risk of 1 in 1,000, it really doesn't make sense to be focusing on surveillance. If I was going to do this right, I'd say screen more people and do less surveillance, right? Figure out who needs to get treated quickly and then kind of ignore the rest. That's what I'm trying to get at. But the risk is so low, and we've seen more and more evidence of this, and people with less than a centimeter or irregular Z-line or just right at the GE junction, right? I don't think this is relevant. Okay, surveillance. And so what we've now suggested is that people with columnar-lined esophagus less than a centimeter with intestinal metaplasia without neoplasia, now we suggest against endoscopic surveillance. All right. So the other part is, once we characterize this particular diagram, you want to have a couple things. The first actually is on the right side is how to characterize that using the PROG classification. And so first of all, you got to identify the top of the gastric folds, right? Where this is the beginning of the columnar of the esophagus. And of course, it's hard to do sometimes when you have a hiatal hernia, which almost all patients have with Barrett's, but you see that depicted on the right there. And so the PROG has a circumferential or C, and then the maximal, the M. And so the circumferential, where you see the salmon-colored mucosa above the level of gastric folds, you're going to say, well, that's the circumferential amount. And then any kind of tongue above that is the M part of the PROG. So everybody has a C and an M. The other thing on the left panel right there is how do you actually do surveillance? And the first thing you do is targeted biopsies. Take your time. As I showed on the other end, high definition, white light, use your NBI, use a CAT. Most neoplasia, again, is visible, right? So biopsy any visible lesion, whether it's a little erosion or whether it's a little bump or whether it's an ulcer. That's the kind of stuff that actually is neoplasia. And then once you do that, the targeted biopsies, then you actually have the Seattle protocol. What that is that every 4 quadrant biopsies every 2 centimeters in people who don't have dysplasia, or every centimeter in people who do have loga dysplasia, if you're going to do surveillance and not therapy. But basically, that's what those are the biopsy protocols. And on the bottom is just really briefly the Paris classification. The type 1 is going to be the polypoid. Type 2 is either going to be either slightly raised or slightly depressed. And type 3 is actually going to be the ulcerated. But those are the ways you kind of characterize lesions in Barrett's esophagus and how you take biopsies. And so surveillance with Barrett's with indeterminate, that's the other thing, is that sometimes your pathologist says, I can't figure out if this is dysplasia or not. Sometimes it's just simply inflammation. And of course, reflux acid causes inflammation. So it's hard to distinguish, is it dysplasia or is this inflammation? And so the suggestion now is that, well, it's hard to know exactly to sort this out. So ensure that they're on acid suppression and taking their acid suppression correctly and do an annual endoscopy. And at some point, they're going to declare themselves, meaning that either they'll actually have loga dysplasia or that indefinite goes away now that you've controlled the acid, right? The other part about loga dysplasia and the difference between 2011 and now is we understand that loga dysplasia, a little bit is the biggest difference is it reactive changes due to reflux or is it truly dysplasia? And so the suggestion now is really if you see by endoscopic means loga dysplasia, then put the patient on a high dose PPI for 6 months. And with that, you should actually be able to control and get rid of all the acid-related inflammation. And then you go back down there, and really, if it was any kind of inflammatory changes or reactive changes that made it look like dysplasia, that'll go away, and you'll actually have no evidence of dysplasia. But if you can confirm loga dysplasia after this intensive therapy to really get rid of the inflammation, that is low grade. And we do now suggest endoscopic eradication therapy. Now we put a caveat on there as like, after shared decision making, your patient decides not to do this, then we can have surveillance at 6-month intervals. But generally, when we're talking about now patients who are undergoing surveillance, they've usually agreed as like, hey, this is the trigger now to get therapy. Whereas before it was high grade, now we say any kind of dysplasia. We also, this is the point of contention, it says endoscopic treatment should be performed by high volume endoscopists. This is tough. I was at these in these meetings, like, what do you mean? What do you mean high volume? What is a high volume? And then they were saying, oh, we should be to like a specialized center. It's like, what do you mean a center special? You get a certificate or something. So I have a little bit of problem, and I'm got my name on this thing, right? But the bottom line is that this is these types of therapies isn't just going to RFA. I think that's the problem we have. It's too easy to do radiofrequency ablation. What you really got to do, and the reason these things, endoscopic therapy fails is people don't look at the visible lesions and they aren't doing EMR or ESD to take it out. And you cannot do, RFA does not work when you have a raised thing or an ulcerated thing. You got to remove those visible lesions using EMR or ESD. And then when it's flat, then actually the RFA or cryo works pretty well. And that's the whole point about high volume endoscopies. You got to do this a lot to be able to visualize these lesions and be able to take them off appropriately. All right. Okay. Some adjunctive things in surveillance. Now, we actually address WATS. Now, WATS is during endoscopy. It's actually a very stiff brush. And what it does, it just doesn't get cells. It just gets clumps of cells. It's almost like it's more than cytology. It's clumps of cells, not really a biopsy. But then it actually does some image analysis and some biomarkers. And so the bottom line here is it actually does pick up more neoplasia, meaning low-grade, high-grade, and cancers than if you did random biopsies. But the problem here is in these kinds of studies using either WATS, or I'll show you two more things, is that in general, the studies are done in high enriched populations. In other words, we already know that this is a population that either has Barrett's with low grade or Barrett's with high grade or cancer, right? And when you have a population like that, that's actually not the population we're using it in, because what we're doing is the general population where we don't know they have dysplasia. If you look at a enriched population, you get kind of obvious cancer, obvious dysplasia, where you don't really need these markers. So the markers always do better in those kinds of studies where you have an enriched population. And so that always gives us a little pause. And so because of the fact that even though these data look pretty good, because of the fact they aren't doing these studies in the population where it's intended, we actually at this point make no recommendation for or against the use of WATS 3D as adjunctive sampling tech to structured biopsies. The knowledge gap is this: if we actually did studies in a screening, or excuse me, a surveillance population in which we didn't know until we actually did the biopsies and things, whether they had low grade or high grade, and followed them for, let's say, 5 years, then I think we would actually have the knowledge to actually make a recommendation, right? The same kind of thing for P53. P53, it's KRAS, P53, it's one of these, it's a part of the cascade that's related to progression from high grade to cancer. P53 is a marker that's in many of these commercial assays. But why not just just do P53 as opposed to doing all these other very expensive things? So this is actually more of a, not just a meta-analysis, but the way we kind of look things at, on the guideline panel. We look at the sensitivity, look at the specificity, and we apply it to a population with a certain proportion of, let's say, dysplasia or cancer, and figure out, well, how many true positives you have, how many false positives, what kind of burden will be. And these are the kind of tables that are put out. The only thing you really want to know here is that, gosh, it's the evidence is going to be, it says very low, and there's a lot of potential sources of bias. And so for the same reason, in patients diagnosed with any kind of Barrett's, either that with non-dysplasia, indeterminate, low grade, we could not make a recommendation for or against the use of P53 alone as an adjunctive test to histopathology to predict progression to high grade or cancer. Again, if we could find a population that was a surveillance population and follow them long term, probably that would be enough information. TissueCypher, which is again, I don't usually use names, but this is again a commercial name. But in this particular case, it does require endoscopic biopsies, and it looks at both architecture as well as the nuclear morphology and a variety of biomarkers. And it looks at the biomarker not just as a marker in itself, but actually where the marker shows up in the cell, and also looks at how these different markers co-locate, right? And it uses some type of a AI algorithm that's proprietary to be able to assess this and give you a low, intermediate, or high risk of progression to esophageal cancer or high-grade dysplasia. And the assay is pretty cool stuff. It's P16, you got P53 as we talked about, you got Amicar, you got HER2/neu, you got CD60. They're beautiful pictures, right? This looks really cool. COX2 and HIF1 alpha, and CD4 rho. Okay, And so what we see here is the same kind of thing. You see when you look at, it does differentiate non-dysplastic Barrett's and patients with indefinite as well as low grade. But the biggest thing is trying to predict, not just what you have now, but predicting whether or not you go on to high-grade dysplasia or cancer. And basically, if you look at this, the assumed risk of progression, you can see here, and it does differentiate compared to doing biopsies alone. But the problem again is the same thing, is that the populations that were used in all of these studies really is enriched. So again, in this case, still feel bad, but in patients diagnosed with either non-dysplastic or indeterminate or low-grade dysplasia, we really couldn't figure out a way to say there's a recommendation for or against routine use of this particular assay as an adjunct test. I think we're getting very close. In other words, there actually are studies by the company who are actually looking at more generalized populations in which they would use this test, but we have long-term follow-up that's needed. So I think we're hopefully within a few years, we'll have enough data to be able to make a recommendation. But at this point, I think we're quite limited because the data are promising, but the data aren't sufficient for us to make a recommendation to use these particular tests. This one's obvious, that using a PPI suggests the use of a daily PPI compared to no PPI for prevention of progression to neoplasia in people with Barrett's. I don't think there's actually, strangely enough, there's still a low certainty of evidence. There's actually the aspect trials out there. It's like works, but it didn't work as much as we thought it would, just like a lot of things in medicine, right? But we do suggest using a PPI. When we finally get to treatment, which is the last part, this is actually kind of an old thing. I wanted to show a couple things, again, using the banding cap to be able to visualize things. Once you have MBI, this is a rather obvious. There's actually a lesion here, more about 4 o'clock. And so again, most dysplasia, almost all dysplasia is visible. In this case, actually, a lot of times we actually don't bother doing a submucosal injection. We can just loop it, band it. In this case, there is a little bit of a bleb that's being raised. Using this particular device, you'll actually then put a band ligator, use a regular endoscopic band ligator onto this thing. This is a visible lesion with high-grade dysplasia in a area Barrett's in this particular case. And then after this, using a snare to be able to snare this off. So this is pretty standard endoscopic mucosal resection for an area of dysplasia in Barrett's esophagus. And so in terms of treatment, we still would think it's important that without dysplasia, the risk of cancer or progression to high-grade cancer is still low. So it's a conditional recommendation, but we do just recommend no endoscopic eradication therapy if you just have B without dysplasia. The problem is if you look at these registries, you find out that the majority of people who get eradication therapy in Barrett's actually are people without dysplasia. And it's kind of nuts. It's like, I don't know who's doing this, but the bottom line is that the majority, I'm going to say it again, the majority of people who are getting like a code for therapy for endoscopic eradication therapy are people with Barrett's without dysplasia. But again, we're going to say, look, the risk of cancer in this group without dysplasia is still pretty low. We recommend against that. Low-grade dysplasia, now we're changing. Before in 2011, hey, do more surveillance, figure this out. Now we know that if you confirm it, really understand that you get away from the idea of there's inflammatory changes. You really know that this is true low-grade dysplasia. We now should pull the trigger, endoscopic eradication therapy. And then high-grade dysplasia, just as always, strong recommendation for endoscopic eradication therapy over surveillance. Now, again, these visible neoplastic lesions, there's a debate a bit about using endoscopic mucosal resection or endoscopic submucosal dissection. But actually in T1A, probably actually, if you look at the studies, there actually isn't a whole lot of difference. There does seem to be that then T1Bs, and again, it requires endoscopic ultrasound to differentiate. It is preferred to do endoscopic submucosal dissection over EMR in that particular case. And then once everything's flat, then you go and you can do ablation using RFA or cryotherapy of a flat area after you've ablated or resected all the visible lesions. So my last couple of slides for Barrett's esophagus screening. I think we're excited about this new guideline. We'll talk about prediction tools using age, sex, BMI, smoking, GERD symptoms Turns out race is not as strong a predictor as it used to be, mainly because I think a lot of Westernization is no longer just Westernization. We're starting to get bad habits across the world, and whatever we're doing to kill ourselves is expanding to other countries. So race is not as good a differentiator anymore. But I think the big thing is we're going to be able to screen high-risk individuals who don't have reflux symptoms. I think that's going to be the game changer. And then once you have surveillance, if you don't have dysplasia, if you have a less than a centimeter, don't do surveillance. The risk is really low. A lot of garbage in that thing. Between 1 and 3 centimeters, surveillance every 5 years. 3 centimeters or more, there should be every 3 years. And surveillance, again, the risk stratification using high definition white light endoscopy, targeted biopsies and mucosal abnormalities, Seattle protocol biopsies, and molecular precision medicine can be considered, but again, we're not quite ready to the point where we can recommend that universally. And finally, Barrett's with low grade and high grade. Low grade that's confirmed, endoscopic eradication therapy. If you have visible neoplastic lesions using either EMR or ESD, that's based on the lesion characteristics. And for actual cancer, still T1As consider endoscopic eradication therapy, in particular T1Bs using ESD, and then ablation after you've done EMR, ESD of all the visible lesions, and RFA in this particular instance is preferred. So I think that's it, and hopefully I'm on time. So.
Thank you so much, John, and welcome back, Amanda. We'll take a few questions, and then we will go on to our last state-of-the-art talk. So please kick it off, Dr. Dulé.
John, so in over 20 years now, we knew 20 years ago that we didn't know who to screen or if screening would actually have some positive outcome for patients at risk for Barrett's and esophageal adenocarcinoma. We knew that reflux disease didn't explain it all, at least symptomatic reflux disease. We knew that we were not doing a good job in terms of doing endoscopy in people who were at risk. We had screening methods like transnasal endoscopy that didn't require sedation that could have been widely rolled out, but we never did. We had this much maligned Seattle biopsy protocol and dysplasia as the real marker of risk for neoplastic progression, but everybody said that that'll soon be a thing of the past. We already knew that you could ablate tissue either with thermocoagulation or PDT and change outcomes. And here we are 20-something years later with a lot of research, a lot of time and effort for a still less common cancer. And it seems like we haven't made any ground, and there haven't actually been a ton of changes in our practice other than doing more. And maybe endoscopic therapy is more prevalent, and maybe EMR, ESD is a revelation, but that's for a very small subset of people. And we probably also know that if we did a chart review today, that most people don't follow the Prague classification, and that people are referring patients with Barrett's for ablation therapy when they don't need it. And that probably each year that we get more patients who have Barrett's, we see that the risk of non-dysplastic Barrett's, meaning a good exam, 1 or 2 exams, the risk that that person is ever going to get cancer is vanishingly small. And it seems to me that if we're going to push for screening, which I think we should, using the Klunsman algorithm or whatever you want to use, we really have to be more realistic about saying you don't need to do anything for non-dysplastic Barrett's. Just wondered what you thought about that.
Yeah, Gareth, I think you actually nailed it right there. You know, I think the biggest problem, as I pointed out, is we've screening the wrong people, or rather, we're not screening. I think we need a big funnel, right? We got to screen a lot more people, but then we can't waste all this money and time doing all the surveillance and people who never get cancer. And I bet, I'm not sure how many people have actually seen somebody in surveillance actually develop cancer. It's pretty rare. You know, it's generally you find people that have dysplasia or cancer right when the first time you diagnose Barrett's. So I think I'm agreeing with you. I think the idea is that we got to find a bigger pool of people. And I think, you know, one of the things with AI, you know, you're looking at the electronic record and finding with these tools the highest risk people. Usually it's the metabolic syndrome, right? do any type of screening. Now, I think it's going to be these non-endoscopic methods that'll actually be best, right? It's a triage tool to then get people to get endoscopy. But as opposed to just doing all the surveillance, have these tools quickly decide, are you going to get treatment or not? And then realizing that probably the reason we're doing better is like better acid suppression therapy, which is actually also probably reducing the risk of progression as well. But if we can do that, we actually screen more people, but then rapidly decide who actually gets therapy and then do therapy and then ignore everybody else. Basically, I think that's where we're just doing way too much surveillance in people who aren't going to get cancer. And I think that's what you're getting, and I completely believe it. Yeah.
Please go ahead.
Thank you for your talks. Tuyan Lei from San Diego. I have two questions. The first question is, if you have a patient who has GERD, well-controlled on PPI, with non-dysplastic Barrett's you've been following, they get a fundoplication, their GERD symptoms go away. Is there any utility in continuing a PPI in that scenario?
That's interesting. So, yeah, the question really is, does a fundoplication reduce the risk of progression to cancer in people with Barrett's? And actually, people have looked at that. No, again, most of these are retrospective, not some kind of randomized controlled trial. But they haven't found that fundoplication therapy reduces the risk of cancer. And so we still recommend PPIs. The other part is, if you talked about people with symptoms and people without symptoms, the issue is once you have Barrett's, the question is, does symptoms predict cancer risk? They do, but at the same time, once you have Barrett's, the general idea is that the acid is still what's causing continued inflammation. You got to get rid of acid irrespective of symptoms. So I think in this case, even though if you have Barrett's, you shouldn't be doing fundoplication for Barrett's. You should be fundoplication for reflux symptoms. But if you have Barrett's independent of that, I still believe they belong on a PPI.
The second question is, I think there is early data to suggest that there are some gender differences in terms of risk of progression to cancer in those with Barrett's. If that is the case, how come our surveillance strategy across the board is the same for both genders in terms of surveillance?
That's really good. That's a good pickup on these things. So the question really is, there's sex differences in esophageal cancer. Why aren't there surveillance differences? That actually, the biggest difference is in the I would say not incidence, prevalence of Barrett's. Much higher prevalence of Barrett's in men than in women. And then once you get, I would say, dysplasia, there is no difference in at least the studies I've seen, no difference in progression from dysplasia to cancer. The unknown more is like, what is the risk of, the progression of Barrett's to cancer or to hyperdysplasia, let's say, in between men and women. There's less of a difference. So it seems, again, higher risk in men, but not so much that we would actually change any kind of surveillance guidelines. So it's much more the incidence of Barrett's is higher in men, not so much the progression once you have Barrett's. One caveat, you didn't ask this, is, why is that? It probably has to do, again, with, we talk about fat, and fat is very metabolically active, and it's the central fat as opposed to peripheral fat. And so the interesting that Joel Rubinstein has actually been looking at this and seeing that, actually men who have more gluteofemoral fat are protected against Barrett's. And again, it may not be simply sex, but rather the fact that women have more gluteofemoral fat and men have more central fat. And so, we haven't found any kind of hormonal differences in risk of Barrett's, but it may be the fat distribution that actually is that. So it's kind of fascinating. But the bottom line to your question is that there's a much bigger risk of Barrett's itself between men and women, as opposed to the progression once you have Barrett's. And that's why we don't have a difference in surveillance. I would say that the only caveat is in terms of, there was one abstract I didn't get to, which was, when to stop surveillance. And the risk, just in general for women, if you look long enough, the risk is lower, even though they have Barrett's a long period of time. And so the stopping age may differ based on comorbidity and age between men and women once you talk about that. But right now, we haven't really differentiated in terms of the surveillance. But again, we may if we find greater differences. It's a great question, though.
Yeah, I'm sorry for taking up one more minute. Just to clarify that first question I had, this is a very common scenario that we see in the community, is that they usually come with a hiatal hernia. That's what kind of prompts them to want to have a fundoplication. So they have a fundoplication, they come back. So in your opinion, even in that patient who we are continuing to do surveillance for the Barrett's, they have zero GERD symptoms post-surgery, that there is still benefit for continuing a PPI?
Yes.
Thank you.
Yeah.
Great.
Great. Thank you
Another
both.
Barrett's expert, Raman.
Great. Yeah. Thank you both for being here, John. Great to have you here. So I have one comment and a question kind of to build on what you were saying. So I think one of the things we've learned is that it's really hard to detect dysplasia just visually within a region of Barrett's. And I guess our next talk may address some of the challenges and maybe some future solutions on that. But I think that's where, and obviously there's a lot of information now about this peak and peen, this post-endoscopy esophageal cancer neoplasia. And so what we're seeing is something that combines, I think, the surveillance and the treatment. Is we're seeing a lot of non-dysplastic patients now who are getting molecular tests, whether it be a TSP9 or a TissueCypher or even a P53, which comes back with elevated. And so is there guidance in the guidelines specifically with what to do with those patients who may perhaps be at some elevated risk? Are they more appropriate for treatment? Just wanted to get your thoughts on that group.
Yeah, so I think the summary of the question is really how do these molecular tests alter my management, right? And so the interesting about, let's say, the TSP, there's two parts of this that are intriguing. One is people who don't have dysplasia but come back with a high-risk TSP. And if you look at that, the data, and again, it's limited to people in an enriched population, but it does show that even among non-dysplastic people, if that TSP is positive, your risk of high-grade dysplasia is much higher than even if you have low-grade without this. So it's a conundrum, but right now there's, I would say the guidelines are not going to say, oh yeah, you're going to do endoscopic eradication therapy. My sneaky suspicion is that these molecular changes do indicate the risk more so than pathology. I think our reliance on pathology is limited. I think we're going to get to the point where molecular diagnostics will supersede our belief in pathology. And so right now I can't say it, but I bet in the future, if you actually have a P53 or if you have a TP9 and it shows high risk of progression, even though you don't have dysplasia, but we're going to recommend endoscopic eradication therapy.
Yeah, we're seeing more and more of those types of patients getting referred. So I just want to bring that up. Thanks.
Okay, great. Thank you. Not seeing any more questions. I want to thank you both. Appreciate your dissecting all of those abstracts. And I think you've given us a lot of food for thought. Now we have an opportunity to bring it on home with our last state-of-the-art talk. So thank you again. And I'd like to invite Dr. Samarathena back for our state-of-the-art talk on AI and gastroenterology, which may touch on Barrett's and everything else we've been talking about today. And then you can feel free to come up to the stage afterwards and talk to Jason, and then we'll adjourn for the day. I think it's been action-packed, and we really appreciate you sticking it out for this state-of-the-art talk as well. Thank you.
All right, I really appreciate everyone sticking it out. This is not a commencement address, so you don't have to boo. So we're going to talk about AI and GI. These are my disclosures. One that I should have included in there is I did have experience in starting an AI computer vision company called DocBot, and I'll show some slides related to the work with DocBot. So why should endoscopists care about artificial intelligence? I don't think there's very many people in the room that would recognize this. Maybe one. And he just put up his hand and he acknowledged it. So, but I think the first time that we stuck a camera into a patient, that was an amazing moment for our field. And the ability for us to take care of that patient was really enhanced so much because of our ability to see inside. And then the scopes evolved to the fibroscope, and then the video scopes, and now we're getting into high fidelity scopes, and really now we have these like beautiful high definition scopes. And the clinical utility of taking care of that patient as the imaging got better and better and better kind of flattens out. And so now this is an image taken of a dysplastic nodule in Barrett's. And this was from a scope that was made 5 years ago. And it really gives a beautiful depiction of this nodule. We're using something called near focus. And I really do believe endoscopy has reached the limits of human visual capacity. And so seeing more pixels may not actually improve the clinical diagnosis that we make. And what's next for elevating the care of our patients with endoscopy? Well, I think it's probably going to be artificial intelligence. So why is artificial intelligence useful or relevant for gastroenterology now? Well, GI doctors, we spend a lot of time in front of this TV, more so than any other specialty in medicine. And the high definition endoscopy has led to really high fidelity and detail. Plus, we have these large classified data sets. We have more video data than we've ever had before. And thanks to the video game industry, we have these very high and compact, high performance graphics processing units. And so, when you put that all together, we can say endoscopy is really nothing more than a silent stream of still images shot by a fast clicking camera, captured by a highly trained camera person. And so what's nice about all those images is you can kind of interpret and predict things off each of those images, and now in even real time. So I think about endoscopy as a composite of three things. One, understanding the biological, sociodemographic, and clinical factors surrounding the case. Two, the technical expertise and manipulation of the endoscope and the adjunctive instruments. And three, real-time interpretation of the visual matter displayed on the screen. And I think, GI fellowships do a great job of addressing 1 and 2. But I think the thing we struggle with the most actually is this real-time interpretation. And I think your skill set for this is really dependent on who you learn endoscopy from and your case volume of specific pathologies during that endoscopic training. And when I think about endoscopy during a screening exam, there's really two tasks. There's red flagging, where you're detecting areas of suspicion for neoplasia. And we do this during colonoscopy. We do this during a Barrett surveillance exam. We're doing this, when we do an EGD. And task two is characterization. So areas of suspicion are interrogated and a mental calculation of neoplasia probability is made. And, it takes a few cases of looking at Barrett's and understanding what dysplasia and how it can present to know that what we're seeing there is an early esophageal cancer. And, it takes experience to know that, what we're seeing in this picture is also esophageal cancer, different type, but it's not just schmutz in the proximal esophagus. And I don't know how many colonoscopies we did, and we passed over these mucus caps for years and years and years, not realizing there was a polyp underneath there. And so this is all a lack of experience and understanding and real-time interpretation. And the question is, can you use an AI algorithm to help you with these tasks? And yeah, you can. Task one is red flagging, and that's called computer-assisted detection, or CAD-E. And task two is called computer-assisted diagnosis, or CAD-X. And these are terms that we're hearing more and more. Because within a group of endoscopists, there's going to be a variability in skill set, whatever that particular task is. And there's going to be someone that's probably an expert. And there's going to be people that are lower performers. And I guess the question is, if you can train an algorithm to be as good as an expert, and then you can apply that algorithm during endoscopy for the whole group, could we sort of level up everyone's skill set? And that could potentially lead to a better clinical outcome. I think there's examples in our practice where we can do that. So there's many focus areas in GI for artificial intelligence. And I'm going to touch on a few of these and one more, cologenetic AI at the end. Colonoscopy. This is the original target for AI. And we know that detection and removal of polyps during colonoscopy is the most effective way to decrease the incidence of mortality of colon cancer. And missed polyps are a known issue with colonoscopy. And, getting an ADR and a PDR and, improving your ADR even, 1% can make a tremendous impact in the incidence of reducing colorectal cancer. So, but within colonoscopy, there's different targets for AI: polyp detection, optical histopathology, that's called CADX, performance supervision, mucosal surface area mapping, and auto documentation. So let's talk about polyp detection. So these are, what I call spotters. And so this is like, a bunch of people in the room looking at the screen at the same time saying, hey, there's a polyp over there. And then we kind of draw a box on that. And, these are additional eyes. And using deep learning convolutional neural networks based algorithms trained on large data sets of labeled polyp images, you can create these algorithms. Pretty easy to create, actually. And there's a number of randomized controlled trials. The conventional ones are AI on versus AI off. So the AI off group is just a conventional colonoscopy group, and AI on is, using the AI, and these are different patients, different groups, and then you look and see. And then there's tandem trials where you have AI on versus AI off first, and that's randomized. And so we did a meta-analysis looking at kind of both types of studies, the non-tandem and the tandem. And if you look at, there's a really tremendous improvement, 58% increased adenoma detection rate in the non-tandem studies, 36% in the tandem studies. And with a tandem study, you can also calculate something called a miss rate. And there's a 33% lower adenoma miss rate with tandem colonoscopy studies. So there's great RCT data, extremely strong. It increases your ADR, probably more impactful than any device or technique in colonoscopy to date based on the randomized trials. There's multiple FDA-approved systems now, so no-brainer for widespread adoption, right? Well, what's interesting is there's been a number of negative studies. So this was one at Stanford. It was a retrospective pragmatic trial with historical and concurrent control subjects. So basically, a CADI device was installed for 3-month evaluation at one endo unit, and then those 5 other endo units served as control sites. And they looked at all sorts of polyp and quality metrics. And they actually divided the endoscopists into the bottom tertile of performers, the middle tertile of performers, and the top tertile of performers to see if there was any differences in improvement. And there was 24 endoscopists, over 1,000 colonoscopies, and ADR and adenomas per colonoscopy actually did not improve with AI. But that was just one study. So, but here's another one. So this is a retrospective analysis at MD Anderson. And in this case, the decision to activate the CADI system was at the discretion of the endoscopist. So the person that is turning it on really wanted to use it, really decided that they want to use it to help them improve polyp detection. And in this study, interestingly, so about half of the people activated the system, but compared with historical controls, there was no statistically significant difference in adenomas detected per colonoscopy. So that's kind of weird. This is, definitely going against what the RCT data was telling us. But here's a bigger study. Now we're talking about over 4,000 colonoscopies performed by 30 endoscopists. And in this study, there was a statistically significant difference, except it was actually making them statistically significantly worse. So they had a significant decrease in PDR, ADR, advanced adenomas, and they looked at high ADR people and low ADR people, and this was actually making people worse. But that was, again, retrospective stuff. But now there's a randomized control trial, very large one, 769 patients. And even in this one, different system than what was covered in the others, no significant difference in APC. adenoma detection rate was similar in the AI group versus non-AI group. So this is kind of weird. Okay. So what's going on? You know, we've got these great studies with RCTs, and now we're seeing kind of this poor real world performance. So potential reasons, and I'm not saying I agree with these reasons, but these are potential reasons. Ceiling effect for polyp detection among high performing endoscopists. Maybe you're so good, you're just not going to get any better. But we saw some, you know, lower tertile performers not get better also. Something called the unconscious degradation. So in the quality of mucosal exposure. So you kind of get this false sense of comfort that the AI is on. So it can kind of make you not as attentive to looking behind folds. Alarm fatigue. This is one that people always talk about. Too many false positives, too many boxes on the screen. And because of that, I was just like, forget it. I'm just going to forget those boxes. I'm not going to pause and interrogate, you know, where that box pointed something out. And then another one, which I lean to a little bit more, false positive intrusions, distracting the endoscopist away from doing their usual exam. And I think all of us have sort of a rhythm when we do colonoscopy and our withdrawal phase of colonoscopy. And now if somebody's tapping on your shoulder and you're looking behind yourself, and then you're kind of getting back into the moment, and then, you know, 30 seconds later, somebody's tapping on your shoulder again and, you know, distracting you. I think that could play a role, but these are potential reasons. In real world practice, you know, whether it's CADI or CADX, implementation without attention to the endoscopist's inclination and behavior, it's not going to lead to good results. So this is something called a physician AI hybrid. So better understanding of physician attitude and the subtle factors at the physician AI interface could yield a more optimal result. I'm going to give you a quick example. So talking about self-driving cars, and I got one recently, and it's a Tesla, and there's kind of 5 different modes of the AI to, you know, drive the car, different kind of personalities. And I think, you know, now I kind of understand, you know, which mode to pick for different scenarios as I'm driving or I'm kind of cruising. And so this is something I thought about, like, I'm not really driving any better, but I'm able to use my AI a little bit better. And I think this is sort of a little bit hitting on the physician AI interface. Okay, optical histopathology, CADX. So about 10 years ago, the ASGE came up with something called the PIVI criteria on optical diagnosis. So this was if you had an imaging or optical technology that could predict the histology of polyps correctly, well enough that there was a 90% or greater negative predictive value of adenomatous histology and a 90% or greater agreement in assignment of post-polypectomy surveillance intervals, you could do something called resect and discard, and you could also do something called diagnose and leave behind. And so a lot of technologies have tried to do this. We've tried to teach people NBI and virtual chromoendoscopy and endomicroscopy and things like that. But what about AI? So this is a study from Europe, Italy, and a lot of work on AI is done by this group. This is a study looking at AI potentially allowing leaving in situ colorectal polyps. So this is 544 polyps were removed in 162 patients. About half of them were less than 5 millimeter rectosigmoid. CADX diagnosis was feasible in almost all of them. 82% of lesions in the rest of the colon were also amenable for a leave-in situ strategy. And 82% of those lesions were amenable for a leave-in situ strategy. 39% of lesions, even outside the rectosigmoid, were amenable to a resect and discard strategy. But looking at this algorithm in this patient population, there was a 95.9% agreement between CADX and histology-proven surveillance intervals. So this algorithm in this patient population actually achieved the PIVI thresholds. So that's encouraging. I think resect and discard in the US is going to be a little bit challenging. Optical biopsy is not really implemented now due to lack of motivation, maybe low confidence assessments of looking at a polyps and likely medical legal issues. But could the CADX AI kind of overcome that motivation or low confidence issue? Because if all of a sudden your predictions became high confidence, would you be okay taking out that polyp and putting in the trash, or looking at that polyp in the rectosigmoid and saying, okay, that actually is a hyperplastic polyp, I'm going to leave that alone. So I think we need more real world studies. We need more AI studies to be done outside of this Italian group. Eventually it's going to depend on the physician and how confident they feel. Performance supervision is something that I have an interest in. Could we use AI to aid the endoscopist perform colonoscopy with higher quality? Withdrawal time is a good target for AI algorithm development, an important quality indicator in colonoscopy, and a rapid withdrawal would, reduce endoscopic stability, increase the risk of inadequate visualization of the mucosa and missing polyps. So this is a AI called EndoAngel. Does a lot of different things. But one thing it can do is essentially a speedometer on the way out. So it can calculate similarity between consecutive frames to monitor real-time withdrawal speed on a virtual dashboard. And when you're going too fast, it'll just chime and let you know you're going too fast. So in this randomized trial with no CAD-E, no polyp detector, nothing else except just a speedometer, withdrawal times were higher, 6.38 minutes versus 4.76, and adenoma detection rate was higher and polyp detection rate was higher. So, and if you combine multiple AI modalities with an automated procedural timer, an audio prompt for rapid withdrawal speed, an audio prompt for a poor Boston bowel prep score in a certain segment, as well as a CAD-E algorithm for detecting polyps, if you put all that together, it looks like withdrawal time is better or longer, I should say, and the bowel prep scores were better in this randomized trial, and there was definitely an improved ADR, including flat and sessile adenomas. So, I think the nice thing about performance supervision is this algorithm, like the speedometer, doesn't really require any FDA approval, doesn't require regulatory pathway. It's but it's something again that could be put in there to help us just perform endoscopy better. Mucosal surface area mapping. So one of the things that we all know is if you don't expose the mucosa, you could miss a polyp. And so here is some work by Sean Tucker, who looked at, and you can see here that it's TL, TR, BL, BR. So top left, top right, bottom left, bottom right. And it's sort of a dark block. And when you look more closely at say, that particular quadrant, that block turns to a lighter block. And then you can, so it's sort of kind of pushing you to, look a little bit better, look behind those folds, look in the corner of that part of the colon. So sort of real-time feedback, kind of to push the endoscopist to inspect more carefully, and potentially could provide a quantification of the mucosal exam. And the last thing to talk about is auto documentation. So, and I think this is what people really, would really like AI to do, is kind of watch you do the colonoscopy, take notes, report, and this has the potential to avoid errors, improve efficiency, minimize click screen time. And so, so with the company DocBot, we try to, actually do this. So to do this, you actually need to do a bunch of different algorithms. So you need a polyp detector. We did that. You needed something that does optical pathology, so you can get point of care assessment of the polyp to calculate adenoma detection rate. We need landmark recognition. We need an algorithm that could quantify prep. We need one that could recognize all the tools that we use for remove polyps. And then we needed an algorithm to assess polyp size and morphology. And so this is an old video, but AI marks the in and out time. It looks at the quality of the prep. It sees when you get to the cecum, and then it does a polyp detection. And then at the same time, it's giving you a prediction of, what the polyp is. It's detecting that you now have a tool. It's figuring out what kind of tool that is and how that particular polyp was resected. If you've got multiple polyps, the algorithm actually has to keep track of all of those polyps. And but in this case, and if you were using any kind of device, it can, like a endocuff or cap, it would tell you that. So that, all that information, would then basically feed into the report. So, when you think about colonoscopy, there's a few different targets here for AI to be used. And I think, this is coming. So AI has assisted you in performing a detailed exam. It's got the polyp spotter technology. You've got the withdrawal speedometer, potentially, maybe a mucosal surface mapping tool. It's recorded all the quality metrics, including cecal intubation, withdrawal time, prep quality, based on the optical path. It can give you, it can feed in that data into the ADR calculation. AI completes colonoscopy report. It auto labels images, including the cecum. It gives you the diagnostic procedure codes and gives you guidelines, guides your surveillance recommendations. Simply review, edit, and sign. I think that would be a great use of AI, and I think we're going to get there. So my next topic is Barrett's esophagus, and we heard an amazing talk by Dr. Inadomi about, really how the guidelines get crafted. And then Dr. Muthuswamy asked an excellent question about, well, are we that good at detecting dysplasia in Barrett's? And I think the answer to that question, based on now a lot of data, is I don't think we're there yet. And so, so this is an algorithm that that I created a few years back to detect dysplasia within Barrett's. And this is one of the first continuous real-time AI-assisted Barrett's algorithms. And so for the sake of time, I didn't actually play the video without the boxes on there, but I play this video for a lot of people and they're like, I don't really see the dysplasia. This is all dysplasia that you're seeing here. And it's, but this is pattern recognition. And, in our 3-year fellowship at UCI, there isn't a whole lot of time that the fellows get with, Barrett's dysplasia, training. And we're a fairly high, volume center, and our 3rd-year fellows actually work with all of us for about 2 or 3 months. So, but it's just one of those things that you don't see very often. And so in here, you can see, that the AI is clearly, concerned about this area, but really not so much up here. And, it's correct. And so, and then even, as we're pulling back, the AI is saying, hey, keep looking down there on that right side. So I think this would be, a very useful AI tool. But I want to show you kind of where things are kind of going. So this is courtesy of Professor Messman in Germany. And now this is like, kind of like blows the socks off the one that I did, because this is now a really, really nice, GUI with, complex polygons being drawn right on the tissue. It's almost like a gel cap that you can see. And it's like, really highlighting that area of dysplasia. And so, these sorts of things are, that is beautiful because it's not that intrusive. And, it just looks, really, really slick. But that's clearly dysplasia. And Dr. Muthuswamy will back me up on that. So this, again, is another kind of algorithm. And as you can see here on the left, this is a motion meter. Okay. So one of the things, again, that I think is helpful is, controlling the motion of the scope. Dr. Inadomi shared that, we should use a cap. This is one of the ways that we can do a really high quality exam. And the reason the cap works so well is it really does reduce motion. And so, So again, a motion meter on the endoscope doesn't require any regulatory effort. It was a very simple algorithm to build. And I think this is going to slow us down, and it's going to make us better endoscopists. And so, you know, if you think about the algorithms out there, you know, if you had an algorithm told you to put on a cap, told you to slow down, told you to take more than 1 minute, you know, per 1 centimeter segment of your Barrett's exam, and then kept the motion low, I mean, that I'm sure would improve us, you know, dramatically towards what we are considering a high quality exam. So this endoscopic quality improvement thing, you know, this is an older study, but even with EGDs, you know, there's a lot of, I've actually modified the way that I've done EGDs, and now I'm realizing that, you know, there's definitely blind spots during an EGD. And, you know, if you had an AI that is watching you do the EGD and it's telling you, okay, you need to look over here, you need to look over here. Okay, I'm not really happy with that view, do it again. Okay, insufflate better, you know, get rid of the bubbles, you know, these sorts of things. But this study was essentially showing that when AI was utilized during an EGD exam in actually a sedated EGD, a oral endoscopy with an ultra slim scope, and an unsedated EGD, it helped decrease the blind spot rate in all groups. Capsule endoscopy, everyone's favorite thing to do. This is as exciting as it gets for capsule. Fortunately, there's help coming. So this was a huge study, over 113 million images on almost 7,000 patients at 77 medical centers. And so images were categorized as normal, inflammation, ulcer, polyp, you know, different findings. And the model was further validated in another 5,000 patients. And the sensitivity per case was extremely high, better than the manual analyzers. And the sensitivity per lesion was extremely high as well. And the reading time went from over an hour to about 6 minutes. So I think this is one really, really great potential application of AI, and hopefully we'll be seeing this soon. Rajiv showed a study, a multi-center study, looking at AI-assisted cholangioscopy, and this is the technology that he was talking about in that DDW abstract. So it's essentially, you know, guiding, you know, where to take this biopsy to hopefully improve the yield of finding cholangiocarcinoma. Carlos Robles Merdranda is doing a lot of great work with endoscopic ultrasound and artificial intelligence. And I think, you know, EOS is one of those things that it's difficult to learn, and it's difficult to find places to learn it. AI training is sort of a, you know, we have these great fellowships in the United States and a lot of people come, but it's a difficult thing to learn. And I think using AI as a tool to understand what you're seeing is really going to be helpful. So my last topic is what's called generative artificial intelligence. And I think a lot of people know a lot about this. There's a lot of large language models that we're using as consumers, as in the public, and people are finding creative ways to use this to help them in their jobs, and, you know, write reference letters and different things, emails, you know, sound smart. There's also something called retrieval augmented generation, or RAG, and this is where you can take an LLM, but you can optimize the output. So it references sort of a knowledge base that you're sort of feeding to it. And that is really kind of the start of what we call agentic AI. And so we worked with a company, and this was a few years ago, and the company did this, what's called their, the company's called Aidify, and they did something called a care aid. And so a patient of mine could just log into a website and say, hey, I've got questions about my colonoscopy prep. And, you know, it would spit out some answers. This was a few years ago. Now the latest iteration is, or the next iteration was a phone number. So you could call that phone number and talk to an agent, an AI agent, and ask questions, and it would kind of deliver pretty good information. You know, our patients were pretty happy. They knew it was a part of a kind of a research thing, and they were pretty impressed with the quality of the responses and the care that they were getting. And but the latest is actually proactive calls. So now the agent can actually call the patient. And so this could be a reminder call. This could be, did you stop your GLP-1? Did you stop your Plavix? And the latest is reaching out to patients to backfill a spot that just got canceled. And so I think as a lot of us who are administrators, the revenue and the margins with an endoscopy, really wherever you are, is not going up. You know, they're sort of going down. Operating costs are going up as staff are becoming more and more expensive, and there's sort of more and more things that kind of eat into that. And I think using AI to help with some of the back office work may actually be a good solution going forward. So this is, actually, let me just.
Hi there. I'm UC Irvine's colonoscopy care aide, here to answer any questions you have about colonoscopy procedures at UC Irvine. How can I help you today?
Yeah, my procedure is in a few days, and I actually have the Go Lightly prepped, but I just lost the instructions. Can you give me the instructions for Go Lightly?
Of course I can help you with that. Here are the instructions for your Go Lightly. Go Lightly bowel preparation. Key instructions. Do not eat solid food the entire day before your colonoscopy. Buy your bowel preparation at least 5 days before your colonoscopy. Do not mix the solution until the day before your colonoscopy. A responsible
I'm sorry. My aunt is having the procedure, and she actually only speaks Vietnamese. Can you explain it to her in Vietnamese?
Chắc chắn rồi, tôi sẽ giúp bà của bạn hiểu rõ các hướng dẫn chuẩn bị cho cuộc nối soi đại tràng bằng tiếng Việt. Hướng dẫn chuẩn bị cho thuốc Go Lightly.
You can jump back to English, actually. How long does the procedure typically take? You know, it's my aunt's first colonoscopy.
The colonoscopy procedure itself typically takes between 30 to 60 minutes. This includes the time for the actual examination of the colon. In addition to the procedure time, you should plan for about 3 to 4 hours at the endoscopy center. This includes time for check-in, preparation.
Now, can you jump to Spanish? Because my uncle is going to be driving my aunt to the procedure. My uncle only speaks Spanish, so.
So you got to get the idea. So I think that was a clip from over a year ago, and now it's even quicker, sharper. You know, it's more human-like, honestly. So in conclusion, high-definition endoscopy has reached the limits of human visual capacity. And I think real-time interpretation of the visual matter is where endoscopists needs help. I think computer vision algorithms fill this need well. Progress in AI computer vision development is really exploding. Neoplasia detection and characterization, potentially endoscopic quality improvement, and live prospective real-time studies have started. Integrating multiple algorithms on a single platform will be necessary. And I think AI will serve as the virtual expert in the room, guiding us through the exam and assisting us with interpreting studies. But we've learned from colonoscopy, the benefit of AI is not automatic. And as with any device, the endoscopist needs to be trained. And this is, I think, the physician AI hybrid. And I think generative AI will continue to improve and aid us with patient communication, education, and potentially back office staff tasks. Thanks very much.